This is Sophie. She just turned 45. A wife, a mother, a daughter, a friend, a teacher. She is many things to many people. She was 17 when she first met her partner. 28 years and 3 children later, they still look at each other the same way as the day they met. Every summer, they go to the countryside cottage of Sophie's parents in a hope of a quiet escape from their busy city lives. And maybe it would be if it weren't for all the cousins and siblings, and their families of course, all trying to escape the city buzz. Many of Sophie's friends, even from high school and university days, have been visiting for years. It is probably her unconditional love for people and passion for art that brings people together. She always says, "I am lucky because my passion is what I do." Over 20 years as an art teacher, she has inspired and touched the lives of many. It's only recently Sophie has been feeling like something isn't quite right. Today, Sophie was diagnosed with breast cancer. Breast cancer doesn't only affect those who are diagnosed with it. It has an impact on families, communities, and our society. Every 20 seconds, someone is told they have breast cancer. So Sophie may be just like someone you know. One diagnosis, hundreds of lives impacted. Treating breast cancer early may provide the best chance of cure. That is why we are committed to bringing every single patient with breast cancer closer to cure. And it is this commitment that drives us every single day.
Torrent Pharma, one of India's leading integrated pharma companies. Torrent Research Center works zealously in the quest to discover better therapeutic solutions. Have to their credit novel drugs that have been developed for the first time in the world for various therapeutic segments. Currently, we operate in over 70 countries across 6 continents. Most respected pharma company.
We have seen that HMOs are components unique to human milk, which are surprisingly very abundant, but devoid of any nutritive function, leading us to wonder what they actually do. Revealing that HMOs play a key role in supporting the immature immune system of infants, thus protecting them at a time of great vulnerability when their defense system is not yet fully functioning. HMOs also help to educate the developing immune system in order to make it fully functional. So, how do HMOs do that? HMOs help the immune defenses in four major ways. First, they help establish a protective commensal gut microbiota. Second, they block pathogens from doing harm. Third, they strengthen the gut barrier function. And fourth, they help educate the developing immune system. The more you learn about HMOs, the more you will understand what makes them so specific and beneficial.
Deflon 500, the world's first oral drug with international guideline recognition for hemorrhoidal disease and chronic venous disease. Deflon 500 is the ideal partner for your hemorrhoidectomy. With a dose of 2 TDS for 4 days, 2 BD for 3 days, you will get an inflammation-free and bloodless access to the site of surgery. For varicose patients with a dose of 2 tablets daily for 3 months, you can provide rapid relief from symptoms such as leg pain, night cramps, and sensation of heaviness. In type 2 diabetic patients, Diamacron MR60 achieves potent HbA1c control up to 6.5% without compromising hyposafety. Cavasil provides a stronger BP reduction compared to other RAS inhibitors.
Our people, our partners, our technology, the foundation to world-class healthcare. MR Pharma, service for health.
Good morning, ladies and gentlemen. Welcome to the second and final day of the 80th Annual Academic Sessions of the Gall Medical Association. Thank you all for joining us on this virtual platform, and please stay connected for a prolific academic experience. Kickstarting the day, we have the second free paper session, and I cordially invite the co-chairpersons, Professor Mahinda Kommalage, Professor in Physiology, Faculty of Medicine, University of Ruhuna, and Dr. Lanka Dasanayaka, Senior Lecturer in Obstetrics and Gynecology, Faculty of Medicine, University of Ruhuna, to the head table.
Good morning. Welcome to the previous two. Before we start the session, I would like to make a few announcements. We have 6 oral presentations and 8 minutes for the presentation and 2 minutes for the discussion. I would like to good morning. So welcome for the free paper session 2. And before we start the session, we would like to announce few announcement about the sessions today. We have 8 oral presentation, and each presentation get 8 minutes for the presentation and 2 minutes for discussion. And I would like to inform the audience who join online. If you join as an attendee, please direct your questions Q&A box in your Zoom platform. And if you join as a panelist, please raise your hand, and then you will get chance to talk. We'll move to the first presentation. First presentation today. Topic is comparison of outcome of management in dengue hemorrhagic fever using minimal invasion and the standard management protocol in pediatric units of teaching hospital Karapitiya. Paper authored by Kaushalya PGC, Leonarach ND, Vijay Singh CG, Lankapriya RGS, Vimalasena TBGH. And paper is presented by Kaushalya PGC. Over to you.
Ladies and gentlemen, I'm Kaushalya Pusaguda, Registrar in Pediatrics from Teaching Hospital Karapitiya. Thank you very much for giving us an opportunity to share our study, a comparison of outcomes of management of dengue hemorrhagic fever using minimal intervention and the standard management protocol in pediatric units of a Sri Lankan tertiary care facility. Dengue infection is a significant health concern. Most of the admissions are due to dengue fever or dengue hemorrhagic fever. Management of dengue hemorrhagic fever has changed over the past few years. At present, dengue hemorrhagic fever is managed following a standard protocol according to the national guidelines laid down by the Ministry of Health. According to the standard protocol recommended by the Ministry of Health, all the patients who enter into critical phase should be given intravenous fluids. Even the patients who can tolerate oral fluids should be given intravenous fluid at a minimum rate to keep vein open. Urine output should be measured hourly. To make it easy, urethral catheterization should be done. Regular hematocrit measurements is also supposed to be done 4 to 6 hourly. During the last epidemic of dengue, a deviation from standard protocol was observed in our wards due to various reasons. So, some patients were managed with minimal interventions. Those minimal interventions included total oral fluids instead of intravenous fluids, measurement of urine output 2 to 3 hourly without urethral catheterization, hematocrit measurement 12 hourly with full blood counts instead of 4 hourly hematocrit measurements. There aren't much research evidence in the literature to see the difference or the comparison between IV and oral fluids. In a study done in Taiwan had shown oral hydration may be as effective as intravenous fluids for adults with non-shock dengue hemorrhagic fever. There, they have concluded that patients treated with intravenous fluids were prone to develop pleural effusion and pulmonary edema. There are no similar studies conducted in pediatric patients. So, the objective of our study is to compare the outcomes of minimal intervention and the standard protocol during the critical phase in managing pediatric patients with dengue hemorrhagic fever admitted to Teaching Hospital Karapitiya. It was a comparative cross-sectional study conducted retrospectively using secondary data available in the clinical records of pediatric patients with dengue hemorrhagic fever. The critical phase was diagnosed by doing 2 ultrasound scans on those patients. So, we included pediatric dengue hemorrhagic fever patients admitted to Teaching Hospital Karapitiya during the year of 2019 who have undergone bedside or departmental ultrasound scan on a minimum of 2 occasions to objectively assess progressive leaking. Patients with incomplete clinical records and those who were managed with minimal interventions initially but later changed to standard protocol were excluded from our study. The study sample was categorized into 2 groups based on the type of management received. Minimal intervention group included patients who were managed with minimal interventions since the time of the diagnosis of critical phase. Patients who were managed according to the standard management guidelines issued by Ministry of Health since the diagnosis of critical phase were included in the standard protocol group. Relevant data were extracted from bedhead tickets and dengue monitoring charts using a data extraction sheet. Data analysis was done using SPSS statistical software. Moving on to the results, the study sample consists of 151 subjects. Out of those, 53 patients were managed with minimal interventions initially. 98 patients had been managed under the standard protocol. Out of those 53 patients, 28 patients had been changed over from the minimal intervention to standard protocol due to various reasons. Therefore, at the end, minimal intervention group consists of 25 patients and standard protocol group consists of 98 patients. Age, sex, duration of fever on admission, and hematological parameters including white cell count, hematocrit, and platelet counts on admissions were compared between 2 groups. There was no statistical significance between 2 groups. During the critical phase, again, some hematological and biochemical parameters were compared. So, there was no significant difference in the lowest platelet count during the critical phase in 2 groups. However, the highest AST, ALT, and hematocrit were different in those 2 groups, and those were statistically significant. When comparing the complications between these 2 groups, standard protocol group had more infections. 16 patients of standard protocol group had some kind of infection. None of the patients in minimal intervention group developed infection. Bilateral pleural effusion again present in 32 patients in standard protocol group, and only 1 patient was seen in minimal intervention group. Fluid overload with dyspnea was demonstrated in 25 patients in standard protocol group, but none of the patients in minimal intervention group developed fluid overload. Therefore, infections and fluid overload were common in standard protocol group, and it was statistically significant. The final outcome of those patients were compared. All the patients recovered with or without complications. There were no fatalities among our study group. About 5 patients in standard protocol group needed ICU care, but none of the patients in minimal intervention group needed ICU care. 61 patients had complications in standard protocol, and only 1 patient in minimal intervention group. That difference was also statistically significant. The fluid quota is the amount of fluid that patient is given during the critical phase. In standard protocol group, average of 91% of fluid quota had been given. In contrast, minimal intervention group needed average of 80% of fluid quota. That difference is also statistically significant. In 2 groups, there is no difference in the duration of hospital stay and final outcome. We would like to conclude that minimal interventions during the critical phase of the dengue hemorrhagic fever minimizes the risk of infection and fluid overload in children. So we believe that using minimal interventions during the critical phase would reduces the workload of the healthcare staff, increase the patient satisfaction by reducing the pain and discomfort, and it will reduce healthcare cost. But further prospective studies are needed to make recommendations as there were limitations. Our study was a single center experience and it was limited by sample size. And it was a retrospective study, so clinical parameters which gives a clearer picture of patient were not analyzed in depth. Therefore, further large-scale prospective clinical trials are needed to determine the indications for minimal interventions. We would like to acknowledge the Director, Teaching Hospital Karapitiya, consultant pediatricians, and staff of the record room of Teaching Hospital Karapitiya for their immense support. Thank you.
Thank you, Kaushalya. Now time is to entertain with the questions. So there are no questions in the Q&A box now. So the panelists, you can ask questions. There are two panelists waiting for asking question. Dr. Ruwani, Professor Ruwani Hewawasam, please you to ask questions. Professor Ruwani.
Yes, thank you for your presentation, Dr. Kaushalya. Can you please tell me the age group of your participants?
Age group, pediatric age group, up to 14 years, madam.
So
patients admitted to pediatric wards.
No, in both groups, were they in the same age group?
We couldn't, it was a retrospective study, we couldn't match the age, but after collecting the data, we have compared the age group. There was no significant difference, madam.
Okay, and then you mentioned that 28 out of this 53 moved to the standard protocol.
Yes, madam.
So what was the reason for that? You didn't mention about that in your presentation. That is like a majority, I think more than 25 that is left behind, right?
Yes. Initially, they were started to manage as minimal intervention group with oral fluids and without doing catheterization and without doing hematocrit measurements regularly. But after that, some patients, 22 patients, were started IV fluids mainly on night time. As there was retrospective study, we couldn't assess the clear indications for that. And others were catheterized due to urine output measurements problems and reduced urine output.
Yeah, the time is up. Thank you, Professor Hewawasam, asking for question. And finally, I thanks Kaushalya, PGC, for your important presentation. We have to move to the next presentation.
Thank you. Thank you.
The next presentation will be trends in clinicopathological profile of thyroid cancers diagnosed over a period of 19 years at a single histopathology unit. The authors are Lienage TG, Mudduwa LKB, Mudduwa YDB, Abesiri Gunawardana DS, and Lienage AUG. Presenting author is Lienage TG. This is over to you.
Good morning. I'm going to present the trends in clinical pathological profile of thyroid cancers diagnosed over a period of 19 years at a single histopathology unit. Thyroid cancers show an increase in incidence over the past years. The latest cancer incidence data available for 2015 reveals thyroid cancer is the second most common cancer among females. It is the commonest cancer among females aged 15 to 34 years in Sri Lanka. The age-specific incidence rate of thyroid cancers has doubled from 7.4 to 15.9 per 100,000 population in females from 2010 to 2015. Galle is one of the 4 districts with highest crude incidence rate of thyroid cancers in 2015. There are 4 main types of thyroid cancers: papillary carcinoma, follicular carcinoma, medullary carcinoma, and anaplastic carcinoma. And papillary carcinoma, which is less than 1 centimeter in size, is known as a papillary microcarcinoma. The objective of our study was to describe the trends in clinical pathological profile of thyroid cancers reported at a histopathology unit in Galle. It is a descriptive cross-sectional study, and the study population was all thyroid specimens, that is thyroid lobectomies and total thyroidectomy specimens received at Department of Pathology, Faculty of Medicine, Galle from 2002 to 2020. Study sample was all patients who were diagnosed with thyroid cancers at the Department of Pathology, Faculty of Medicine, Galle. The study period was for 19 years. So all thyroid specimens reported at our unit from 2002 to 2015 was included in cohort 1, and which has been analyzed and presented in the GMA academic sessions in 2016. From 2016 to 2020, we continued collection of data, and it comprises the cohort 2, which was compared against data of cohort 1. Clinical pathological features: age, gender, clinical presentation, histological diagnosis were extracted from the laboratory worksheets and compared. And data analysis was done on SPSS. There were a total of 3,015 thyroid specimens. Cohort 1 had 1,735 and cohort 2 had 1,280 specimens. And there was a significant increase in thyroid carcinomas reported when compared with cohort 1. And there was a decrease in percentage of males affected. So this chart shows that in 2002 to 2015, that is a 14-year period, there were a total of 1,735 thyroid specimens, and out of which 266 thyroid cancers were there, which comprised 15.3%. And during the period of 5 years, from 2016 to 2020, there were 1,280 total number of thyroid specimens, and out of which 279 cancers were there. So which comprise about 21% of thyroid specimens had cancers, which was of significance. And when you compare the gender distribution, there was a reduction in males affected from this cohort to this cohort. When we compare the trends in age groups affected by thyroid cancers, there was no significant difference in age distribution between cohort 1 and cohort 2, but the 40 to 49 years age group, shown in gray color, shows an increase. The proportions of papillary carcinomas, that is papillary carcinoma more than 1 centimeter size, follicular carcinoma and other thyroid carcinomas, age and stage at presentation, and association with autoimmune thyroiditis have not changed. But on the other hand, papillary microcarcinomas, that is a papillary carcinoma which is less than 1 centimeter in size, has increased significantly. When compared the total number of thyroid specimens, thyroid cancers, and the papillary microcarcinomas during the 14-year period, out of 1,735, we had 49 papillary microcarcinomas, that is about 2.82%. And when you compare the 5-year period, the most recent period, out of 1,280 specimens, 110 papillary microcarcinomas was diagnosed, which is about 8.59%, which is of significance. And the clinical presentation has changed with an increase in cancers presenting as solitary thyroid nodules and diffuse goiters, and the increase in severity of associated autoimmune thyroiditis. So this chart compares the trends in clinical presentation of thyroid carcinomas. Blue color bar shows multinodular goiters, orange color solitary thyroid nodules, and the diffuse goiters in gray color. And you could see that there's an increase in cancers presenting as solitary thyroid nodules as well as diffuse goiters. So our conclusions are, over 19 years from 2002, there is an upward trend in the number of thyroid specimens received for histopathology and the percentage of thyroid carcinomas diagnosed, as well as percentage of papillary microcarcinomas diagnosed. The clinical presentation of thyroid carcinomas also showed an upturn in presenting as solitary thyroid nodules and diffuse goiters. There is an increase in the severity of background autoimmune thyroiditis. Our references are Ackermann's Surgical Pathology and Cancer Incidence Data 2015. I'd like to acknowledge staff of Department of Pathology, Faculty of Medicine, Goa, and staff of Department of Surgery, Faculty of Medicine, Goa. Thank you.
Thank you, Dr. Tushari, for the interesting presentation. Now it's open for questions, discussion. And to start with that, I would like to ask a question. In your second cohort, it seems a higher rate of cancers. I want to know whether, because of the latter part of, with the development of many investigations like fine needle aspiration and ultrasound and other things, whether this second cohort cases are more highly suspected cases of cancers compared to first cohort. Can it be the reason? You have to unmute. Yes.
Okay, now I am allowed to unmute. I didn't get your question. I was concentrating on, because I cannot unmute this thing.
Yes, my question is, in second cohort, yes, sample, can it be some sort of screen sample with other investigation like fine needle aspirations and other radiological investigations and highly, suspected cases of cancers compared to the first cohort cases?
Yes, but especially now you saw that there was an increase in the solitary thyroid nodules. It may be because we got more ultrasound guided FNAs being performed, and because of that, so the cancer will present as a solitary thyroid nodule, especially when they are less than 1 centimeter. Especially papillary microcarcinomas, I think the increase was mainly because of that.
Okay, thank you. We can entertain one more question. Okay, since we have only 30 seconds, we will move to the third presentation. Thank you very much for your presentations and your answering questions. So we will move to third presentation today. Topic is assessment of advanced ECG knowledge among postgraduate trainees in emergency and general medicine in Sri Lanka, authored by Gunawardana MA, BA, Lanarol MI, Silva SN. And paper is presented by Gunawardana MABM. Yes, Gunawardana, over to you.
Good morning, everyone, and welcome to my presentation. My name is Dr. Bhaginda Gunawardana, acting consultant in emergency medicine. First of all, I must thank Gold Medical Association for giving this opportunity. The topic of my research is assessment of advanced ECG knowledge among postgraduate trainees in emergency and general medicine in Sri Lanka. I'll be discussing under these headings. We'll start with introduction. ECG is widely used in the diagnosis of many cardiac disorder and act as a preferred screening tool. An accuracy of interpretations is important for correct diagnosis to aid the decision-making process in patient management to avoid life-threatening conditions. Interpretation of ECG is basic medical skill. However, across the globe, many studies have concluded that undergraduate training on its own is not sufficient for accurate ECG interpretation. Studies have also shown that practitioners other than the cardiologist don't reliably recognize common abnormality in ECGs. In Sri Lanka, ETU, the first contact doctor could be a medical officer, emergency medicine or general medicine trainee, or trained emergency physician or general physician. Therefore, it is essential for medical doctors to have an adequate knowledge and ability to define, recognize, understand the basic pathophysiology of certain ECG abnormalities. Objective. The general objective of my study was to assess the knowledge of advanced ECG interpretation among postgraduate trainees in emergency and general medicine in Sri Lanka. Specific objectives were to assess the knowledge of Sri Lankan emergency and general medicine trainees in diagnosis ECG based on common and critical emergency condition, and to assess the years of work experience and years of training of Sri Lankan emergency and general medicine trainees in diagnosis ECG. We'll move to methodology. My study was a descriptive cross-sectional study, and study setting was Postgraduate Institute of Medicine, University of Colombo. Study population was specialist trainees for emergency medicine and general medicine registered under the Postgraduate Institute of Medicine, University of Colombo. Sample size was 200. It was taken after reviewing previous similar studies and expert advice from statistician. Sampling method was convenience sampling used to collect data. Participants were contacted via email through a contact list obtained with the permission of Postgraduate Institute of Medicine. Inclusion criteria was trainees who are currently registered in both emergency medicine and general medicine training program at the time of research. Trainees who were currently participating outside Sri Lanka and had some sort of foreign clinical training for more than 6 months, and who had cardiology ward exposure before more than 6 months were excluded. Data was collected using self-administered online questionnaire, which assessed the clinical scenario-based ECG knowledge of trainee via set of multiple choice question. All ECGs in questionnaire were selected by subject expert, and they were clinically significant. These were independently reviewed by 2 cardiologists, and there were no disagreements. Data was collected period between 15th of May to 25th of May 2021. All the data collected was entered to the computer database, and they were analyzed through using Microsoft Office Excel 2010 and IBM SPSS version 20 software. Ethical approval was taken from Ethics Review Committee of National Hospital of Sri Lanka. Informed written consent was taken before participation. Introductory note was provided to all participants with online questionnaire in English. Confidentiality was maintained by not documenting names and any other personal identifiable details. And there were no harm to any person involved in this study, and all steps of the research were done after ethical consideration. When we come to the results, we had 188 valid responses. Majority were from emergency medicine trainees. This chart shows the distribution of participants by their years of postgraduate training. Most of the participants had less than 1 year of PG training, and only 4.5% had PG experience of more than 5 years. And this chart shows distribution of participants according to their overall work experience. Majority were within a category of 6 to 10 years of total work of experience. This table shows results of ECG condition arranged in the that has arranged in the most correctly diagnosed. Most correctly diagnosed condition ECG condition was Brugada syndrome. 181 of participants were able to correctly diagnose Brugada syndrome, and followed by hyperkalemia and long QT syndrome. Least correctly diagnosed condition was pericarditis. Only 36 of participants were being able to diagnose it correctly. We, depending on the type of the question, all the 10 questions we asked in our questionnaire were categorized into 4 main domains. This was done due to identify further training. For example, question regarding trifascicular block, which was the question number 5, were included in the criteria for diagnosis and clinical correlation. So their performance in relation to this all 4 categories is as follows. On the left-hand side chart shows self-reported confidence in interpreting ECG of participants. 58% of participants say they are confident in interpreting ECG, and 19% say they are not confident. On right-hand side chart shows self-reported need for further training. 83% of participants say they need further ECG training. To compare the PG experience in years with mean accuracy of diagnosis ECG of maximum was 1. Number of years were categorized into 3 as less than 3 years, 3 to 5 years, and more than 5 years, except 2 questions that is related to pericarditis and WPW. The participant with more than 5 years of experience scored more than other 2 categories. However, in another 3 questions, the participant with less than 3 years of PG experience scored more than one with 3 to 5 years of PG training, suggesting that there were no clear relationship between years of PG training versus accuracy of ECG diagnosis and the interpretation. Further, there were less participants in latter 2 groups. Analysis to compare the work experience in years with with mean accuracy of diagnosis ECG yield similar results. Participants were grouped into 3 categories, and less than 5 years of work experience, 5 to 10 years of work experience, and more than 10 years of work experience. Except 2 questions relating to pericarditis and Brugada, all other questions show that there were no clear improvement in ECG diagnosis with the year of experience. The conclusion of my study: most correctly identified diagnosis was Brugada, and least correctly identified was pericarditis. The next correctly diagnosed were hyperkalemia and long QT syndrome. All the ECG were related to scenario that a qualified doctor who work in emergency department should know. Most postgraduate trainees were unable to diagnose and correctly interpret the selected ECGs appropriately, which implies that there is low a level of accuracy for some critical ECG diagnosis. An accurate diagnosis and interpretation is vital for patient management. Therefore, adequate training needs to be implemented for those who are involved. These are my reference, and thank you very much for your attention.
Thank you, Dr. Gunawardena. As time is elapsed, so I would like to invite the attendees or panelists to ask one question. As there's no question, so I would like to ask one question. In your sample, I saw it has been demonstrated that there is a below average, the diagnosis is made correctly in left bundle branch block. What is the reason for that?
Maybe because we gave a case scenario, and with that we provided some ECG. Maybe they weren't not been able to identify, maybe they are not be able to identify this ECG according to case scenario. That may be the reason.
Thank you. Thank you, Dr. Gunawardhan and the rest of the authors for your important presentation. I would like to move to the next presentation. The topic is effect of alendronate and vitamin D3 treatment on bone turnover markers in postmenopausal women with high bone fracture risk. A double-blind randomized control trial. The authors are Ratnayaka H, Lekavasam S, Vikramatilaka CM, Lenora J. The presenting author is Ratnayaka H. This is over to you.
I am Hasanga Ratnayaka from University of Ruhuna. Title of my presentation is Effect of alendronate and vitamin D3 treatment on bone turnover markers in postmenopausal women with high fracture risk, a double-blind randomized control trial. Moving on to the introduction, bone turnover markers are proteins or derivatives of proteins that are released during bone remodeling. They could be collagen breakdown products, matrix proteins, or enzymes. Bone markers are increased in osteoporosis, and these are expected to decrease significantly after receiving anti-resorptive treatment in osteoporosis, and they can be used to monitor the efficacy of the treatment. Further, bone markers provide early therapeutic response compared to BMD values. Our objective was to evaluate the degree of response of bone markers following alendronate and vitamin D3 treatment in postmenopausal women with high fracture risk. This was a double-blind randomized controlled trial conducted during 2018 to 20. The sample was collected randomly from Bopipodala MOH area goal. Postmenopausal women aged more than 50 years were considered, and they had high fracture risk. Total of 60 individuals were considered for the study, where treatment group had 30 individuals and control group had 30 individuals. Ethical approval for the study was received from Ethics Review Committee, Faculty of Medicine, University of Ruhuna. We excluded participants with diseases which could affect bone metabolism, and also we excluded participants who were on medications that could affect bone metabolism. Eligible participants were allocated into treatment group and control group using block randomization. Then, baseline bone marker levels were measured. Treatment group received 70 milligrams of weekly alendronate with daily vitamin D3 dose of 1000 international units. Control group received a placebo similar to alendronate tablet with daily vitamin D dose of 1000 international units. Then both groups were followed up for 6 months, and after that, again, bone marker levels were estimated. These final bone marker levels after 6 months were compared with the baseline values to see the significant difference. Bone mineral density of hip, femoral neck, and spine were measured using DEXA at Teaching Hospital Karapitiya. High fracture risk was determined according to the FRAX model, which was validated for Sri Lanka based on femoral neck, BMD, and clinical risk factors recommended in the FRAX webpage. Women with major fracture risk more than 9% and or hip fracture risk more than 3% was considered to have a high fracture risk. We considered 2 types of bone turnover markers, bone resorption marker CTX and bone formation marker P1NP. Normally distributed data were presented as means and standard deviation. However, bone marker levels were not normally distributed, and log transformation was done prior to the analysis. Therefore, bone marker levels were presented as geometric mean with 95 confidence intervals. Bone marker values before and after the treatment were compared by paired t-test. P-values less than 0.05 was considered as statistically significant. Any of the considered parameters such as age, menopause years, BMI, BMD parameters, fracture risk data, and bone marker data were not significantly different between treatment group and control group at baseline. According to results, in treatment group, mean CTX levels reduced by 60% after 6 months when compared to the baseline. Mean P1NP levels were reduced by 39% after 6 months of treatment. And these changes were significant. In control group, significant mean differences were not observed for bone markers, CTX and P1NP, between baseline and after 6 months. The findings reported in the present study are congruent with the available literature. Literature shows 30 to 70% reduction of CTX and P1NP upon treating with oral alendronate after 3 to 6 months. Considering this information, certain countries such as Australia, China, Japan, and Thailand have already been utilizing these markers in the management of osteoporosis. In conclusion, combination of alendronate and vitamin D3 treatment significantly reduced bone turnover markers. Vitamin D3 alone had no significant effect on serum bone marker levels in this group of women. CTX and P1NP would be promising markers in monitoring early therapeutic response of postmenopausal women with osteoporosis and high fracture risk in Sri Lanka. However, more studies with larger sample size are recommended to verify the findings generated from the present study. These are the references. And I would like to acknowledge technical staff of Nuclear Medicine Unit, Faculty of Medicine, University of Ruhuna, for performing ELISA assays, and would like to acknowledge technical staff of DEXA unit for performing DEXA scans for the participants. And also I would like to thank participants of this study for their kind cooperation, and would like to acknowledge UGC block grant for the financial assistance. Thank you.
Thank you, Ratnayaka, for interesting presentation. Now is paper open for discussion, questions, comments. You can make your questions in Q&A box. So to start with, I would like to ask one question. This is a very interesting study. Are there any new findings compared to other studies in other countries and other society with other nutritional status? Is there new findings in this study?
The question is not clear to me, sir.
No, my question is, compared to studies in other countries with other nutritional status, is there something new in your study result? I mean, in your result?
Yes, that means the bone markers have been studied in many countries. That's because the behavior of these bone markers are different from one country to another. That is based on their environmental factors, genetics, and many other things. The new thing that I did was conducting this research in Sri Lanka, because these bone markers have not been studied for Sri Lankan population. So other developed countries, they have already studied and they are being utilizing these markers for their management of osteoporosis, but we are still not doing that. So before doing that, we have to see the behavior of these bone markers in our population. So that is the new thing that I have found in my study. And also most of the literature data, they haven't considered specifically high fracture women. They had larger sample size, but they have just considered women with osteoporosis. But the real group of which need the treatment is the women with high fracture risk. So that is a new finding of my study.
Okay, thank you very much. Of course, we can see one question from the audience, but due to the time factor, we will move to next presentation.
Thank you, sir.
The fifth presentation is on, the title is Zero Prevalence of COVID-19 Among High-Risk Population in Galle, Sri Lanka, a story behind successful control of first wave of COVID-19 pandemic. Authored by Palangasinghe DR, Disoisa PDWD, Dahanayake NJ, Herath HMM, Disilla PU, and paper is presented by Palangasinghe DR. Over to you, Palangasinghe.
Good morning. Today our presentation is about zero prevalence of COVID-19 among high-risk population in Galle, Sri Lanka. A story behind the successful control of the first wave of the COVID-19 pandemic. As you all know, COVID-19 is the most devastating global health emergency faced by us in the current context, and its impact on the healthcare systems have been immense. And not only healthcare systems, also all facets of society, including education, socio-cultural interactions, economy, had been massively impacted by this pandemic. It's a well-known truth. Looking at the control strategies adapted by different countries to limit the spread of the disease, there were two types. Mainly, some of the countries like China, Sri Lanka has adopted a very strict control measures to combat the pandemic. That included and not restricted to lockdowns, closure of schools, airports, mandatory quarantine and screening of all first-line contacts, and so on. And some of the countries has adopted the less stringent control strategy. So it was well known and it was quite evident looking in retrospect. All the countries has adopted strict control measures, had been successful in reducing the number of cases and was able to limit the transmission of the disease. And to what extent these strict control measures are successful has to be scientifically determined by zero prevalence studies. So in a given community, prevalence of COVID-19 can be determined by viral detection tests as well as antibody detection tests. So these antibody detection tests can be adapted in communities which are non-vaccinated. So we have conducted this survey from June 2020 to August 2020 by performing antibodies against SARS-CoV-2 and PCR testing in a high-risk population in Galle. And there we have selected 100 tourism industry workers who has had close contact with foreign tourists visited Sri Lanka during the period of 3 months starting from 1st of January 2020. And as you all remember, from June to August 2020 was the time where we came to an end of the first wave, and we wanted to determine how successful we really were in controlling this pandemic by adapting those strict control measures mentioned. So only scientific way of determining the success of these control measures were in performing these zero prevalence studies. So out of those 100 participants, all 100 participants we have done antibodies, IgM and IgG antibodies against SARS-CoV-2 by conducting it in a new coronavirus IgG IgM rapid test kits, which had a sensitivity of 98.8% and a specificity of 97.7%. And PCR testing was performed in 81 participants, obviously because 81 participants only consented for PCR testing, and both these tests were performed on the same day. And what have we found? All 100 participants were tested negative for antibodies, IgM and IgG antibodies against SARS-CoV-2, and all 81 individuals who consented for PCR was tested negative. So what does it indicate? It proves zero prevalence in this high-risk community in Galle from June to August 2020. And that indicates the success of these control measures adopted as a country. So let's see about the social demographic factors of the study participants. In terms of age, gender, and occupation, you can see the breakdown in this table. So majority were males, 89% of were males, obviously because of the industry we have selected. And majority of the participants were in the age range 30 to 49. They are in the economically productive age group, and all these participants being tested negative is a fantastic achievement in terms of healthcare indices, isn't it? And this graph, you can see the distribution of comorbidities. About 32% of participants had some comorbidity, at least diabetes, hypertension, heart disease, bronchial asthma, chronic lung disease, dyslipidemia, and other comorbidities were found in 32% of the study participants. So this is a fairly distributive or representative sample from the community, and as we all know, these strict control measures had been successful in achieving a zero prevalence in this high-risk population in Galle. And in conclusion, we can say the negativity of both PCR and antibody test among this study population provided us a strong evidence for the healthcare success of the control measures adopted during the first wave of pandemic in Sri Lanka. And one of the important questions that arises with that, why didn't we sustain these measures during the following waves, second, third, and fourth phase, and why we are at a situation now where we have almost exceeded the healthcare capacity with devastatingly high number of ICU admissions and deaths that we never expected by moving to a less stringent strategy from a tight control strategy in COVID-19 pandemic. So there are lots of debates and arguments about lessening these control strategies, loosening these control strategies. But the most important question we have to leave here is how sustainable these measures in terms of economy, education, and socio-cultural interactions as a lower middle income country like us. Not only as a lower middle income country, even countries who had a high income with very well developed healthcare facilities and a very wealthy economic strategies, they also could not sustain these control measures. So that is the most important question we have to answer, which is open for the debate. So these were our references, and I would like to thank study participants, laboratory staff, and Dr. Gaya, consultant microbiologist, in advice to conduct this survey. So with that, I would like to open the stage for the questions from audience.
Thank you, Dr. Palangasinghe. Now the forum is open for questions. So there are no questions from Q&A box. So the panelists, so you can ask questions if they're interested questions with you. One question from Q&A box. One question from Q&A. Yeah, one. So one question now from Q&A box. The question is, having seen how the pandemics unfolded subsequently, do you still believe this is a cost-effective strategy? Dr. Palangasinghe?
Yes, thank you for the question. So it's looking in retrospect, it's not a difficult question to answer, but only problem is prospectively how practical to adapt these measures, and as I mentioned, how practical to sustain these measures. But we have to perform surveillance in terms of economy and the healthcare statistics and give an analysis for that. But personally, I do believe if we had sustained these control measures, it would have been health as well as economically productive, looking at the number of deaths, ICU admissions, and the immense cost that we are spending on each patient who get admitted to an ICU or who requires oxygen. So ultimately, it looks that it would have been economically productive also, not only in terms of health statistics. So that's my personal opinion. But as I mentioned, it is still debatable, and maybe lots of pros and cons related to that. But if you ask for my personal opinion, as a physician looking after patients with severe COVID pneumonias, yes, I believe even as a low middle income country, we would have been more successful in terms of economy and health if we have sustained these measures.
Thank you, Dr. Palangasinghe, and the rest of the authors for presenting the timely important study. So I would like to move to the final presentation of this session. This presentation will be on clinical profile of the patient with cerebrovascular accident admitted to the emergency treatment unit at Teaching Hospital, Karapitiya. Presenting author is Karunanayaka A. The rest of the authors are Veerasuriya MA, Munavira NW, Ranasinghe RDNN, Dahanayaka RLS, Airangani SAN. This is over to Dr. Karunanayaka A.
The title of my presentation is Clinical Profile of the Patients with Cerebrovascular Accident admitted to the Emergency Treatment Unit at Teaching Hospital, Karapitiya. The authors are M.A. Veerasuriya, N.W. Munavira, R.D.N. Ranasinghe, R.L.S. Dahanayaka, S.A.N. Irangi, and A. Karunanayaka. CVA, or cerebrovascular accident, is the fourth commonest cause for in-hospital mortality in Sri Lanka. The community prevalence of CVA in Sri Lanka is 1.6%. Spontaneous non-traumatic intracranial hemorrhage, SICH, is defined as intracranial bleeding that occurs without trauma or surgery. SICH accounts for 10 to 15% of all CVA and is associated with a higher mortality rate than ischemic type. Data on SICH in Sri Lanka are not available, mainly due to the unavailability of brain imaging facilities in government hospitals. The objective of the study was to determine the clinical profile of the adult patients with first ever cerebrovascular accident admitted to the emergency treatment unit at Teaching Hospital, Karapitiya. Method: consecutive consented adult patients with first ever cerebrovascular accident referred to ETU-THK in first 3 months of the 2020 were recruited for this prospective observational study. Ethical approval was obtained from the Ethics Review Committee of Faculty of Medicine, University of Rohini. Results. This study includes 58 patients presented during first 3 months of the 2020. 60.3% of them were female patients, 39.7% of them were male patients. Mean age of the male patients was 66.1 years and female patient mean age was 64.6 years. The mean age between two gender were not statistically not significant. The cohort includes patients from 31 years to 94 years of age. In both sexes, majority of patients were from 70 to 79 age group. Majority of them had a previous medical history. Hypertension and diabetes mellitus were the commonest non-communicable chronic disease among the patients, followed by dyslipidemia and bronchial asthma. 17% of them had 3 or more chronic disease at the presentation. During hospital stay, 17% of them were diagnosed with hypertension, and one patient was diagnosed with diabetes mellitus, and one patient was diagnosed with brain vascular malformation. When we analyze the adverse events occurred within 24 hours before the incident, 10.3% of them had sleep deprivation, and 6.9% of them had stressful physical or psychological event or ethanol consumption within 24 hours before the incident. Patient denied usage of recreational drug or sexual enhancement drugs during the particular period. 51.7% of them had a family history of cerebrovascular accident. 20% of them had given a history of cerebrovascular accident among the mother of the patient. Limb weakness and headaches were the most common initial symptoms of the patient, followed by slurred speech, nausea, and vomiting. 51.7% of them had spontaneous non-traumatic intracranial hemorrhages. Mortality rate was 33.3% among the SICH patients, which is compared to ischemic type CVA, it was around 2.3%. SICH was slightly higher among the female patients, however, that finding was not statistically significant. Glasgow Coma score, systolic blood pressure, diastolic blood pressure, pulse rate, respiratory rate, and oxygen saturation were analyzed as the initial clinical parameters. However, initial parameters were statistically not different between the sexes of the patient. Also, initial clinical parameters were not statistically significant between according to the CVA type. NIH stroke scale score was used to determine the severity of the disability. Analysis has shown that on admission, NIH stroke scale score was statistically significantly higher among the female patients. However, NIH stroke scale score was not significantly different according to the type of CV. Conclusions. Patient admitted with CVA to ETU at THK have shown high prevalence of spontaneous intracranial hemorrhage. And the mortality rate was significantly higher among the SIACH compared to the ischemic type. And CVA patients were suffering from non-communicable chronic diseases, and the prevalence of non-communicable chronic disease is also high. Female patients had more severe disability in the initial presentation than the male patient. Those are my references. Thank you.
Thank you, Dr. Karnanayaka, for your interesting presentation. Paper is open for discussion. Now you can ask questions, put your questions in. Yes, there is one question from the chat box. Question is, any reason for higher percentage of ICH than other series? ICH is about 20 to 30% in other series. Is it due to reference of more ICH to the teaching hospital Karapiti due to availability of NSU facility?
Thank you for your question. I also believe that as a tertiary care center with NSU facilities and imaging technique, and the ETU is a specialized unit to care the acute patients with acute presentation. So that is the one that may be the one reason which has contributed for higher ICH among the CVA patient presented with the ETU. However, this study was initiated by the researchers having observed that there is a significantly high percentage of ICH among the CVA patients, and then the researcher has some doubt whether there is linked to use of this recreational drugs or sexual enhancement drugs. So that is the one observation which has led for this to start this research. But generally, we have some impression that ICH levels, the percentage of ICH is somewhat higher than the reported cases. So that is the one initial research question we had before embarking on this research.
Okay, thank you very much for your interesting presentation. And with that, we conclude second pre-paper sessions of 80th Annual Academic Sessions of Gold Medical Association. And I would like to thank all the presenters and authors and the participants all over who attend online. Thank you very much. Thank you.
Encouraging research. Each year, the Government Association awards a competitive research grant to its library. Next in line, we have the presentation of the recipient of the GMA Grant 2020. I cordially invite the co-chairpersons for the session, Dr. Keshari De Silva, Consultant Anesthetist, Teaching Hospital Karapitiya, and Dr. Nayana Liyanarachi, Senior Lecturer in Pediatrics, Faculty of Medicine, University of Ruhuna, to chair the session.
Good morning to all of you. Welcome to the presentation of the recipient of GMA Research Grant for the year 2020. The presenter is Dr. Deepani Sirivardhana, Senior Lecturer in Pathology, Faculty of Medicine, University of Ruhuna. The topic is Evaluation of Performance Characteristics of Selected Albumin Assay Kits. Over to you, Deepani. Please remember the questions are not allowed for this session.
Good morning, chairpersons, ladies and gentlemen. Firstly, I would like to thank the Gall Medical Association for giving me this opportunity to share an overview of our research project and its preliminary findings. I was the recipient of the Research Grant 2020. The application was submitted on 25th November and we received the grant on 18th of December during the annual general meeting of the Gall Medical Association. We had prior ethical approval for the project granted from the Ethical Review Committee of the Faculty of Allied Sciences, University of Rwanda. My co-researchers are Dr. Kalani Gunawardena and Ms. Rajika Jinadasa from the Department of Medical Laboratory Science, Faculty of Allied Sciences, University of Rwanda. Albumin or microalbumin, as it was previously known in urine, is an important biomarker. In the current clinical practice, this is used for screening and monitoring of diabetic nephropathy, classification, risk assessment, and monitoring of treatment for chronic kidney disease. Furthermore, it is an independent risk marker for cardiovascular disease. Urine albumin creatinine ratio in a first morning void urine sample is the recommended test, and it shows a good correlation with a 24-hour urinary albumin excretion, which is the gold standard. In the laboratory, either immunoturbidimetry or immunonephrometry techniques are used. Anti-human albumin antibodies react with albumin in the sample, and when the complexes form, they increase the turbidity of the sample. This change in absorbance or the scattering of light can be determined spectrophotometrically. There are automated, semi-automated, or manual spectrophotometric methods. Globally, the assay standardization is still evolving. Therefore, the results produced from different assays are not yet comparable. The ISO 15189-2012 Medical Laboratories Requirements for Quality and Competence, the international standard, requires test results to be traceable to a certified reference material or a reference method. Manufacturers need to declare the methodological traceability information in their reagent kits or leaflets. ERM DA 470, produced by the International Federation of Clinical Chemistry, is the currently available certified reference material for urine albumin. The first criterion in selection of a kit is its calibrated traceability to this CRM. The next step in the evaluation is the performance characteristics. In our study, we are focusing on urine albumin assay kits for manual and semi-automated platforms, which are commonly used by small-scale laboratories. In our objectives, firstly, we will do a desk evaluation of the urine albumin assay kits, followed by the laboratory evaluation. In phase 1, we would tabulate and compare the manufacturer declared performance characteristics given in the kit inserts. In the phase 2, through a laboratory analysis, we would verify the performance characteristics declared by the manufacturers. Ours is a cross-sectional comparative study conducted in the departments of pathology and medical laboratory science, University of Rwanda. We are acquiring patient samples for the laboratory analysis from the nephrology clinic, Teaching Hospital, Karachi. The kits are acquired from registered suppliers of University of Rwanda, and we are only selecting urine albumin kits used for manual and semi-automated analysis. They need to have the calibrated traceability for ERM-DE 470 produced by the IFCC. Manufacturers need to provide written consent for both the desk and the laboratory evaluation, as we plan to share the findings with the name of the kit and the manufacturer. We have invited 6 suppliers and 4 of them gave written consent both for the desk and the laboratory evaluation. One kit manufacturer gave the consent only for the desk evaluation. When we were evaluating performance characteristics, we looked at the linearity range, the precision profiles, and the accuracy declared by the manufacturer. This table summarizes the names of the kits, their assay principles, and the linearity range. We have 5 kits: BioLabo from France, Biosystems from Spain, Dialab from Austria, Human from Germany, and Randox from the United Kingdom. Except Biosystems, the other 4 kits have the same assay principle, which is immunoturbidimetry, where the endpoint reaction is measured at 340 nanometers. Biosystems is slightly different. It has latex particles coated with antibodies, and the turbidimetry is measured at 540 nanometers. All 5 kits meet the requirement for the linearity range from 2 to 400 milligrams per liter, which is required for the current urine albumin assays. When it comes to intra-assay precision, Human gives the best precision profile. However, the other 4 kits too give a precision less than 6%, which meets the analytical goals for intra-assay precision. Likewise, when it comes to inter-assay precision, Human again is the best performer with the lowest precision profiles. However, again, the other kits too meet the requirement. When it comes to accuracy, the kit manufacturers provide this data using a method comparison study. Biosystems do not give this information in the kit insert. They state the information can be acquired on request. Human gives detailed method comparison data. They have performed their assay using Beckman array reagents on Hitachi 911 analyzer and using 30 patient samples. BioLabo and Randox have used 143 samples respectively. Dialab does not mention the sample number but mentions the technique, which is nephelometry. All 4 kits show a correlation coefficient of R exceeding 0.9 for their accuracy data. In the phase 2 of the research project, we are going to verify the linearity, precision, and the accuracy. The linearity would be verified using a series of standards prepared by dilution using the standard provided by the kit. The precision profiles would be assayed using commercially available internal quality control materials at 2 specified levels. We would look at both the intra and the inter-assay precision. Accuracy would be evaluated using 14 patient samples given by the sample size calculation. Patient samples would be analyzed by all 4 methods and compared against values obtained from an accredited laboratory. We will be using manual spectrophotometric analysis with the Shimadzu double beam spectrophotometer. Reagents and samples have been acquired already for the laboratory phase. The data generated by this research project would be very useful for the small scale laboratories which are using these manual assay kits for urine albumin detection. I would like to acknowledge the Gall Medical Association for the financial support to do the laboratory evaluation and the kit manufacturers for their participation and especially for giving consent to publish the data using the kit names, and the director and the consultant nephrologist of Teaching Hospital Karapitiya for giving us permission
to acquire patient samples from the clinic and the patients for providing samples. Thank you.
On behalf of the Gall Medical Executive Committee of the Gall Medical Association, I would like to thank Dr. Deepani Sirivardhana, and I would like to wish her good luck in her future research. At the same time, I would like to thank all the online participants being with us.
Thank you, co-chairpersons. Next on the schedule is the second plenary lecture. I take the pleasure of inviting the co-chairpersons for the session, Dr. D.K. Dias, Consultant Oral and Maxillofacial Surgeon, Teaching Hospital, Karapitiya, and Dr. Satish Gunasinghe, Consultant Urological Surgeon, Teaching Hospital, Karapitiya, to the head table.
Thank you, Lalindi. We've come to the plenary lecture, second plenary lecture this morning, and it will be delivered by Dr. Satish Vijayamana, who is a consultant plastic surgeon at the Teaching Hospital, Karapitiya. And he was trained in plastic surgery in Colombo and St. Thomas's Hospital, London. And Dr. Satish Vijayamana will speak on miracles of plastic surgery. Over to you, Satish.
Good morning. Thank you for giving this opportunity to talk on miracles of plastic surgery. You hear things about remarkable innovations and surgical procedures in this modern world that was not possible then, but now it's possible now. You might consider that it's a supernatural event, and in plastic surgery, they are not random events. These surgeries as a result of extraordinary people who thought out of the box for the betterment of people. Theodore said creativity is thinking up of new things, and innovation is doing new things. Way back in 1400, Antonio Branca reconstructed the nose for the first time. And then it was known as nose job. The nose is reconstructed on the forearm, and then arm is raised to the head and nose flap position on the face and stitched to the defect. After 8 to 10 of agonizing and uncomfortable weeks, forearm is freed from the flap. The procedure may sound frightening now, but it was the cutting edge at that time. We have come a long way from Sushrutar's days, 800 BC. All these giants achieved things by moving out from their comfort zone. At the break of World War II, there were only 4 experienced plastic surgeons in Britain. This picture, from left to right, Brentford, Kilner, Sir Harold Gillies, and Mackintosh. The government requested them to get divided and head up 4 separate plastic surgical units to treat the war casualties, mainly the service members from Royal Air Force. Mackintosh, the New Zealander, finally found his place at East Grinstead in England. He founded a Centre for Plastic and Jaw Surgery to deal with Royal Air Force casualty. Mackintosh's dedication and work on these members of the Guinea Pig Club led to the new era. The burn care and the flaps he performed revolutionized plastic surgery. The miracles were due to his dedication. I had my training at East Grinstead, this Mackindow's old hospital. This is my boss with Mr. Roger Smith. Kwande, from his junior resident experience with a dedicated senior resident, generates a key question. What does it take to be good at something in which failure is so easy, so effortless? Someone who is vigilant and focused will see things differently. The curiosity and diligence will bring creativity. Putting this creativity will lead to innovations and miracles. The human thumb is undoubtedly the most important digit. Humans are greatly separated from lower primates for its ability to oppose. It is essential for the great dexterity of the human hand. We take our thumbs for granted, but every day around the world, children are born without thumb. A life without a thumb would be dreadful. It is even more painful for young parents to see their child growing with a disability where the child is struggling to perform things a normal growing kid would do. Basic functions like playing with building blocks, grabbing onto things, even holding a pen is a challenge. Only surgically could change this kid's future. Making a thumb is a challenge. It's a challenging and a difficult operation. It took 100 years to perfect the surgical procedure. This operation is called polycization, a complex and an advanced surgical technique developed to give the best possible outcome. It is one of the great triumphs of surgery. These are some of my drawings. Today, a surgeon can build an almost normal thumb using the child's index finger. This is a magnificent surgical procedure. The index, which stands with the other fingers, will be moved into its new position where the tip of the new thumb will be facing the other fingers. The extra phalanx of the index will become the metacarpal, and the metacarpal of the new thumb and the metacarpal of the index will become the carpal bone after shortening its length. Sir Charles Baird, renowned Scottish anatomist, said the thumb's vital importance. His famous words written almost 200 years ago. On the length, strength, free lateral motion and perfect mobility of the thumb depends on the power of the human hand. This procedure is broken down into 15 steps. Incisions are placed very carefully to make sure the new thumb will position in its new location with a smooth and a web space which is a wide web space so that scars will not interfere with its movements. Here, this video clip will show kid is struggling to pick things. And here, the pen is held between the two fingers with a poor grip. The created thumb will have its position, stability, strength, the length, which is required to perform all the functions of a normal hand. To perform this surgery, the surgeon needs to develop a very high level of skill. There can't be a an error in this surgery. And this is after constructing the thumb. Confidently, kid holds on to the pen. Firm grip. On 19th of May 2015, one of the most challenging surgeries ready to kick off here at Karapiti. 5 different surgical specialists working together with a team of experienced anesthetists for a miracle surgery. The neonatal intensivist is ready with a team for post-operative care. Clock is clicking. Everyone knew their role. The separate team was kept ready for any emergency. You could see at the top picture, pediatric surgeon. And as you come down, the orthopedic surgeon operating. The conjunctivitis. It was a sudden call. And looks like one child is not going to do. We had limited time. Before the heart stops, we had to separate the healthy baby. The pressure was building. I printed almost life-size pictures to plan the incisions, how I'm going to separate these 2 kids. After placing the incision, the pediatric surgeon started to dissect it, then the vascular surgeon. And the orthopedic surgeon got involved in separating the bony part of it. And finally, for me, it was a lifetime experience for all of us. But this is not the only challenge I had to face. Establishing a plastic unit at Karapiti was another challenge, especially when it comes to microsurgery. Reconstructive microsurgery is one of the main components of a modern plastic surgical unit. This is a surgical discipline in which specialized operating microscope is needed, definitely, and very fine instruments to carry on finer reconstruction. Looking after these fine instruments is very difficult as it's very delicate. So I had to replace these instruments many times. There's a long history for this. The origin of microvascular surgery started way back in early, as in 1900. And the 3 components that contributed to develop the specialty was the fundamental surgical techniques, suturing techniques, the anticoagulation and intraoperative magnification. The early era, they performed these surgeries without any magnification. 1902 was the year the most significant technical breakthrough came in, when Carroll reported the triangulation method of end-to-end vascular anastomosis, which is still routinely used today, for which he was awarded later in 1912 the Nobel Prize. The work of these pioneers laid the foundation for the development of microvascular surgery. The achievements of these surgeons are especially remarkable, as they performed at the era, as I said before, without anticoagulation and intraoperative magnification. In 1921, Neelan developed the very first operating microscope. It was a monocular and used for autologic surgeries. With that, the early 70s, surgeons tried to understand the skin perfusion. Like dermatomes in neurology, angiosome concept came into light. The Australian plastic surgeon Ian Taylor exclusively studied these vessels and together named as perforators. This concept of angiosome is a block of tissue where it supplies skin, muscle, bone, or combination, supplied by a particular artery and accompanying veins. It can survive when isolated on its pedicle and the perforator. Each perforator, as it shows on this diagram, supplies a particular area known as angiosome. When the perforator to an angiosome is occluded, the surrounding choke or variable resistance vessels, which connects to the adjacent angiosome, dilate to maintain the blood supply of that affected angiosome. Usually, a perforator will only reliably perfuse one adjacent angiosome with these choke vessels. Therefore, it is possible to raise a flap or skin tissue based on a single perforator to cover local defects. This led to development of different fasciocutaneous flaps based on a specific blood supply. This diagram, it shows a flap known as anterolateral thigh flap. It's one of the most popular flaps among the plastic surgeons for reconstructive purposes. The flap is raised based on its descending branch of the lateral circumflex artery. The cross-section of this artery at the point where we divide for anastomosis is about 2 millimeters or less. With the help of tiny vascular clamps, microvascular clamps, and the microscope, it is possible to separate this tissue from its donor site to reconstruct the defect. About 8 to 12 of microsutures will be used to anastomose this vessel. This is a patient with a scalp defect following a resection of a recurrent squamous cell carcinoma. Shifting tissue or transferring soft tissue for such a large defect on the scalp is always a challenge. But here, we used this technique, used anterolateral thigh flap to reconstruct this patient's scalp, and it was connected to the regional temporal vessels. Two teams, the oncosurgeon started to resect the tumor, while the second team, the reconstructive team, started to harvest the fasciocutaneous flap from the thigh. And once the flap is ready, we go back to the defect where the onco team has completed their resection and look for a suitable donor vessel to reconnect the tissue. Once it's ready, this tissue will be transferred, keeping a very short ischemic time. This covers the scalp and will be reconnected to its new blood supply. Of course, this kind of flap need to monitor for a period of 3 days on regular basis, and the patient will be discharged thereafter. It is a similar situation. This is a foul-smelling malignant tumor. It's living with this for a while. So like in the previous case, the oncosurgical team resected the tumor, and while that was happening, we started to raise the anterolateral thigh flap and divided its blood supply when it is ready to transfer to keep the ischemic time short as possible. Here we dissected the neck vessels, the facial artery and vein to connect to its, to supply the blood, to establish the blood supply. You can see how big the size. It was a challenge because we had to resurface or design the flap to cover both the interior and exterior surface of the cheek. Patient was discharged after 5 days, and he never had to undergo any further procedure to correct his defect. Moving on, silicone breast implants, one of the most commonly performed surgical procedure in plastic surgery. Though it's heavy use for breast augmentation, it is also used for breast reconstruction following mastectomies. Breast reconstruction is a key element to the successful treatment of breast cancer and has become the standard of care for the Western world. But implant-based reconstruction, it has a lot of complications. We know it's very good for augmentation, but when it comes to reconstruction, it's not the best. We know very well the complications on an irradiated breast implant. The implant can move away from its position, disfigure, and the implant can come out, extrusion. And this will bring patient back to the hospital for a revision surgery or to remove the implant. A woman with a breast cancer can come at an early stage or advanced stage, and we can't clearly say whether we can avoid radiotherapy. Therefore, the autologous reconstruction is the preferred first choice. Tissue is taken from the patient itself, and there are many ways we could do it based on the size or the volume requirement. With the introduction of the transverse rectus abdominis myocutaneous flap by Hartman in 1980, reconstruction with autologous tissue became more successful and gained its popularity. The lower abdominal skin and fat with its underlying rectus muscle is used to reconstruct the breast. Taking someone's abdominal muscle to reconstruct this fatty breast doesn't look correct on principle. We are going to weaken the abdomen. And on the other hand, this area of tissue is mainly supplied not by the superior epigastric artery. Its dominant blood vessel is the inferior epigastric. So over a period of time, we are going to see significant fat necrosis, which can lead to about 25%. And if you happen to irradiate this breast, it further shrinks. Because of its attachment to the upper abdomen with its muscle pedicle, we can't move the flap freely and difficult to contour the breast. These are some of triumph flap patients, one and left to right, and we have done a little bit of breast lift on the normal breast to maintain the contour. See the size of the tummy. With the understanding of the blood supply to the lower abdomen and advancement of microvascular surgery, now the flap is raised based on its dominant blood supply, that is the inferior epigastric artery. The deep inferior epigastric artery was first introduced by Koshima in 1989 and then popularized among all the plastic centers for breast reconstruction. The advantage of this is, of course, there will be a microvascular anastomosis. Chances of failing the implant, yes, it's there, but we had the freedom contour the breast. That piece of tissue is taken out from the tummy with its blood supply without or disturbing the underlying rectus abdominis muscle. This gives a huge advantage over the tram flap when it comes to abdominal wall strength, reducing the hernia risk. The technique of breast reconstruction is called deep inferior epigastric perforator flap reconstruction, or DIAP. This has become the gold standard now for breast reconstruction. The lower abdominal tissue is harvested based on its dominant blood supply, which is the inferior epigastric artery. The abdomen is closed in a similar way, like in an abdominoplasty, without sacrificing the muscle or its innervation. It took some time to establish this kind of most advanced breast reconstruction at Teaching Hospital Karapitiya due to various reasons, mainly the awareness. Poor awareness among the patients or even those involved in this kind of counseling. During the first lockdown, we were able to perform the very first this kind of surgery here at Karapitiya. This particular patient even had to undergo radiotherapy after reconstruction. And even with little bit of fat necrosis, she was extremely happy. And to this day, it maintains the contour. Moving on to the nervous system, unlike in the central nervous system, the peripheral nerves can regenerate. If the severed nerve endings are repaired, the nerve cells will regenerate through the existing nerve to its target, proximal to distal. Based on these findings and these developments, we use sural nerves to bridge gaps and reinnovate both sensory and motor nerves. Can we do something for facial weakness? We know there are static surgeries which will correct the facial asymmetry, but that they are not dynamic. They don't get spontaneous smile. Based on the etiology, age of the patient and timing of the reconstruction for an affected individual, we could offer a range of surgery. Mainly the causes for this kind of weakness is congenital, traumatic, surgical, like following excision of a CP angle tumor, or maybe due to Bell's palsy. How soon the patient comes to us and the age and the underlying other comorbidities will decide what kind of reconstruction these patients are going to get. For someone who turns up early, we can use a new donor nerve to innovate the nerve, the facial nerve. Usually we harvest the nerve to masseter and will be transferred to the targeted facial nerve. Here you could see the difference. In a period of 5 months, she started to smile. There's another patient. But some, of course, come quite late, or in a situation like in a child with Moebius syndrome. We have to offer a different approach. More demanding, 2 big surgeries at a period of between about 9 to 18 months gap. In the first surgery, we had to prepare the nerve, a donor nerve, to innervate the muscles. Indeed, you need to realize when the patient is late, all the facial muscles will be they are very atrophy, and by renovating these nerves, you are not going to help anything. So we use a sural nerve graft, dissect the normal side of the face, connect this graft to one of the good branches of the facial nerve, and bring it to the side you're going to operate, or the weakness. Leave for about 9 to 18 months, and the second surgery we go in and transfer the gracilis or bring a new muscle from the thigh to the face, connect that muscle to its new blood supply, facial artery, microanastomosis, and connect the muscle to the cross-facial nerve ground. Show you how the muscle behaves during the surgery. Checking its size, contraction. In this particular group, it's very easy to train these patients as it's a spontaneous smile, and within a short period of time, about 3 months following the second surgery, you start to see contracting this muscle. And they have the spontaneous smile, as I said before. With the development of this advanced microscope, most of our other routinely done surgeries got more refined, especially when it comes to cleft palate surgeries. We started to do a functional repair under good magnification. We were able to identify the anatomy very well, identify the palatal muscles separately, and used to do good functional repair. Brian Summerlad from Great Ormond Street, the one who started to popularize this technique. Here under the microscope, you would see after repairing the cleft palate. The peripheral nerve surgeries, like the nerve tumors, the naked eye or loop magnification, difficult to see the nerve fibers. But under the microscope, we could clearly see how the nerve runs. And there's room for us to go in and separate the nerve tumor without damaging the fibers. And in this case, the tumor is removed and the median nerve left alone, had complete recovery after a period of neuropraxia. Super microsurgery, the vessels less than 1.5 millimeter is a challenge. It's difficult to perform with the existing microscopes, but we have it. And here in a child's digital neurovascular bundle is damaged. And here to bridge the nerve, the gap of 1 centimeter, we used a vein graft. You could see we harvested it from the dorsum of the hand and then transferred it to the hand. Similar situation where digital nerve is damaged and reconstructed under high magnification. But this is not enough to do this kind of a very advanced lymphovenous anastomosis, what we call super micro, less than a millimeter. We need delicate instruments. Staff need to know about the importance of these surgical instruments, delicate handling, and this will be the future. And we need special microscopes to perform these surgeries. Tissue expansion is now commonly performed to correct these kind of defects. This child, following a trauma, lost the scalp. We reconstructed the area with a graft. You know the issue. It's a non-hair. There's no hair in that area. After expanding the scalp, we were able to reconstruct a scalp to get tissue. Similar situation, there's tissue loss on the heel. Generally, we need tissue to bring from an adjacent peroneal region or need to do a free tissue transfer. Dr. Lalan Thamarising, a senior consultant plastic surgeon, who's retired, is still into this kind of wound care. He sent me some remarkable, unbelievable set of pictures where close to his supervision, attending to the wound very carefully daily, is able to change the situation. without using a flap, advanced vacuum therapy, he was able to reconstruct the heel. Miracles don't happen. You make them happen. This is our future. You could see my 2 kids surrounded with their cousins. The miracles don't happen. You make them happen. They are not wishes or dreams. Yeah, there are not wishes or dreams or candles on a cake. They are not impossible. Reality is real. It is totally and completely under my control. The future is we need to train as many as possible to see more miracles. Thank you.
Good morning, ladies and gentlemen. On behalf of Gold Medical Association, I want to thank my colleague, Dr. Satish Vijayamana, who is a consultant plastic surgeon, Teaching Hospital Karapitiya, for delivering this very comprehensive and very informative lecture on miracles of plastic surgery. Thank you, Satish. At the same time, I want to thank all the audience on behalf of Gold Medical Association. Thank you very much.
Thank you, co-chairpersons. The Young Specialist Forum is a unique initiative of the GMA to inspire careers of its blooming young specialists. Next up, we have the Young Specialist Forum winners presentation. To chair the session, I cordially invite the co-chairpersons, Professor H.M.M. Herath, Professor in Medicine, Faculty of Medicine, University of Ruhuna, and Dr. Ganaka Senaratna, Consultant Physician, Teaching Hospital, Karapitiya, to the head table.
Good morning to all of you. The session that we are chairing is dedicated for the winner of the Young Specialist Forum 2021. This will be delivered by Dr. Harindu Ranga Kankanamheva. He is one of the senior registrar in medicine attached to the Teaching Hospital Karapitiya. The topic of the presentation is Stethoscope of the 21st century. Are you ready for the new era in medicine? So let's listen to the presentation.
This is Google, undoubtedly the most popular search engine. It guesses what you intended to search as soon as you type the first couple of letters. Google Maps will find you the fastest route to reach your destination, considering real-time traffic. Social media platforms will identify you and tag you as soon as you upload photos. Luxury of self-driving and parking cars are already available in developed countries. So have you ever wondered how all this became a reality? The intellectual power behind all this. Ladies and gentlemen, this is artificial intelligence. Good morning, everyone. My name is Tarilu. I'm a senior registrar in medicine. Today, I'll take you through this amazing technology as it is evolving to become the digital intellectual companion for us, the doctors. So this is artificial intelligence in medicine. Along the way, I will introduce you to this term, artificial intelligence, how this technology will be applied to the field of medicine, and the potential this technology holds to transform global health in the future. And finally, some of the limitations of this technology. The term artificial intelligence was first coined in 1956 by John McCarthy. So what is it? Basically, it means machines mimicking cognitive functions of human. What are the cognitive functions that we have? Learning as well as decision making. So in other words, we can say artificial intelligence is the use of computers for automated decision making to perform tasks that normally require human intelligence. So before moving on and learn this new technology, let's focus on traditional programming. So as you can see in this diagram below, in traditional programming, we have an algorithm which is manually set, manually made by a programmer. So when we enter data, this program has the capability of analyzing that data and come up with the results. For an example, if we want to differentiate apples from cherries, in simple terms, we can identify a variable such as weight. If the weight is more than a specific value, it's an apple. If it is less than that, it's a cherry. Or else we can use diameter. If the diameter is more than specific value, it's an apple. If less than that, it's a cherry. So let's look at this example. So as you can see, there are series of photos. In some photos, there are puppies. In others, there are muffins. What if we want the computer to correctly differentiate and identify muffins from puppies? Using traditional programming, to do that, we might have to, probably it's an impossible task to manually set an algorithm with such a vast number of variables to correctly tell the computer to identify in between muffins from puppies. So this is where this new technology, machine learning, comes in. So it is a technique by which a computer can learn from data without using a complex set of different rules like in traditional programming. Look at this diagram. Here, there's a first in this technology, there's a learning algorithm. Unlike in traditional programming, there's another algorithm which is called learning algorithm. This algorithm is fed with vast amount of data and expected results. So this learning algorithm itself will come up with a model or new algorithm which has the capability of analyzing that data and come up with the expected results. So when this new model applied to new data, then it has the capacity, or it can correctly analyze data and come up with results. I'll further explain this with an example relevant to medicine. So you can see there are X-rays. Some are healthy, some are fractured. So we feed a learning algorithm with large amount of healthy as well as fractured hands, X-rays of the hands. So this algorithm will come up with a model on its own. When we feed this new model, new algorithm with new data and new X-ray of the hand, this model has the ability to correctly identify healthy X-ray hands from fractured ones, and it will identify where the fracture is. Let's move on to our next part of the journey, where we will look at the applications of this technology in medicine. One such application is online consultations. In United Kingdom-based company, Babylon Health made an app with AI-driven technology, which has the capability of doing online consultation. So through this app, patients can report symptoms and it will automatically analyze these symptoms and it will offer the patient with relevant course of action. This app also gives the opportunity for the user with greater access to their own health data. So this is one such application. Next, health assistance. Sensely developed Molly. Molly is a virtual nurse. It's an AI-driven virtual nurse where the patient can monitor their own health with customized follow-up care. Medication management is another aspect where we can use AI technology. Example is IQ app. So this is an AI-driven compliance monitor where it uses smartphone's camera to detect real-time ingestion of the tablet. So we can use this app for diseases with public health concerns, such as tuberculosis. So we can monitor the compliance of the patient. Even participants in clinical trials to make sure that the patient is adhering to their medications. One important aspect where AI might practically applied in medicine is triage. AI-based algorithms accurately predicted the need for critical care of patients in emergency departments. So they outperform the conventional triage tools that we use and early warning scores. There was another AI-based algorithm accurately predicting the septic shock at initial triage. So it significantly outperformed clinical scores in screening septic shock at emergency department triage. So how this AI technology can be applied to diagnostics? This is one such application, deep learning based automatic detection. So this app has the capacity, the capability of automatically detecting malignant pulmonary nodules on chest radiographs. They have shown that this app could outperform physicians in nodule detection for malignant pulmonary nodules on chest radiographs. When used as a second reader, it enhanced physicians' performance. This is one example where this app has detected a nodule. So in the X-ray, you can see there's a faintly visible mass just behind the cardiac shadow, which was later confirmed with CT chest. This is how the app detected it. This nodule was detected by only 7 observers out of 80, unlike the app. Another application is AI-guided ultrasound software. This software allows doctors to perform cardiac ultrasound without specialized training. So it gives you real-time guidance how to handle the transducer. So it acts as a co-pilot for performing ultrasound scan for optimized imaging. Another application would be designing treatment plans. IBM Watson is one example. It gives evidence-based treatment options for oncologists. IBM Watson is going to combine patients' data with clinical expertise and research papers, and it will suggest promising treatment plans for patients with cancer. Drug creation is another field where this technology is applied. Atomwise created a new tool with AI which can discover drugs. So this AI will root out treatments from a database of molecular structures. One example drugs would be two drugs predicted by this AI technology had the capability of significantly reducing Ebola infectivity. So as you can see, there are a series of applications of this technology in healthcare. So let's see how this technology will transform global health in the future. First, we'll focus on key issues in global health. What are the key issues in global health? One is inadequate access to healthcare, inconsistent quality of care, shortage of well-trained healthcare workers, inadequate access to rapidly changing management standards. So artificial intelligence would be the answer in the future for all these questions. Before implementing this technology, we might have to face key challenges. What are they? One thing is reliability and availability of data. As I explained earlier, AI systems are trained with large volumes of data. So the quality of output will reflect the quality of input. So we need to train these algorithms with quality data. And we need to locally validate these algorithms by locally available data. So we need local, digital, quality data to train these algorithms. These tools need right set of practitioners. So as doctors and healthcare workers, we need familiarity with these AI tools. And we need to have the ability to assess the validity of these tools. That will only set proper implementation of these new technologies. And there's a common fear in healthcare workers that AI might replace them. So we need to address these misconceptions if we want to implement this new technology. Another challenge would be health systems lacking the capacity to regulate this technology. As we know, there is inadequate regulatory capacity even for traditional technologies. So AI-driven systems will create more complex regulatory challenges in the future. Finally, we'll move on to limitations of this technology. One limitation is unexplainability of AI models. So there are millions of learned parameters determining the output of AI decisions, which is created by learning algorithm itself. So even the developer might not understand how it draw conclusions. So this unexplainability will affect the trust by patients as well as medical professionals. Other problem is privacy, confidentiality, and data security, because AI needs access to medical records. They have shown that even data is anonymized, individual profiles might be traced back. So privacy is a problem. Other thing is biased AI. Example is this US criminal justice system using an AI to predict tendency of a convicted criminal to reoffend. This AI predicted disproportionately high probability of black people committing future crimes. This might be due to poor quality data used to train these algorithms. Another example is Amazon HR department using an AI to sort out best job applications. They have found that this smart algorithm favoring men. Another limitation is diagnostic errors. Boeing Max airplane crash is an example. So this is a faulty machine-driven decision overriding actions of highly trained pilots. leading to this disaster. So we have to keep in mind there is greater potential to cause large-scale harm with these technologies. So to conclude, AI is a promising technology which we might be able to use in everyday medical technology if policymakers make policies that favor adaptation, medical associations give clear guidance on implementing, and medical community accepting this technology as stethoscope of the 21st century. So, are you ready for the new era in medicine? Thank you.
Thank you, Dr. Tarindu Eranga Kananka Heva, Senior Registrar in Internal Medicine, for your excellent and eye-opening lecture, which was actually the winning presentation at ISF 2021. I would like to make this opportunity to thank all the judges of YSF 2021. GMA President and the Council would like to extend profound thanks to these judges. They are Professor Tilak Veeraratne, Professor Sampath Gunawardena, Dr. Arash Disanayaka, Dr. Krishant Jayasekara, Dr. Aruna De Silva, and Ganaka Senaratne. World Medical Association wish all the very best for Dr. Tarindu and all the senior trainees in Teaching Hospital Karapitiya for future endeavors and their professional development. Thank you very much.
Thank you, co-chairpersons. Next, we will take a short break and the session will resume in 5 minutes. Please stay connected with us for this intellectual journey. Welcome back. Moving on with our schedule, we have the second symposium of the academic sessions, Advances in Cardiology, Beating the Beat. I cordially invite the co-chairpersons, Dr. P.P. Sadanandan, consultant cardiologist, Teaching Hospital Karapitiya, and Dr. Arosha Disanayaka, senior lecturer in medicine, Faculty of Medicine, University of Ruhuna, to chair the session.
Thank you very much. Good morning to both the panelists as well as the attendees. Welcome to the Symposium on Cardiology, Advances in Cardiology, Beating the Beat. That's our theme. And for this session, we have three very eminent speakers. We have Dr. Kirti Divulweber, who is a consultant cardiac electrophysiologist, Dr. Vajira Senaratna, consultant cardiologist, and Dr. W.S. Santaraj, consultant cardiologist. I just wish to remind you that questions will be entertained at the end of all three presentations. And also the audience, those in the audience need to type in their questions in the Q&A box of this platform. If by any chance you cannot access the Q&A box, please raise your hand, unmute, and talk. Now that will happen at the end of all three presentations. And then we will start off with Dr. Kirti Divulweber, the first speaker. He is the consultant cardiac electrophysiologist attached to Teaching Hospital Kurunegala. And he will be speaking to us on arrhythmias in young adults. Over to you, Dr. Divulweber.
Very good morning to you all. It's a pleasure for me to deliver this lecture on this historic Galle Medical Association annual academic sessions, and I should thank the president of the Galle Medical Association and Sri Lankan College of Cardiology for giving me this opportunity. Without further ado, I'll start my presentation. The topic at hand is to discuss about arrhythmias in young adults. Sorry. The WHO definitions about young adult means that anyone who falls between age of 20 to 40 is considered as young adult. However, that we know that legal age of adulthood start at age of 18. Despite having witnessed a significant development in the diagnosis and management of all kinds of arrhythmias, but there are significant deficiency of epidemiology and surveillances regarding rhythm issues. So in brief, as we know, the heart is a muscular pump which has a very sophisticated electrical wiring. And if you classify arrhythmia, you could basically classify them into broad arms. The other end is bradycardia. The other extreme end is tachycardia. If you take arrhythmia in young adults, you would find that they are not a uniform group. They are a heterogeneous cohort. On one end, we have a set of people who have arrhythmia in the presence of a structurally normal heart. And we could find people who have either congenital heart disease or acquired structural abnormalities presenting with arrhythmias. And then we have inherited arrhythmia syndromes. And occasionally we find people who present with heart rhythm issues, but obviously their heart is either electrically or structurally normal, but the rhythm is resulted from external factors. So there are very many ways that people who present with arrhythmia to us. This is not very specific for young adults, but given the spectrum, you would find people presented with palpitation, either transient or sustained, they come with syncope, they come with features of heart failure. And sometimes, if the acute presentation could be with multi-organ failure, and most tragically, people can die of all these arrhythmias out of hospital cardiac arrest is one of the big issues. And very rarely we come across people, they are not straightforward in its way of presentation. They come as fits, they come at following road traffic accidents, and drowning could be resulted as having an arrhythmia or as falls or strokes. So why do we need to take these matters seriously? Because we know that young adults being a workforce of the country, and they need to be on their feet and deliver their maximum, and arrhythmia can get on the way. And as we know that arrhythmia, in my understanding, that's how I feel, it brings agony, it brings misery, and it brings tragedy. So we need to take arrhythmia more seriously, because we know that sometimes arrhythmia could be a manifestation of an underlying structural heart disease. It could lead to decompensation of a stable heart disease, and it could lead to sudden tragic deaths. And if you take this issue a bit further, arrhythmia runs in families, and arrhythmia has implications during pregnancies and being young adults, sports participation, and involved in recreational activities. Arrhythmia has some implications. So these things we know. So if you take common arrhythmias, in your practice, you are more likely to encounter people having sinus tachycardias. Atrioventricular nodal reentry tachycardia are common as well. And you might come across WPW syndrome and various tachycardias that can associate with WPW syndrome. And in this part of the world, premature ventricular complexes are very common, especially when they come from outflow tracts of the heart. Reflex syncope is not necessarily arrhythmia per se, but it's actually causing heart rhythm issue due to vagal activation coming down from the brain. And if you take SVTs, supraventricular tachycardias, you could appreciate the age, especially in young people. AVNRTs is relatively common as compared to accessory pathway tachycardia or tachyarrhythmias. So SVTs can either present with narrow complex or wide complexes, both morphologies. Sometimes, mostly it is 80% of the time, it's going to be a narrow complex tachycardia. And WPW syndrome, as I mentioned earlier, they can have various ways of presenting. They might come with an incidental description of having pre-excited DCD. They might present with the narrow complex tachycardia or broad complex tachycardia or even pre-excited tachycardia. Atrial fibrillation is relatively uncommon in younger people, but however, they can present in the presence of having after a binge of alcohol, and as we know, obesity and obstructive sleep apnea is now prevalent in the younger people, and atrial fibrillation could be the first presentation, and rarely concealed accessory pathways or structural abnormality can cause atrial fibrillation. The PVCs are very common, and it's not unusual that if you come across one or two PVCs, if you do an ECG. What is the important thing about PVC, that it could most of the time they could be idiopathic, that you wouldn't find anything unusual in their hearts. However, it's important that they will require a thorough assessment of that includes Holter monitoring and imaging in order to make sure that they don't have anything underlying. And however, the long-term data suggests that the PVC increase the mortality. Outflow tract PVCs are the commonest. This is a ECG of a person who has RVOT type of ventricular PVCs. And occasionally PVCs can organize into ventricular tachycardia. So when we come across a PVC, what we do is we try to build up a symptom ECG correlation, and when we do a ambulatory ECG in order to assess the number of PVC to quantify them and take at a percentage, and whether we see whether they develop ventricular tachyarrhythmias, have they got any other abnormal rhythms, and we make sure that they will have either at least an echocardiogram to assess the cardiac structure, because sometimes PVC can cause troubles. If the PVC burden is high, it can lead to LV dysfunction, or sometimes PVC could be a manifestation of subtle underlying cardiac issues. Rarely, PVC can cause sudden cardiac death. And the reason I wanted to highlight PVC is they are actually treatable, and the catheter ablation has excellent results if it comes to a point that the treatment is required. Bradyarrhythmias, what we have to remember, there are various types of bradyarrhythmias, basically sinus bradyarrhythmias and heart blocks. They are relatively rare. Pathological bradyarrhythmias are relatively rare in young people. However, if we come across a person with bradyarrhythmia, we need to assess their symptom, depends on the functional status. They might have, because the bradyarrhythmia lead to tissue underperfusion, they develop weakness and they complaints of exercise electrons. They might have a single episode at rest or during exertion. Sinus bradycardia, remember that it's not equivalent to sick sinus syndrome. We know that in young people, they tend to have bradyarrhythmia, especially during nights, and make sure that obstructive sleep apnea can cause bradyarrhythmia during nights. And reflex physiology is common, and after a common faint, if you do an ECG immediately after, you would find they can have various kind of bradyarrhythmias. So PR prolongation and Wenckebach phenomenon is common in young people, especially during sleep. So the point is that intrinsic bradycardias or bradycardia due to intrinsic conduction tissue disorder is uncommon in young people. So we have to exclude secondary causes. So it's important that we need to build symptom ECG correlation. They might require long-term monitoring, and it's important to assess the choreographic competence with exercise ECG. We have to make sure that there's no underlying causes or endocrine causes that can cause bradycardia, and we need to assess them with imaging in order to make sure how is the airway function, is there any structural abnormality, and if you suspect reflex or neurocardio inhibitor or common faint, might have to want to do a tilt table test as well. Heart blocks generally rare in young people. However, it associated with congenital heart disease from the disease itself or as a result of receiving some sort of surgical treatment. And it's important if you come across people with complete heart block in young people, what we have to remember that it carries a poor prognosis. So people can die suddenly from having ventricular standstill, or very rarely we have come across people develop ventricular fibrillation due to extreme bradycardia. And if a person lives on extreme bradycardia, it leads to LV dilatation and eventual LV dysfunction and pump failure. So we have to take complete heart block serious in young people. So we discussed this, and it's important that we assess this patient, make sure that symptom ECG correlation can build up and we can prove that this ECG is responsible for their symptoms. In order to do that, we might have to do an ambulatory ECG. An implantable loop recorder is a small stick that acts like a monitor, which can record a continuous heart rhythm for 2-3 years. It's a simple device which can go underneath the skin. Also, we have to arrange 2D echo, cardiac MRI, and depends on the risk history, we might want to do a tilt table test or exercise ECG. Only very rarely require an EP study. So the point that I need to highlight is if a patient is having sinus node disease, pacing will only improve the quality of life. But when you have a heart block, the pacing will improve quality of life and prognosis. So we have witnessed a significant development of device therapy for heart rhythm abnormalities. This umbrella term, cardiac electronic implantable devices. So we can offer endocardial pacing, we can offer epicardial pacing, we have cardiac resynchronization for patients with heart failure, we have novel pacing techniques, leadless pacemakers, we can pace the conduction system, And when it's come to tachycardia therapy, you must have heard this implantable cardioverter defibrillator. They are capable of giving shocks. Now we have subcutaneous ICD. And from the diagnostic front, we have implantable loop recorder, we have telemetry and remote monitoring as well. And remember that in certain situations, we could offer catheter ablation for certain type of bradyarrhythmia. This is something we haven't even thought of. Now, obviously, we could cauterize the neuronal ganglions inside the heart, and thereby cutting off the undue vagal stimulation to the heart, and we might be able to cure reflex syncope, certain AV nodal disease, or heart blocks or sinus bradycardias. As we know, pregnancy is a state where people are prone for arrhythmias. And these patients, obviously, for various reasons, pregnancy is at a higher risk of having all these comorbid and comorbidities. And they are prone to develop arrhythmias. And sometimes it could be the first presentation of an arrhythmia, or it could pregnancy itself exaggerate the arrhythmic symptoms for a person who already has an underlying structural or arrhythmia syndrome. But as far as I'm aware, none of these arrhythmic conditions are not an absolute contraindication for pregnancy. However, these patients will require a electrophysiologist, with follow-up with an electrophysiologist. And sometimes we might have to intervene during the pregnancy. Most of the time, we try to manage them medically. Very rarely, if we are to do any intervention or a pacemaker or ICD or an ablation, we will choose second trimester. And moving from that, if you think of arrhythmia with a structurally normal heart, that means they have a normal 2D echogram. If you want to do a cardiac MRI, you might find subtle changes, but there are no gross abnormalities. We think they are purely electrical. If you take some examples, inappropriate sinus tachycardia, AVNRT, or accessory pathways, certain focal atrial tachyarrhythmia, most of the time out for tract PVCs and other types of PVC. Generally, they have a very benign course, having excellent prognosis. However, remember that certain arrhythmias, they can cause LV impairment in the future. Generally, sudden cardiac risk is very rare. And the point I need to highlight is that most of these arrhythmias are easily fixable with catheter ablation. And moving from that, this is something that we need to take very seriously. And sudden cardiac death in younger age is a tragic. And every now and then if you follow the news, you might hear that young people found dead and under unusual circumstances. And most of the time, these are arrhythmic deaths. And these are most of the time, these happens due to pulse sensitivity or VF, but very rarely it can happen with complete heart block or SVT in the presence of already existing LV dysfunction. As you can see, considering age 16 to 40, you would see that the risk of dying in the incidence is 2 per 100,000 people, roughly around about the same age. So if we take what condition that could cause these type of tragic situations, Brugada syndrome, congenital long QT syndrome, early reproduction syndrome, and here's the list, and you can see almost all these conditions are inherited, and as a blanket term, we might call them channelopathies. And this progressive cardiac conduction system disease is obviously we see rarely in young people that they develop sinus bradycardia and AV nodal disease without having any other structural abnormality. WPW syndrome is not a channelopathy, however, it can cause sudden cardiac death. Don't forget hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy, and this is MVP and malignant mitral syndrome is something new. And we thought MVP is a benign condition, but now there are evidence piling up to say that certain MVPs could actually generate malignant arrhythmia leading to sudden cardiac death. Now, there's a few ECGs you could appreciate the long QT in the first ECG, and the right top ECG shows the Brugada changes. The left bottom ECG shows early repolarization, and right bottom ECG shows short QTs. And as we know, congenital people with congenital heart disease, now they are surviving into adulthood and they develop various kind of arrhythmias. And if we take valvular, all kinds of valvular heart disease and cardiomyopathies, alcoholic cardiomyopathies, secondary heart disease due to chronic airway disease, and now we see lot of people who develop myocardial infarction in their younger age, and that leaves a damaged myocardium, scarred myocardium, and they are prone for arrhythmias. So if we take as whole, we can see that arrhythmia is obviously a significant burden to our health system, and it is more so when young people develop arrhythmia. So arrhythmia leads to repeated hospital admissions, and it could be manifested underlying cardiac disease. It could lead to decompensated heart conditions, and arrhythmia sometimes cause sudden cardiac deaths. And remember that arrhythmias runs in family. So what are the management implications? So the first we need to highlight is that we have to establish the rhythm ECG correlation or symptoms ECG correlation, and then we have to make sure that there's no structural or electrical abnormality. And thirdly, we need to reduce or eliminate the probability of having another episode. And fourthly, we need to reduce or eliminate the probability of dying suddenly as a result of the arrhythmia kicks in. And we have to manage them in such a way that it will not limit the ability to live a normal life that includes sports participation, recreational activity, and undergoing pregnancy. So what are our management goals in the acute setup? If a person presented with abnormal rhythms, we have to restore the sinus rhythm for a meaningful duration to alleviate symptoms. And if the patient is hemodynamically unstable, we have to follow the resuscitation guidelines. You could do the cardioversion or defibrillation or transcutaneous or transvenous pacing for a bradyarrhythmia. If the rhythm is stable, we have to get this idea that we need to restore. It could be a VT, it could be an SVT, it could be atrial fibrillation. We have to restore the normal rhythm by the least invasive method. That includes pharmacological treatment, anti-tachycardia pacing, DC cardioversion, and left stellate ganglion block in case of having recurrent VTs. And we have to make sure that we correct the underlying biochemical hormonal abnormalities or remove toxin, and we may have to unload the heart, control the volume overload status. And if we take heart rhythm issues and looking at the long-term management, here are our goals. We have to offer them a tachycardia suppressive treatment that includes pharmacotherapy, and we have to actively evaluate them for the suitability for catheter ablations. And we have to consider offering them cardiac electronic implantable devices that includes bradycardia and tachycardia. Don't forget about the anticoagulation, and we have to make sure that we treat the underlying condition in order to minimize the cardiac damage. So comprehensive history taking is very important, and these slides are self-explanatory. And it's very important to, if you are lucky, you have the ECG with you. Sometimes they presented sometime after having the symptoms, and the ECG at the time you do may not have obvious abnormalities. But you need to read between lines and look ECG carefully and methodically in order to find these type of abnormalities. Make sure that your patients get the necessary imaging in the form of echocardiogram or cardiac MRI scans or CT scans, and that will enhance our understanding, and that will enhance our way of treating these patients. and make sure that genetic and family screen should be offered to these patients as well. So why do we need to sort an electrophysiologist? Because each individual patient with rhythm issues require very personalized evaluation and treatment. And remember that we live in an era where personalized practice of medicine is now becoming the norm. So as an electrophysiologist, we can offer you comprehensive heart rhythm evaluation for your patients, and we can provide catheter ablations and necessary pharmacotherapy, and we can assess this patient for the risk of sudden cardiac death, and we can offer various type of cardiac electronic implantment device therapy, and if it come to that, we can give you inputs to manage special situations such as sports participation, pregnancy, and family screening. So electrophysiological study is a study that is a minimally invasive procedure using catheter introduced through either veins or arteries to record the electrical activity from within the heart. And that is what we do in the cath lab. So electrophysiological study help us to determine the nature of the tachycardia in its pathophysiological nature, and thereby helping us to treat these patients. And this is what we do. We put catheters through the groin, and catheters are placed at various locations inside the heart, gathering information. We can test the cardiac electrical activity, the system, and we can find the abnormal areas, abnormal connections, and then we can treat. As you can see, this is an important slide. I want to highlight that ablations offer very promising results. If you take focal atrial tachyarrhythmia, atrial flutters, AV nati, all these tachycardias basically can be completely cured by doing an ablation. So the hallmark of this presentation to give you an idea that your patients require more than giving a beta blocker or a calcium channel blocker or amiodarone. And heart rhythm management, as in electrophysiology, we can offer a lots of treatment and inputs to manage your patients and make them feel better and safe. So wrapping up the presentation, in summary, we have arrhythmias in young people could be due to various causes, and most commonly these arrhythmia present as briefly or sustained palpitation or transient loss of consciousness, and very rarely it could be a early manifestation or precursor to that can cause sudden cardiac death in time to come. That is something we have to remember. And arrhythmia in young people means it's not a uniform group. It is a group with heterogeneous subgroups in it. And focus history taking is the key, and do a thorough examination and plan your investigations. And careful assessment of both tachycardia and non-tachycardia is very important. And it's important for us to establish the symptom ECG correlation. Is sometimes long-term and ambulatory rhythm monitoring is required. Cardiac structural assessment can be done with MRI and 2D echo. And most arrhythmias can be treated effectively with minimal invasive approach. And we can offer you cardiac implantable devices and catheter ablations for these patients, and in order to reduce the symptoms burden, and at best we can cure them and prevent them dying suddenly and improve quality of life. Thank you for listening.
Thank you very much, Dr. Kirti Divulheva. That's a very comprehensive overview of a common topic. And we'll move to the next topic. Our next speaker is Dr. Vajra Senaratne. He is known to all of us. He doesn't need any introduction. He is going to talk to us about interventional cardiology, current and future perspectives of Sri Lanka. Over to Dr. Vajra Senaratne.
Good morning. First of all, I must thank the President and the Council members of Galle Medical Association for making me a part of this important clinical meeting. The topic today is interventional cardiology, the current and future perspectives in Sri Lanka. You all know when you go back to the history about 3 decades ago, our cardiology care in Sri Lanka was in a very primitive state. The first cath lab was introduced in 1989, and afterwards, for the last 3 decades, there have been so many cath labs started in Sri Lanka at various places. For instance, Galle, Kandy, Kurunegala, Anuradhapura, Jaffna, Polonnaruwa, and recently at Kalutara. With this, the cardiac care was dramatically improved in Sri Lanka, particularly for the chronic patients. I'm going to discuss on the following headings the therapeutic strategies in cardiovascular interventions. First is intervention management of chronic coronary syndromes, which is earlier told as stable angina, and then acute coronary syndromes. And management of complex coronary cases such as left main disease, undilatable and calcified lesions, chronic total occlusions, CTOs, and novel techniques used for improved outcomes in coronary interventions, such as coronary physiology and coronary imaging. And lastly, the structural and valve interventions, valvular heart disease and congenital heart disease interventions. First, I would like to discuss the most common problem, the coronary disease. That is 2 categories we call chronic coronary syndrome and the acute coronary syndrome. You know, the coronary plaque due to atherosclerosis gradually develop over a period of time. And when it becomes about 70% or so narrowed, you can develop angina. And then when there's a plaque rupture, you can end up with the acute coronary syndrome. So basically, chronic coronary syndrome and acute coronary syndrome are part of the same process, which is a dynamic process. Sometimes chronic coronary syndrome becomes acute coronary syndrome due to plaque rupture. And then when the plaque is settled after a few months or so, then it becomes chronic coronary syndromes. So management depends on which situation with the patient, the chronic coronary syndrome or acute coronary syndrome. Usually the management was angina was optimal medical therapy with lifestyle modification. With the introduction of cath labs, the interventional therapy became a major part of management of coronary syndromes. Most of the time, we do angiograms, invasive angiogram in patients with symptomatic patients who are high-risk patients, or when you try with medical management with failed optimal medical therapy. And all these patients are basically treated with statins, antiplatelets, beta blockers, and ACE inhibitors, etc. And there was a study which wanted to find out in stable patients with at least moderate ischemia, does catheterization and revascularization improve outcomes when added to OMT therapy? That is called ischemia trial. They randomized study for the invasive strategy with optimal medical therapy with conservative strategy with optimal medical therapy alone. Of course, they excluded high-risk patients like left main disease more than 50%, ejection fraction less than 35%, EGFR less than 30%, acute coronary syndrome within 2 months, and valvular disease. So all the risk factors were included in this study. But the primary outcomes such as cardiovascular death, MI hospitalization, and for unstable angina and heart failure, all these outcomes, there was no big difference over a 5-year period of time with conservative versus invasive therapy. And particularly when you look at all cause, there was no signal at all. So what is the difference between the invasive versus medical therapy? That was the conclusion is ischemia trial. Patient with stable coronary disease with moderate to severe ischemia had significant durable improvements in angina control and quality of life with an invasive strategy if they had angina. In patients without angina, an invasive strategy led to minimal symptom or quality of life benefits as compared to conservative. That means most of the patients stable coronary disease. If there are no symptoms, the benefit of invasive therapy has no major value. But you remember, the quality of life is very important. The young working person who has angina, the quality of life is deteriorated and they can't perform. So death is not only matters, the quality of life is important. So invasive therapy helps them a lot to keep good quality of life with angina-free status. So you have to remember that angina baseline invasive strategy is better. With no angina baseline, no difference between invasive and conservative therapy. That's the basic conclusion from this trial. I'll move to the acute coronary syndrome. There are these patients, as I told you, they develop after coronary plaque rupture, develop thrombus, and gradually occlusive vessel. The patient may have typical signs of angina. There's tightening, severe chest pain, which lasts for half an hour or more, which is pain over transverse neck, jaws, and back of the chest. And they can ECG might show ST depression or ST elevation. There is ST elevation with acute ST elevation in mind. So you do troponin. If the troponins are negative, pain is rather atypical. That we of course rule out MI. But the patients who have got suggestive pain, positive ECG changes with positive troponin, depending on the ST elevation or depression, labeled as acute ST elevation MI or non-ST elevation MI. So management depends on whether there's ST elevation or not. So look at non-ST elevation myocardial infarction and when to intervene. This is by EAC guideline 2020. This clearly shows there are 3 categories of patients depending on the clinical the risk category. There's a category score we have called GRADE score, which you can calculate and decide about the high risk patient. Patients particularly with high risk are the hemodynamic instability, cardiac shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complication, and ST segment more than 1 millimeter over more than over 6 leads. And these patients are high-risk patients. If you don't intervene, they may end up with disaster. Therefore, those patients should have invasive management within 2 hours. So those are very high-risk patients. Another category of high risk, which you get with GRADE score more than 140. And those patients also have a non-STEMI, dynamic ECG changes, or maybe results in a cardiac arrest. And GRADE score more than 140, those are high-risk patients. They should be taken to cath lab within 24 hours. The other group is low-risk patients where you don't have these high-risk features. Those could be managed in a ward and necessary like stress test, ECG, CT, whatever it is, and then you can manage them. You can take your time and manage. So the most important thing, assess the risk of this patient and act accordingly. The next, GRADE score, you have so many parameters to decide: the age, heart rhythm, systolic pressure, heart failure, future lip glass, creatinine, accessible deviation, so on. And if they have GRADE score more than 150, is considered high risk and to be done within 24 hours. Then I move to acute ST elevation MI. These are the patients, as I told you, get severe chest pain, ongoing chest pain. And the patient, if they come to the PCI center, those patients should be done according to the EAC guideline within 10 minutes, and ST elevation, they should directly direct to the cath lab for primary PCI. You should not go, they should bypass the CCU and all that, directly go to cath lab. Patient comes to the non-PCI hospital, you have to decide what is better, whether thrombolytic therapy or primary PCI. But if you assess the patient's time to reperfuse the artery is more than 1 to 2 minutes, they should be as soon as they should be given thrombolysis therapy and then manage accordingly. So if you feel that you could open up this artery by transferring to cath center, within 120 minutes, the patient should be transferred to the cath center for primary PCI. Now, all this factors depend on the time. If you get a patient within 3 hours, a primary PCI and primary both are very good study because the thrombus burn is less. Even fibrinolysis is also good. But what happens is fibrinolysis only you clear the thrombus, but the plaque remains there, so you might have to re-intervene. But patient comes after 3 to 12 hours period. Still, primary PCI is the best management strategy. But if you can't transfer the patient within 120 minutes, then you should be given thrombolysis. What happens if the patient comes late, 12 to 48 hours? essentially there would be thrombolysis management, only primary PCI. If the patient, even after 48 hours, if the patient has ongoing chest pain, hemodynamic stability, or arrhythmia, they should be taken for primary PCI. But if the patient is stable after 48 hours, routine PCI is contraindicated. That is 3A. That is, by doing that, you may do more harm than good to the patient. Therefore, after 48 hours, you should not attempt unless the patient is unstable. I would like to show you a case I've done, acute constitutional multivessel disease. This is a patient, 64 years old man with acute ST elevation MI with ongoing chest pain. And he has family history, but no diabetes, hypertension, or smoking. His hemodynamic was stable, pressures were normal, heart pulse rate is about 48. And if you look at the angiogram, you see he has a small circumflex and a huge bifurcating ramus, which has about 90% lesion. And second picture, you can see the LAD is totally occluded at the origin. You can see from this pointer, it is totally occluded. And again, you can see the right coronary artery has critical narrowing in the mid-segment. So the management, this is a 64-year-old man with no diabetes, acute ST elevation MI with ongoing chest pain, critical three-vessel disease with acute LAD occlusion or at the LAD ostium. What are the treatment? Obviously, medical management for health. So you could do either urgent CBG or primary PCI. You know, urgent CBG, it takes time to arrange patient. It might take few hours. By that time, there should be myocardial damage. So it is not the best option for such patient. Therefore, we should try and open up these arteries with primary PCI. See, this is what we have done. We have put the guiding catheter, pass a wire through the lesion, cross the lesion, and just passing the wire, you can see the vessel is open. The LAD is fully open. That is the most important artery in the system. Then what you do is you do balloon, and then you can see flow is much better. Then you do the stenting, and see the LAD is fully open nicely with TB3 flow. Now we have to do something for the ramus. We are putting another stent to the, it's called a bifurcation stent. We call tap technique. I don't have to liberate on this at the moment, but there's a technique we used routinely for this sort of bifurcation. And we do trap stent into ramus while keeping the balloon in a LAD. And you see the result. So this is before PCI. This is after PCI. So we have established flow in LAD, which is totally occluded, and ramus within half an hour or so. So then the patient is stable. Now what are we going to do the right coronary artery? We don't have to do all this in the same time. We can wait till the patient is stabilized. So we form it about after 48 hours later, we step to the right coronary artery, and that is a result. So this is a patient with acute anterior MI with severe three-vessel disease. What is the evidence to do all this at one sitting? This is the latest trial, complete revascularization in ST MI. That trial shows that published in NEJM October 19. That shows they studied 4,000 patients. The culprit only, complete only, or multivessel disintervention, and that clearly showed culprit only versus complete revascularization has a significant benefit with regard to cardiovascular death and MI. The p-value is 0.004, very significant. So acute estimation MI, you have to do the complete revascularization, not necessarily at the outset. You may do it before discharge or maybe a little later, but complete revascularization definitely beneficial than handling all the culprit lesion. And what to do when you have a cardiogenic shock with acute MI? The latest guideline says if you have a cardiac shock, you have to handle only the culprit vessel. If you do other vessels, the risks are higher. This is a 2018 ESC guideline that clearly shows routine revascularization non-infarct lesions should be considered in all patients with multivessel disease before hospital discharge. That is level A, 2A level evidence. And cardiogenic patient doing all three vessels is contraindicated because it carries higher mortality. Now I would like to show a patient who has come a little late. There's a large thrombus. The left system is totally normal. You see the right coronary artery has total block at the distal RCA. What we do with there's thrombus, we do a thing called use aspirate catheter. You can see the wire cross the lesion. Then you used I don't know. You can see this is the one called the dot that is called export catheter. You try to aspirate the clot with the export catheter, and after aspiration, you can see the result is better. But you can see large thrombus burden sitting in the distal right coronary artery. What you do is this is an exceptional case which cannot be there should be done only by experienced person. Deep throated the right coronary artery catheter to the lesion and aspirate the clot. You can see the amount of clot we aspirate, large thrombus burden. And after that, you put the stent, and then you can see the result. Wonderful result, superb result, almost normal after removing the clot and stent. And I will have to move to complex coronary interventions. Left main coronary artery. The left main coronary artery was basically a surgeon's territory all these years. We started, if you look at the guideline, you see left main disease with low CT score. That is the way you can assess the coronary artery structure. And if CT score is less than 22, the class 1A, both for surgery and PCI. So left main is not only a surgery, if there's class 1A indication for interventions with the CT score less than 22. The patient between 22 to 32, it is two-way indication. Surgery is still better there, but still PCI has a place two-way. But if the CT score is more than 30, it's essentially surgical because PCI is contraindicated in the situation. So you have to decide which patient you are going to do. You have to evaluate the patient before embarking on intervention. This is a patient, I did the first case done in Sri Lanka's left main. I did in 2003 or so. This is a 35-year-old lady presented with class 3 angina with normal LV function. You see the angiogram, I don't know, you can notice there's a critical ostial narrowing, almost 99% ostial narrowing. Those days it was essentially surgical patient. Now see what we have done. We have put the guiding catheter and you can see the degree of problem. We have a pass of wire and you balloon the left main, and after dilatation you can see it's better. Next you position the stent and then you deploy the stent. And post dilatation you can see wonderful results. So it's become day to day. I mean, you're doing a lot of more complex lesions now, not ostial mid shaft bifurcation lesion. That is part and parcel of our day to day practice, and that is with evidence from ESC and European ACC guidelines. The rote ablation, which is a complex coronary intervention when there's calcified coronary artery. You know, calcium is the enemy of the intervention. But when a patient like this comes, this is a patient who has got totally normal left system with right coronary artery, two critical lesions with heavy calcification. But my colleagues attempted to cross and he could not pass the balloon. That's why he referred the patient to me for rote ablation. So what happened, this calcium spicules jutting into the lumen. Therefore, we can't pass balloons or stent. Therefore, if you don't have rota, you have to give up procedure or send the patient for surgery. See, this is the gadget. You have a diamond rota ablator. There's a burr has a diamond cutter, and it cuts clearly cuts to the calcium plaque and make it quite smooth. You can see this from picture. You can see the rota ablator. We use picking movements and gradually clear the lesion. You can see nicely it is clearing the calcium in the vessel. And then what we do is we put the stent. You can see the distal stent being implanted, the proximal stent. Now the whole vessel. Now you can see the difference. The lesions we were unable to cross with the balloon. Now we are stated with wonderful result thanks to the rotablator machine. I would like to put the complex coronary intervention, other one, chronic total occlusion. Somebody might ask why do you want to open up the coronary arteries when the total occluded patient is living normally? But in fact, you don't just open up artery unless you demonstrate the viability and symptoms. If the PET scan or the ischemia burden is more than 10% is considered high risk, therefore you have to open up. Is there evidence? Yes. The EuroCTO trial showed greater improvement of angina and quality of life with successful CTO interventions. And there are 25 session studies showed that a median follow-up of 3 years, successful CTO PCI was associated with 1, improved clinical outcomes in comparison with failed revascularization, including overall survival, angina burden, and requirement for CMH. And ideally needs demonstration of viability by non-invasive tests, because you can't just open up close till you demonstrate non-viability. However, it's tedious process, may carry higher risk. So you have to spend a lot of time, high radiation and contrast. So this will be done by a very experienced person. This is usually we do anticipate, but retrograde canalization not done. Actually, this is the first or second case done in here, Sri Lanka. Retrograde retrograde tracking. You can see the right coronary artery. There's a critical narrowing. It's totally up to right coronary artery. You take dual injection, but both sides, right and left, both. Then you can see a long segment is missing. So it's not fair to send only surgeon for bypass just to revascular right coronary artery. Therefore, CTO opening is very important. So we tried antegradely from the normal way it didn't cross. This is the way you go. You try to antegradely, it failed. Then you go through this collateral supply and enter and try to go through the reverse way. And this is angio showing. You can see the nice collaterals connected to the retrograde fitting of the distal RCA. What we do is, you can see we have passed a wire directly with the help of microcatheter, go through the collaterals trying to enter right ostia. Here you can see the wire almost enter in the right coronary artery. So there's a nice loop. Now we can go through the, again, right coronary artery this way and balloon it and deploy the stent, first stent, and deploy the second stent. And you can see the result after PCI. So this sort of patient, if they need for bypass, which is not fair. So I think we should be able to open up by way of either antegrade or retrograde crossing. I would like to discuss then move to the next topic, novel techniques for improved outcomes in coronary intervention. There's physiological measurement such as FFR and IFR and coronary imaging. For physiology, FFR is fractional flow reserve. The FFR considered the gold standard measure to evaluate the clinical signal consolidation. And there are 2 trials, FAME 1 and 2, that have shown that patients with stable angina, when the FFR is less, for instance, how do you calculate? If you assume the pressure is at the altitude is 100, if drops to 80 or less, then it's not signal. But if it drops to 79 or more, that indicates that's a clinically signal lesion which should be revascularized. And now FAME trial also showed that patients with multivessel disease, FFR guided PCI is superior to angiography guided PCI, because you won't make any mistakes by doing that. You only revascularize the only necessary vessel, not unnecessary vessels. If there is evidence here, there's class 1 evidence of using FFR to do these procedures, then either multivessel 2A and other. Anyhow, there's one indication using MFR. This is a patient who has got critical narrowing of right coronary artery plus tight lesion in the middle lady and proximal big diameter. So if you don't have FFR of this, I would have stated RCA, LAD, and D1, all three vessels, if you go by angiography. But here we have done FFR. You can see right from the tight lesion, FFR has come to 73. That is highly significant. We have done the PCI to RCA. You can see post of PFFR come up to 90. That is almost normal. So that gives a very clear picture that we have done the correction. Now you move to the other side. This is the vessel. You have the put FFR wire to the diagonal. You can see the FFR value is 81. So that is not very significant. So you don't have to do a state. You can manage the diagonal with medical management. Now you move to the LAD. You can see LAD FFR is 72. And we did the PCI and it has come to 94. So this gives a very good scientific idea as to how you handle how many vessels to be stented. Then you minimize the stenting. Sometimes the patient you send for 3 vessel disease for bypass. If you do FFR, it might become a single vessel disease. Therefore, these tools are there to optimize the outcomes. Then I like to move to the coronary imaging, intravascular ultrasound, IVUS. This is the IVUS catheter. You pass through the coronary guide wire. You can very clearly see this picture. You can evaluate the length of the lesion, the quality of the lesion, the plaque. You can the disease vessel. You can see the plaques, fluid in the narrow lumen, and you can see there are the thrombus. When there are flaps causing a false lumen and a true lumen dissection, and you can see the amount of calcification, this hypogogenic. So this is very useful in managing this patient. You can get a very accurate sizing of the vessel. You should know how to, whether you have the correct lumen or not, or whether you have a lot of calcium. Then you know what equipments to use rather than just trying to balloon this. You can't open this with balloons. And I would like to show this picture. This is a live picture showing normal anatomy. Now, when we turn toward the left main, you can see the plaques appearing here gradually. And coming down, you see the very, very narrowed vessel with plaque. So we know exactly what the amount of narrowing, and you can measure the length. So by using IVUS, you can really assess the patient. And particularly if you're dealing with left main, IVUS is very important because you can precisely position the stent and also get the optimum dilatation by using IVUS. The structural valvular interventions, I don't have to elaborate this. The VST one we have done some time ago. You can nicely close the VST. You can see the VST has closed completely. And AST also we nicely put to S device. And once you release the device, it is fully closed. So these have been done large numbers in Sri Lanka now. We do most of the ASTs, so still secondary ASTs, and muscular and peripheral VSTs with device closures. And the last topic I'm going to discuss is valvular interventions. The transcatheter aortic valve implantation. TAVI is very popular at the moment. Unfortunately, Sri Lanka, because of course we can't do many cases, these are really expensive at the moment. But there have been few cases done in Sri Lanka. The surgical aortic valve replacement versus TAVI. You see the patient with lower risk, young age, and patient having, say, a sort of suspected endocarditis, whether you have access site problems or coexisting valve disease, you have to send the patient for surgical valve replacement. But the patient with higher surgical risk, such as elderly patients, the previous cardiac surgery, or severely frail patient, you should attempt TAVI, that is percutaneous valve intervention. So, surgical AV, I recommend a younger patient who are low risk for surgery with low uroscope. This is ESC 2021 1B indication. TAVI is recommended in all the patients more than 75 years or those in higher risk. Uroscope more than 8 or unsuitable for surgery, that is 1A. So this is a TAVI 1A indication. So with time, I think we should be able to do more and more cases. And their future directions. The intervention of cardiology is a rapidly developing field. The percutaneous structure intervention will be foremost in the pipeline, such as mitral replacement. These are all percutaneous. Tricuspid replacement, pulmonary vein implantation, and nail appendage closure. Vascular intervention, including venous intervention, is coming in a big way. The cost effectiveness with time will make this available to Sri Lanka as well. So we have to wait till the cost comes down. And the future of cardiovascular care will be transformed by advances in digital health technology and mobile devices. Thank you very much.
Thank you very much, Dr. Rajesh. We move the third speaker. Dr. W. Santaraj will be speaking to us on treatment of chronic heart failure. Dr. Santaraj is a senior cardiologist. May we move on to the third speaker, senior cardiologist, Dr. Santaraj. He will speak to us on treatment of chronic heart failure.
Thank you. First, I thank the Gaul Medical Society for inviting me to give this lecture on treatment of chronic heart failure. Heart failure is a highly prevalent condition. Over 60 million people worldwide have heart failure. It's associated with high rates of morbidity and mortality. It poses a significant strain on the healthcare system. And it's the #1 reason for admission to hospitals over 60 years of old. Heart failure can be divided into three groups. Those are heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. All three groups will have signs and symptoms of heart failure. And for the reduced ejection fraction group, the ejection fraction should be less than 40%. And the mildly reduced ejection fraction group, 41 to 49%. And the preserved ejection fraction, of course, the ejection fraction will be more than 50% by echocardiogram or other imaging modalities assessment. The preserved ejection fraction group should also have objective evidence of diastolic dysfunction, and also you should be able to demonstrate by echocardiographically or invasive method raised left ventricular filling pressures, including raised natriuretic peptides. There are several causes of heart failure, but coronary artery disease, valvular disease, hypertension, and dilated cardiomyopathies are the common problems we face in clinical practice. Clinical features: dyspnea, swelling of body or legs, loss of appetite, lethargy. Symptoms can be acute or chronic onset. Past history of cardiac illness may or may not be present. Edema, dyspnea, raised JVP, cardiomegaly, third heart sound, gallop rhythm, basal crackles, all should be looked for when you are assessing a patient clinically with heart failure. So this is the algorithm. In a suspected heart failure with symptoms and signs suggestive of heart failure, if they have an abnormal ECG, then of course you can go in two ways. That is, you can straight away go and do a BNP level, natriuretic peptide level, or go for an echocardiogram. In our country, of course, getting an echocardiography is done is easier than do a natriuretic peptide because it's not widely available. So the echocardiography is the mode to go in our setup. If the echocardiography shows abnormal findings, then you have to categorize these patients into whether they falls into a reduced ejection fraction, mildly reduced ejection fraction, or a preserved ejection fraction group. And depending on that, then you can go for the etiology and commencement of the treatment. If there is no echocardiographic findings and the natriuretic peptides are normal, the heart failure is very unlikely. You have to consider other diagnoses. Assessment, all the patients with heart failure should be assessed hemodynamically, the blood pressure, then pulse, fluid balance, renal functions, weight, full blood count, ECG, chest X-ray, and any other appropriate investigation like thyroid function and cardiac enzyme should be done. Objective of treating heart failure patient include relief of symptom, look for precipitating factors, improve long-term prognosis, identifying and treating the cause of heart failure, and management of end-stage heart failure. Common precipitating factors are anemia, infection, medications like non-steroidal anti-inflammatory drugs, arrhythmia, excessive salt consumption, ischemic heart disease, acute coronary syndrome, endocrine abnormalities. If you find any of those should be treated promptly to treat the underlying heart failure. The drug treatment wise, the medications can be divided into two broad categories. The first group is the medication that can reduce the chance of mortality in heart failure with reduced ejection fraction patients. The group 1 include the AC inhibitors, ARP blockers, and the new ARNI group, that is an angiotensin receptor neprilysin inhibitor group. The only drug available is sacubitril valsartan combination. And the group 2 is the beta blockers, carvedilol, bisoprolol, metoprolol, or nebivolol are approved for use in heart failure patients. The group 3 is a mineralocorticoid receptor antagonist, spironolactone, or eplerenone. Group 4 is the new SGLT2 inhibitors, which are used for treatment of diabetes mellitus, now approved to use in heart failure patients with or without diabetes. The empagliflozin and dapagliflozin can be used in that group. The medication for symptomatic relief are diuretics. You can use either furosemide, bumetanide type of diuretics. Those are loop diuretics, vasodilators, or oral inotropes like digoxin. The heart rate lowering agents like ivabradine can be useful in patients who have tachycardia despite proper beta blockade. Diuretics are excellent medications for relieving symptoms and edema. Doses should be titrated according to the individual need. IV loop diuretics can be helpful in patients with severe heart failure and those who have gut edema and absorption problems. Diuretic should be reduced when the symptoms and the signs of heart failure subside and the patient become euvolemic. That's the best time to start the AC inhibitors and increase the doses of AC inhibitors. Loop and thiazide diuretics can never be shown to improve the long-term prognosis of heart failure. In refractory heart failure, you can use combination of diuretics, a loop, and a thiazide type of diuretic to achieve the diuresis. When you take the AC inhibitors and ARB blockers, our group 1 drugs, the studies and the clinical trials have shown these drugs are very effective in treating heart failure and the risk reduction. When you are comparing with the placebo, AC inhibitors showed about 30 to 40% risk reduction in several studies. You can see there are several studies tabulated here. And similarly, few studies have shown with ARB blockers 30% risk reduction, and the new ARNIs, that is the angiotensin receptor and neprilysin inhibitor group has a 20% risk reduction in addition to what you get with ACE inhibitors or ARB blockade in heart failure. That's the reason now this medication has become a first-line drug in treatment of heart failure. The Paradigm heart failure trial is the one showed that when you're comparing with ARNI with ACE inhibitor enalapril, there is almost a 20% risk reduction on top of the advantages you get with ACE inhibitor enalapril. Beta blockade, there are three big trials: the Copernicus with carvedilol, Merit FM with metoprolol, and the CBs with bisoprolol, all shown about 30% risk reduction when you use in heart failure patients. The similar way, the mineralocorticoid antagonists, spironolactone and eplerenone showed about 15 to 35% risk reduction in RAILS, FSS, and emphasis trials in different settings. So when you combine these drugs, you can get, rather than using individually, when you combine these drugs, you get additive effect in heart failure. You can see either you can combine ACE inhibitor beta blocker or MRA, or ARNI beta blocker MRA, and get maximum benefits for your patients. The SHIFT trial, which has been shown here, is done with the ivabradine, the heart rate lowering agent. This is used in patients with maximally treated heart failure, patient with all medication mentioned above, and those who are on maximum tolerable dose of beta blockers. Still, if their heart rate is more than 70, then they use ivabradine, and they have shown cardiovascular mortality or heart failure hospitalization is reduced 14 to 17% in these patients. So if any person who have on a beta blockade, if you can't achieve a heart rate of 70, then you can add these medications. With the FDA requirement of all new anti-diabetic agents should undergo a cardiovascular risk trial, they have performed these cardiovascular risk trials in the new anti-diabetic agents. So the two agents, dapagliflozin, empagliflozin, there are more new agents now. And these were studied for cardiovascular risk in their original trials. And interestingly, they noted the cardiovascular death and hospitalization for heart failure, first hospitalization for heart failure, and renal composite endpoint, these three were significantly reduced in patients who were receiving these agents. Hospitalization heart failure is almost 25% reduced in the original trials. That led to the trials on heart failure with these drugs, those who are with diabetes and without diabetes. And those are the two major trials, DAPA heart failure trial and EMPEROR reduced trial. You can see cardiovascular death or hospitalization for heart failure is almost reduced to 25%. And the first hospitalization heart failure again, about 30 to 30% reduction. And you can see the renal composite endpoint. The renal problems are common in heart failure patients. That is reduced to almost 30 to 50%. So it's very advantageous medications using to use in heart failure patients in clinical settings. And you can see in the EMPEROR reduced trial, the benefits started occurring in the day 12 of starting the medication, and it reached the significant level in day 34. So it's almost within 1 month, you can get a significant reduction in cardiovascular risk if you use these agents. What are the advantages of using the new heart failure medications, the SGLT2 inhibitors and ARNI? The SGLT2 inhibitors, they decrease the risk of hyperkalemia. So the most of the heart failure medications like ACE inhibitors, ARB blockers, mineralocorticoid receptor antagonists, all increase the risk of potassium. So when comparing the combination with this medication, it decreases the hyperkalemia. That is one of the important action of SGLT2 inhibitors. It also slows the progression of renal dysfunction. It has been shown clearly in the clinical trials. And so you can increase the ACE inhibitors, ARB blockers, ANI, or MRA whenever it's needed. It has minimum effect on heart blood pressure and symptomatic hypotension in patients with heart failure. When you take the ANI, the angiotensin receptor neprilysin inhibitor, when you compare with ACE inhibitors and ARB blockers, it causes less hyperkalemia. So that's the advantage of this drug. In addition to the additional benefit it has above ACE inhibitor and ARB blockers. So what is the recent guidelines say? The ACE inhibitors, beta blockers, mineralocorticoid receptor antibodies, SGLT2 inhibitors are all class 1A indication for treatment of heart failure. Sacubitril valsartan, the ARNI, is placed in 1B because it has only one clinical trial which has shown clinical benefits. Other pharmacological treatment, as I mentioned, the diuretics should be used in congested patients and to improve the heart symptoms, improve the exercise capacity, and reduce the heart failure hospitalization. The ARB blockers are shifted into a 1B category. That is because ACE inhibitors are the first line medication to use in heart failure patients. But if the patient is ACE inhibitor intolerance, then of course, ARNI is the best alternative because it has an ARB blocker and neprilysin inhibitor, and it is more advantageous than the using ARB blocker for replacement. But this drug is not widely available in Sri Lanka, but in future, I think when ACE inhibitors are intolerant in patients with heart failure, the ARNI will become the recommended drug. Other pharmacological agents, the ivabradine, as I told you earlier, you can use if the heart rate is more than 70, despite the treatment with evidence-based treatment with beta blocker. Ivabradine also can be used in patients with contraindication to use beta blockers, like in bronchial asthma. When you come to heart failure with mildly reduced ejection fraction, the clinical trials are very less in, there are no clinical trials performed. There are several clinical trials performed in this group, but the treatment-wise, these patients should be treated as a patient with reduced ejection fraction patient. That's what the diuretics, ACE inhibitors, ARB blockers, beta blockers, MRA, and ARNI can be used, but the level of evidence is not very good because there are not very many trials to demonstrate the advantage. So when you use medication, if the patients are very symptomatic, you can consider device therapy. This is called cardiac resynchronization therapy. Who are the people who are eligible to get a cardiac resynchronization therapy? They should be in sinus rhythm. Those who have wide QRS complex, likely left bundle branch block, and severe systolic dysfunction, like ejection fraction less than 35%, and persistent moderate to severe heart failure despite optimal medical therapy. And it has been shown that you can get about another 30% risk reduction if you use cardiac resynchronization therapy. So in summary, if you take the chronic heart failure treatment, the ACE inhibitors, ARNI, beta blockers, MRA, and SGLT2 inhibitors are the 4 cornerstones of treatment of heart failure in reduced ejection fraction. These drugs should be started early as possible when the patient hospitalized or in an outpatient setup. And if the patient is congested, you have to start with the diuretics. Once they become evolemic, you must start these drugs concurrently. I think the best is to start with the SGLT2 inhibitors because they have the diuretic action, and you can come down on the diuretic dose when you start the SGLT inhibitors with diuretics. Then you can start on ACE inhibitors, beta blockers, and MRA on consequently. And associated conditions you have to be deal with, that is the patient, if the patient is symptomatic despite the medical treatment, if they have white QRS complex, you can consider the cardiac resynchronization therapy. And also if they have ischemic etiology and if they are prone to get arrhythmias or life-threatening arrhythmias, then of course you have to consider intracardiac defibrillator. Associated conditions like atrial fibrillation, the patient should be prescribed anticoagulation. And to control the heart rate, you can use digoxin, beta blockers, or if atrial fibrillation is a real problem in treating heart failure because of the AV synchronicity, you can use pulmonary venous isolation to get rid of atrial fibrillation. If they have significant coronary artery disease, you have to consider sending them for coronary artery bypass surgery. And the iron deficiency is fairly common in patients with heart failure, and they should be treated with IV ferric carboxymaltase. If they have aortic stenosis, you have to consider aortic valve replacement, or either by surgically or percutaneously. Mitral regurgitation should be treated with mitral valve repair or mitral valve replacement. If they have heart rate more than 70, you can use ivabradine. In black race, hydralazine and isosobide dinitrate can be considered. And if they are intolerant to both ACE inhibitors and ARNI, then you can use ARB blockers. For advanced heart failure patients, you have to consider using heart transplantation. It is, I think it has been performed in this country, but it's very rarely performed. And if that type of a person, you can consider mechanical circulatory support by devices to bridge the heart failure to do heart transplant. And also improve the quality of life of all the patients, exercise rehabilitation and multi-professional disease management like physiotherapists and nurses should be involved in the management of heart failure. A little bit about heart failure with preserved ejection fraction. They are usually obese, hypertensive, associated with atrial fibrillation. They have pulmonary hypertension. They are usually older, and they have, as I told you earlier, they have a high filling pressures, which can be demonstrated by echocardiography. With all these features, you can diagnose heart failure with preserved ejection fraction. And the treatment-wise, there is nothing much because we don't have a lot of evidence-based medications in treating this condition. The diuretics are the drugs which has been recommended to reduce the symptoms and signs. And you have to screen for the etiologies like cardiovascular comorbidities like hypertension, ischemic heart disease should be treated to reduce these conditions, treat these conditions. As my conclusion, the heart failure should be prevented if it is possible. So there are risk factors for heart failure, the treatment of hypertension, diabetes, lipidemia, and also ischemic heart disease is very important in early stages to reduce future heart failure. That is the stage 1, the high risk for with no symptoms heart failure patient. Those who have structural heart disease without symptoms, again, you must vigorously treat them to prevent future heart failure episodes. The stage 3 is the people who have one episode of heart failure, currently having symptoms of heart failure, should be prescribed all the evidence-based medication I have discussed in this lecture. And the stage D is refractory symptoms, those who are the end-stage heart failure patients. They may need inotrope, frequent hospital administration, and ventricular assisted devices and made transplantation. If they are not suitable for any of those, then of course you have to consider hospice treatment and support for this patient as an end of life care. Thank you very much for your thank you.
Thank you, Dr. Santaraj. We have a few minutes for questions. There have been 3 questions. If you look at the Q&A box, 2 have already been answered by the first speaker. May I direct this question to Dr. Santaraj from Dr. Vasanta Disanayaka. The emperor preserved mortality benefit of heart failure with preserved ejection fraction. What is the cutoff point of EGFR in non-diabetic CKD patients with HFpEF when using SGLT2 inhibitors? I hope the question is clear. It's typed in the Q&A box as well, Dr. Santaraj.
Yeah, I noticed that yeah, I didn't mention anything about the emperor reduced, the emperor preserved trial that actually it is presented in the recent ESC conference that shows that is the only drug, again, the SGLT2 inhibitor that showed some effect in the heart failure with preserved ejection fraction patients. But anyway, it's not marvelous. The risk reduction is about 10%, you see. So when you compare with other medications in the heart failure, reduced ejection fraction, the SGLT2 inhibitors cause more than 25% risk reduction. So anyway, these drugs, actually SGLT2 inhibitors will become part of the treatment in patients with heart failure with preserved ejection fraction in future, because those are the ones which have shown in this emperor preserved trial which is effective. Your question is, what is the cutoff point you can prescribe in this medication for patients with renal impairment? Because if you take the clinical trials, actually the emperor reduced trial, the cutoff point for EGFR was almost 20%, 20 ml. So it is very, very reduced ejection, the reduced EGFR. So the EGFR of 20 ml was used in emperor reduced trial. So I think these agents can be used well in patient with kidney, the renal impairment. And when you use these agents, actually what happened is like ACE inhibitors, initially there can be a reduction in the EGFR. But anyway, they get stabilized. When you continue this medication, actually their EGFR improves later. So you can give it a try in all the patients with renal impairment. You can, I think, start this medication in up to, as the trial evidence is there, we can use it from EGFR 20. And yeah, EGFR.
Thank you very much, Dr. Santaraj, for that answer. Then thank you very much from the first speaker as well, who has given detailed answers to the 2 previously asked questions. So in the absence of any further questions, may I take this opportunity to thank all 3 speakers for excellent erudite presentations, which were crystal clear, and for answering the questions also, so that no doubts are left in this area when we finish this session. Together with my co-chairperson, Dr. P.P. Sadanandan, I thank all of you as well as the attendees for participating in this session. Thank you very much.
Thank you. Thank you.
Thank you, co-chairpersons. Next in line, we have the 3rd plenary lecture. I take the pleasure of inviting the co-chairpersons for this session, Dr. Kalum Deshapriya, Consultant Rheumatologist, Teaching Hospital, Karapitiya, and Professor Sampath Gunawardana, Professor of Physiology, Faculty of Medicine, University of Ruhuna, to the head table.
Good morning. I welcome you all for the session 6, plenary lecture 3. In this plenary lecture, questions are not allowed. The plenary lecture is on the application of evidence-based dietary management in patients with irritable bowel syndrome. It will be delivered by Professor Peter Gibson. He is the Professor and Director of Gastroenterology, Monash University, and Alfred Health, Melbourne, Australia. Now it is over to you, Professor Peter Gibson.
Many thanks for the kind invitation to talk about evidence-based dietary management in patients with irritable bowel syndrome. When we look at the evidence for dietary strategies and look at the common dietary strategies that are used, the low FODMAP diet is the only one that has decent evidence to back it up, so I will talk about that. Now, the whole FODMAP concept was one whereby we had a lot of information in the past to say that if you had a large amount of fructose, large amount of fructans, galacto-oligosaccharides, sorbitol, for instance, that it would cause gut symptoms. But these amounts were much greater than what we would normally get in the diet. However, they all have a similar action. And if you add them all up, so 1 plus 1 plus 1 plus 1 plus 1 equals 5, you might get an effect from their combination. And in fact, there is evidence for that. So the idea was that if we wanted to improve people's symptoms, then reducing one would not really have much effect, which is what our clinical experience was. But if we reduce all of them, then we would get more bang for our buck, as the Americans would say. So the idea is that if we can reduce them all in people with irritable bowel and visceral hypersensitivity, then symptoms would improve. Now, one of the problems we met in starting these studies was that where were these FODMAPs? We had, first of all, to design a new term for these collectively, and that's where the FODMAP fermentable oligosaccharides, disaccharides, monosaccharides, and polyols came from. And we knew that they were present in many things: vegetables, fruits, dairy products, and cereals. So we undertook a long process, which is still ongoing, of measuring FODMAP contents of food to get in a big database of where these FODMAPs are. And you can see here on this slide, it shows that many foods have multiple FODMAPs in them. And then the next problem was what was high and what was low and what was moderate. And over years of experience and clinical trialing, we determined cutoff values for what is high and what is low. The next issue was getting this information out to people, and we couldn't publish papers on this because the journals don't accept papers just with lists of content. And so this is when the FODMAP University, the Monash University FODMAP Diet app was born, and this in its food guide has an updated, continuing updated list of all the foods that have been tested. So the FODMAP dietary program that was designed was one in which we first of all avoided all foods high in FODMAPs and replaced them with foods low in FODMAPs in each group. This would proceed for 2 to 6 weeks, depending upon convenience more than anything. And then if there was no benefit, you would stop the diet. If there was efficacy, if there was amelioration of symptoms, we would then go on to a phase 2 or reintroduction phase where the tolerance to individual FODMAPs and the amount of FODMAPs people can tolerate can be determined. And then that leads to a phase 3, which is the personalised or maintenance diet, which is informed by the phase 2 information. All of this has in our hands and in most studies have been dietitian delivered. Now, the idea of the program is, if you look at this stylized diagram, the FODMAP intake is on the y-axis and time on the x-axis. Gut symptoms are shown in red, so that the symptoms are reduced when you reduce your FODMAPs. Then you have this reintroduction phase in which some FODMAPs are found to be quite a problem in the individual. And then you go to the personalisation where the FODMAP intake is nowhere near as low as it was in the first phase, and the symptoms continue to be improved. Well, does this work? Well, the first phase is very amenable to randomised controlled trials with certain difficulties. The problem of the comparator diet is always there, but these are the early studies which really put FODMAP diet on the map. The first one was the pivotal feeding study that Emma Halmos and our group performed, and it showed that the low FODMAP diet had much fewer symptoms in patients with IBS than a typical Australian FODMAP diet. They followed studies from Canada versus a high FODMAP diet, UK versus habitual diet, USA versus a modified NICE diet, and then an important study from UK versus a placebo diet, and all showed benefit of the diet. Now, there have been now 13 randomised controlled trials and 944 patients involved. The trials have not all been of the highest quality, but an attempt was made to put them all together and has just been published. This was done by a very good group of people who are extremely fastidious in how they do these meta-analyses. And what you would show, I'll just show you the information here about comparing it to other diets. The low FODMAP diet for global symptoms, as shown here, have significantly better than all of the other diets. And none of the other diets, such as the NICE diet, were of any significant value in the patients. And so they found that the low FODMAP diet ranked first for efficacy across all endpoint study compared with the alternative interventions. It was more efficacious than habitual diet for global IBS symptoms. And when you compare it with the NICE diet, it was more efficacious for abdominal bloating and distension. Well, the personalised phase of the diet is much more difficult to study by a randomised controlled trial. But there are now 8 published prospective studies with 3 to 44 months of follow-up, and more than 75% of patients who have responded to the initial phase 1 have been able to reintroduce FODMAPs and go on to this personalised phase. The total FODMAP intake is often normal or only marginally reduced, but patients no longer have the binge intake of a large amount of FODMAPs in certain meals. Overall sustained symptom response has been documented in 57 to 82%, depending on how that was assessed, and there's been no evidence of harm. Because of all these studies, the FODMAP diet is now established in guidelines in many places in the world, and some of them are outlined here. Well, you have a diet, but how do you optimally deliver the diet? It's different to a drug, where the drug is the drug, you give it, and that's it. Whereas a diet is much more difficult to deliver. There are 5 aspects that I think are important in optimally delivering the diet. One is to being aware of the risks of the diet. You have to select your patients appropriately. You have to use the 3-phase FODMAP strategy as I have outlined. You utilise a FODMAP-trained dietitian, and then you might want to consider value adding to the diet. So let's go through some of these aspects. The risks of instituting a FODMAP diet are common to all restrictive diets. Firstly, you don't want to exacerbate or precipitate disordered eating. You don't want to do the same for nutritional adequacy. There are psychosocial implications, and there are issues of when you're changing carbohydrate content, particularly of inducing a dysbiosis. But in fact, this has not been, the evidence for this is poor, and the studies so far that have shown that changes to microbiota are largely reversed with the personalisation diet. Now, I'd like to spend some time on, the risks are exacerbated by inadequate assessment prior to the institution of the diet, by poor teaching of the diet. And the other thing that I think is important just to mention is that linear thinking by either the doctor or the dietitian or the patient that the diet is the only part of management has to be avoided, and that diet is only one part of a multimodal integrated care for people with IBS. So I'd like to spend some time on this issue of disordered eating and eating disorders, as people get confused by it. Disordered eating is the irregular or maladaptive eating behaviours that may have nutritional or psychosocial implications, whereas eating disorders have severe and persistent disturbance of eating behaviours with clinically significant medical or psychosocial consequences. And you'll be familiar with the anorexia nervosa, which is driven by the fear of gaining weight. But the more recently described ARFID, or avoidance restrictive food intake disorder, is where there's an inability to meet appropriate nutritional needs, which is driven by picky eating, poor appetite, or concern about symptom induction by food. The other one, orthorexia nervosa, is a preoccupation with healthy eating habits by individuals' belief system as to what is healthy or unhealthy. Now, in IBS, actually determining the prevalence of these is quite difficult because screening tools are not validated in IBS, where more than 60% of people do actually modify their diet anyway. However, where the published data tell us that concerning eating behaviours occur very commonly, and they've been reported from 5 to 44%, and probably would say about 15% would be a reasonable ballpark figure. What is more disturbing is that there's a lack of awareness of disordered eating behaviours by gastroenterologists. In a study from Michigan, that 13% of patients attending a tertiary referral gastroenterology clinic actually had criteria fulfilling ARFID. 70% of those patients were sent by gastroenterologists for a FODMAP diet, and no recognition that there was disordered eating patterns were observed. So awareness was very poor in this otherwise very highly talented group. We don't know whether institution of a FODMAP diet precipitates an eating disorder, but we do know that restrictive diets are contraindicated in patients with disordered eating behaviours unless they have adequate psychological support and it's done very carefully. So who should we be offering a FODMAP education to? The person should have functional gut symptoms. It's not a diet for good health. We want them to be motivated by food choice, and they have to have sufficient FODMAPs in their habitual diet. Some people just avoid them. But where we should be worried is when someone has undernutrition, particularly disordered eating patterns, as I've mentioned, children where growth is very important and undernutrition is a key issue. And if there are other dietary restrictions or they're already nutritionally challenged, such as IBD, and if there's a poor capacity to apply the diet. And what we would say in these, we really need in these settings, a skilled dietitian and possibly a psychologist involved. And the all choices are to avoid the FODMAP diet, to use a psychologist, and to very carefully use the FODMAP diet, or to use what we've called FODMAP gentle, which is a variation of the FODMAP diet, although it hasn't been assessed in its efficacy other than in clinical practice. Can we predict who will respond to the diet, or more importantly, who will not respond to the diet? But unfortunately, predictive tests are being developed, but none are clinically useful at the moment. So what does a dietitian offer? We say we like using a dietitian, so what is special about the GI dietitian? Well, they are very important in assessing. They're skilled at assessing for disordered eating behaviours. They can assess nutritional and FODMAP intake of the patient, and they can assess the actual nutritional status of the patient. Therapeutically, they can advise on the suitability for dietary therapy, and our dietitians will tell us if this person is suitable or unsuitable. They ensure nutritional adequacy of any dietary change. They can take people through the 3 phases of the FODMAP diet with because they devote time to doing this and are skilled at doing it, and they can guide on practical issues like how to incorporate the diet into recipes, how to read labels, things which I don't think gastroenterologists are particularly skilled at. So what about a dietitian? Does the dietitian value add in the real world? Well, Carolyn Tuck, who trained with us and went to Canada for a postdoc, she retrospectively evaluated 80 patients when she arrived in Kingston, and 80 consecutive patients in their clinic. 24 of them saw a dietitian, and 56 of them did not. When she looked at the implementation of dietary phases, particularly in the phase 2 and phase 3, those who did not see a dietitian, shown in the light grey here, performed particularly poorly. They ate more FODMAPs according to a food frequency questionnaire. However, their symptom levels were similar. There was a lot who didn't really improve, but why were the symptoms similar when this group here were doing the FODMAP diet better than this group? Well, the reason was that this group here, who didn't see a dietitian, were using multiple other dietary changes as well as much greater use of medication. So this confirmed that the dietitian can actually make a difference. Well, what about using Dr. Google? Well, Dr. Google is very unreliable. FODMAP lists on the are often wrong, and the readability and quality of what's on Google, as well as the dietary advice for IBS, is really quite diverse and often quite against evidence base. Well, the problem in the real world is that we don't have access to FODMAP-trained dietitians everywhere. Well, what do we do? Well, where there are dietitians available, but they're not trained, we can invest in educating them. And I can tell you it is worthwhile. When dietitians are not available, perhaps the doctor can upskill or other health professionals can. And in some circumstances, nurses have been very good at learning delivery of the diet. And we can ask the patients to do online teaching or give them good information. But what I would not recommend is what I call the paper plane method, and that's throwing a piece of paper at the people and say, here, follow this diet. It's not a good technique. We have invested in trying to help with this education, and we have a dietitian health professional course of 10 modules, takes 25 hours to complete, and it is excellent. But we've also developed a much shorter patient education module. And our app has lots of information on the diet in it. There are other ways of learning. So can we value add to the FODMAP diet? Well, bifidobacteria tend to be lower with the phase 1, lower in their relative abundance, not in all hands, but in many hands. And in fact, this here from London, from the King's College, showed that the bifidobacteria were lower here, but they could correct this with a probiotic. So should we be using a probiotic? Well, there was no symptomatic benefit. And when you go into the personalised phase in this same group, they found that the bifidobacteria went back to their normal abundance, and really there was no ongoing problem. So I don't think this is really where an area we can value add. The area of more perhaps concern is that in many patients do reduce their fibre intake. And this was from a New Zealand study of an experienced FODMAP-trained dietitian who found that in phase 1, dietary fibre intake did reduce. Reasons why fibre might be important is that the FODMAP diet itself doesn't have consistent change in fecal water. It doesn't change the character of the stools. Patients might be quite happy with their stools, but that doesn't change the character of the stools. And perhaps fibre, that's what fibre can do. And when you reduce your FODMAPs, you're reducing distal colonic fermentation, and in some studies, there is a reduced delivery of short-chain fatty acids to the distal colon, which is supposedly very health promoting, and there's increased protein fermentation. And both of these combined likely have an impact on long-term colonic health. So can fibre change this? And so what we have done, Dan So has just finished these studies, which are yet to be fully published, that we took patients who were starting a low FODMAP diet and we fed them all their food. We gave them a low FODMAP diet with either supplement with a minimally fermented fibre or a fermented fibre in resistant starch. And what he did was looked at their habitual diet, and we randomised them to one of the 3 conditions here, and then crossed over to the 2 other conditions. The first issue was the fibre going to make the control of symptoms with the low FODMAP diet worse, and whether we used a visual analog scale or the IBS SSS, there was no real effect. Slightly suggestion that maybe the fermentable resistant starch might increase the symptoms, but this was not significant. No one stopped the study. The stool output with the fibre increased, and most importantly, the stool consistency improved. And so what this here shows is the change in stool water content. And you can see here that with the sugarcane fibre, that the dry stools became wetter, normal stools remain normal, and the loose stools became drier. And this was really the non-fermentable fibre was responsible for this. The combination had no extra benefit. What about fermentation? Well, we know that when you put resistant starch into people, that you get more short-chain fatty acids produced, as shown here by the plasma acetate concentration that went up in the combined group. To look at where fermentation was occurring, we used the experimental but gas sensing capsule, which can measure hydrogen concentrations through the bowel as well as where this is occurring. And we divided up the colon into regions determined by their transit time. So Q1 was the proximal and Q4 the distal. And the hydrogen concentrations are shown here. I've only shown the medians, but you can see here that without a fibre supplement or indeed with the with just a non-fermentable fibre, there was a reduced fermentation in the distal colon. Whereas when you use the combination, the fermentation increased and you got even fermentation right throughout the bowel. So what we defined by these studies was if you're initiating a low FODMAP diet and you wish to use a fibre supplement, a minimally fermentable fibre will normalise the stool water content. If you put in a fermentable fibre, it will enhance fermentation. But if you give them both, you won't make the symptoms worse, but you'll spread the fermentation right across the bowel to the distal colon. So this will value add the diet. So in summary, my messages would be that the FODMAP dietary strategy is efficacious for IBS, it's evidence-based and is in national guidelines. The diet has matured to a dynamic process of reintroduction and personalisation phases with maintenance of efficacy in the longer term. The optimal use of the diet, however, really does require for us as medical practitioners to understand the risks of a restrictive diet, to be aware of disordered eating and the need to assess for it prior to instituting the diet, that it would optimally be used if you actively involve a FODMAP trained dietitian or other health professional who has undergone such training. And we may have potential in value adding with specific fibre types. And personalised therapy is really the rule. You have to always consider, like you do for any drug therapy, the risks versus likely benefits. I'd like to finish by just saying that all of this work has been the result of a multidisciplinary team here, and too many people to name, but Jane Muir, she is the leader of the pack. Together with me, she is known as mother, I'm known as grandfather. Thank you.
Thank you very much, Professor Gibson, for that very informative and valuable lecture. Let me thank the audience also for joining in.
Many thanks to the co-chairpersons. Lined up as the 10th segment of the academic sessions, we have the poster presentation. This session will be co-chaired by Dr. Gayani Punchiheva, Senior Lecturer in Psychiatry, Faculty of Medicine, University of Ruhuna, and Dr. Aruna De Silva, Senior Lecturer in Pediatrics, Faculty of Medicine, University of Ruhuna. I cordially invite the co-chairpersons to chair the session.
Good afternoon to you all. Welcome to the poster session of the 80th Annual Academic Sessions of Galle Medical Association. There are 4 posters lined up today for this session. Each poster will take 5 minutes and 2.5 minutes for the presentation and 2.5 minutes for the question and answer session. Audience is kindly requested to direct your questions to the question and answer box.
The first poster presentation is on prevalence of SARS-CoV-2 infection among Ruhuna medical undergraduates during the first 2 waves of COVID-19 pandemic in Sri Lanka by Veerasinghe NP, Gunasena S, Vijayaratna WMDGP, Vikramasinghe SS, Tabru HHP MJ, Tilakaratna LG, Nagahawata A, DS, Herath HMM, Bodhinayaka CK, Patirana MD, Andunetti R, Gunasekara NCA, Padmini JL, Dharmasiri GNJ, Mahaliyana D, Nicholson B, Wood C, Ubesekara HA, Devasiri IV, Amarasena TSD. It will be presented by Veerasinghe NP. Over to you, Nayani. You can start.
Our topic is prevalence of SARS-CoV-2 infection among Ruhuna medical undergraduates during the first 2 waves of COVID-19 pandemic in Sri Lanka. Medical students are a vulnerable cluster for COVID-19 infection caused by SARS-CoV-2 and their potential vectors due to high rate of asymptomatic infection in healthy young adults. Our objective was to estimate the prevalence of SARS-CoV-2 infection among medical undergraduates during the first 2 waves of COVID-19 pandemic. A repeated cross-sectional study conducted involving 175 and 104 students respectively during the first and the second waves of pandemic in Sri Lanka. A self-administered questionnaire was used to collect data. An RT-PCR and SARS-CoV-2 antibody tests were performed on all the participants. The results: PCR results was positive only during the second wave, and that was in 5 students. However, SARS-CoV-2 antibodies were positive in 1 student in the first wave and 7 students in the second wave, including all 5 students with PCR positive. And out of these 8 students who had positive antibodies, only 1 was symptomatic. Therefore, asymptomatic infection rate was 87.5% in our study group. This graph clearly shows the possible risk exposure to COVID-19 infection during the 2 waves, and it clearly shows that the risk exposure is higher during the second wave, as shown in the dark green color bars. In conclusion, during the first and second waves, the infection rate is very low. More medical students became positive during the second wave than in the first wave. However, most had asymptomatic infection. There is high risk of exposure for COVID-19 during the second wave of the pandemic in Sri Lanka. Surveillance at regular intervals, targeting individuals from diverse geographic regions can be helpful in tracking the spread of SARS-CoV-2 in Sri Lanka. I would like to acknowledge National Research Council for financial assistance and Duke Global Health Institute in USA for various assistance extended during the study, and Gaul Medical Association for giving us this opportunity to present the study findings. Thank you.
So, can I ask a question? Did any of these students who was positive, did they contact it from the hospital or they have contacted it from other sources? Those who became positive, did they contact COVID from the hospital or from other sources, from outside?
As there are no questions, we'll move on to the next presentation. It's on the knowledge, practices, and associated factors related to COVID-19 infection among doctors and nurses working in emergency treatment units in selected state hospitals in Kalutara district, Sri Lanka. Authored by Fernando TNMS, Ranasinghe N, and Athuporala KM. The poster will be presented by Fernando TNMS. Over to you, Fernando TNMS.
Our study topic is the knowledge, practices, and associated factors related to COVID-19 infection among doctors and nurses working in emergency treatment units in selected state hospital in Kalutara district, Sri Lanka. Introduction. COVID-19 is one of the most contagious diseases in the human history. Total number of COVID-19 cases are increasing globally and locally. Hence, healthcare workers are at a high risk of getting infected. Objectives: to describe the knowledge, practices, and its associated factors related to COVID-19 infection among doctors and nurses working ETUs in selected state hospital in Kalutara district, Sri Lanka. We have done our study by a descriptive cross-sectional study which was conducted among doctors and nurses at 4 main ETUs in Kalutara district. Results: out of 220 individuals, majority was female. the total knowledge on COVID-19 infection among participants, which was assessed by a 70 marks scale, and it was ranged from 18 to 63. Social media was the most commonly used source of knowledge. There was a statistically significant relationship between the knowledge and the designation, the current working station, work experience, and training on infectious control and prevention. Proper dunning and duffing practices were poor among participants, while good practices were evident in hand hygiene practices, appropriate discarding of used PPEs, and wearing a new face mask daily. Conclusions. The knowledge on COVID-19 among doctors, nurses varies according to their designation, working experience, working station, and training on infectious prevention and control. The practices are satisfactory except for dunning, duffing, and PPE usage for aerosol generative procedures. Recommendation. There is an urgent need for nationwide practical training on appropriate use of PPE to curtail the spread of COVID-19 infection among healthcare workers.
Thank you very much.
There's no other questions. We'll move on to the third poster. It's on effects of COVID-19 pandemic situation on congenital hypothyroidism screening performances in Faculty of Medicine Gaul by Lianage D. Hettiarachchi M. The poster will be presented by Lianage D.
My presentation today is about the effects of COVID-19 pandemic situation on congenital hypothyroidism screening performances offered by the Faculty of Medicine Gaul. Laboratory at Nuclear Medicine Unit screens about 160,000 samples for congenital hypothyroidism annually. It was running smoothly but had to face many challenges last year due to the situation of the country since March 2020, which was created by lockdown, poster delays, and other financial issues during the pandemic situation. Therefore, we conducted a study to assess the effects of COVID-19 pandemic on our screening function. In this retrospective analytical study, we assessed the laboratory key performances indices in two categories. Pre-COVID period was the time period from the beginning of year 2020 up to 15th of March prior to lockdown period. The remainder of the year was considered as post-COVID. Out of all the samples received during year 2020, about 208 got screened positive, and the results were informed to the parents through the maternal child health medical officers of the relevant area. Out of them, 111 got screened positive after serum confirmation. 17 samples out of them were received during the pre-COVID period, and the remaining 94 samples were received after. The key performance indicators are presented here. The median number of days taken to receive those screening positive samples and the median of days taken to inform results are tabulated here. During the post-COVID period, there was nearly a week delay observed to receive the sample, and it took 2 months to notify the patients. The challenge to any screening program is to deliver its outcome at the earliest to avoid any permanent damage to the babies. For congenital hypothyroidism, our target was to do this within first 3 weeks of life. However, we observed some modifiable factors contributing to the inadvertent delay, such as delayed delivery of samples, lack of reagents, and delay in conveying results. Thank you.
As there are no questions, we'll move on to the next poster. It is on prevalence of anastomotic leakage among patients who underwent intracorporeal and extracorporeal anastomosis in laparoscopic right hemicolectomy in Diana, Princess of Wales Hospital in United Kingdom and National Hospital of Sri Lanka. Authors are De Silva, KPVR, Seneviratna RW, Manavadu NW. Poster will be presented by De Silva, KPVR. Over to you.
Good afternoon. I am Dr. Viduruchira De Silva, Consultant General and a lower gastrointestinal surgeon from Teaching Hospital Karapitiya. This is a study to assess the prevalence of anastomotic leak among patients who underwent intracorporeal and extracorporeal anastomosis in laparoscopic right hemicolectomy in Diana, Princess of Wales Hospital, United Kingdom and National Hospitals of Sri Lanka. Anastomotic leak after ileocolic anastomosis affects both post-surgical improvement and motility of a patient. Therefore, protection of ileocolic anastomosis is of paramount importance in laparoscopic right hemicolectomy. My objective to assess the prevalence of anastomotic leak among postoperative patients who underwent intracorporeal and extracorporeal anastomosis in laparoscopic right hemicolectomy.
This is a descriptive cross-sectional study done with an analytical component among 89 patients with colorectal cancers who underwent laparoscopic right hemicolectomy. The study objects were selected from colorectal cancer registry and theater of the hospitals using simple random sampling method. A number of 45 patients had intracorporeal and 44 patients had extracorporeal anastomosis respectively. They were observed for any anastomotic leak within 1 week duration. The data was collected from the bedhead tickets and associated factors for the integrity of the anastomosis were determined by multivariate analysis. As you all can see, 45 patients who had intracorporeal anastomosis, only one person had anastomotic leak. However, there were 44 patients who had extracorporeal anastomosis. However, they have only 5 patients with anastomotic leak. Altogether, the prevalence of anastomotic leak is around 7%. Therefore, intracorporeal ileocholic anastomosis has minimized the anastomotic leak when compared to the extracorporeal anastomosis in laparoscopic right hemicolectomy. Thank you very much.
Since we do not have any questions, thank you, Dr. De Silva, for that presentation. And we have come to the end of this poster session. Now, with my co-chair, I would like to thank all the authors and the audience. And we would like to conclude the session now. Thank you.
Thank you, co-chairs. Ladies and gentlemen, we will now break the session for lunch. The program will recommence at 1:15 p.m. Do stay connected for an academic experience of a lifetime.
This is Sophie. She just turned 45. A wife, a mother, a daughter, a friend, a teacher. She is many things to many people. She was 17 when she first met her partner. 28 years and 3 children later, they still look at each other the same way as the day they met. Every summer, they go to the countryside cottage of Sophie's parents in a hope of a quiet escape from their busy city lives. And maybe it would be if it weren't for all the cousins and siblings and their families, of course, all trying to escape the city buzz. Many of Sophie's friends, even from high school and university days, have been visiting for years. It is probably her unconditional love for people and passion for art that brings people together. She always says, "I am lucky because my passion is what I do." Over 20 years as an art teacher, she has inspired and touched the lives of many. It's only recently Sophie has been feeling like something isn't quite right. Today, Sophie was diagnosed with breast cancer. Breast cancer doesn't only affect those who are diagnosed with it. It has an impact on families, communities, and our society. Every 20 seconds, someone is told they have breast cancer. So Sophie may be just like someone you know. One diagnosis, hundreds of lives impacted. Treating breast cancer early may provide the best chance of cure. That is why we are committed to bringing every single patient with breast cancer closer to cure. And it is this commitment that drives us every single day.
Torrent Pharma, one of India's leading integrated pharma companies. Torrent Research Center works zealously in the quest to discover better therapeutic solutions. Have to their credit novel drugs that have been developed for the first time in the world for various therapeutic segments. Currently, we operate in over 70 countries across 6 continents. Most respected pharma company.
We have seen that HMOs are components unique to human milk, which are surprisingly very abundant, but devoid of any nutritive function, leading us to wonder what they actually do. Revealing that HMOs play a key role in supporting the immature immune system of infants, thus protecting them at a time of great vulnerability when their defense system is not yet fully functioning. HMOs also help to educate the developing immune system in order to make it fully functional. So, how do HMOs do that? HMOs help the immune defenses in 4 major ways. First, they help establish a protective commensal gut microbiota. Second, they block pathogens from doing harm. Third, they strengthen the gut barrier function. And fourth, they help educate the developing immune system. The more you learn about HMOs, the more you will understand what makes them so specific and beneficial.
Deflon 500, the world's first oral drug with international guideline recognition for hemorrhoidal disease and chronic venous disease. Deflon 500 is the ideal partner for your hemorrhoidectomy. With a dose of 2 TDS for 4 days, 2 BD for 3 days, you will get an inflammation-free and bloodless access to the site of surgery. For varicose patients with a dose of 2 tablets daily for 3 months, you can provide rapid relief from symptoms such as leg pain, night cramps, and sensation of heaviness. In type 2 diabetic patients, Dimecron MR60 achieves potent HbA1c control up to 6.5% without compromising hyposafety. Covasil provides a stronger BP reduction compared to other RAS inhibitors.
Our people, our partners, our technology, the foundation to world-class healthcare. MR Pharma, service for health.
Welcome back, ladies and gentlemen, and thank you for joining the 80th Annual Academic Sessions of the Gall Medical Association. Proceeding to the 11th session of our program, we have the third symposium on a timely topic, COVID-19, Facing Emerging Challenges with Confidence. To chair the session, I cordially invite the co-chairpersons, Professor T.P. Veeraratne, Senior Professor in Medicine, Faculty of Medicine, University of Ruhuna, and Dr. Krishantha Jayasekara, Consultant Physician, Teaching Hospital, Karapitiya, to the head table.
Good afternoon. Welcome to the third symposium in the annual academic session. My co-chair, Dr. Krishantha Jayasekara, we'll be having three eminent speakers in this symposium named Facing the Emerging Challenges with Confidence. The speakers are Professor Suranjit Senaviratne, Professor and Consultant in Clinical Immunology and Allergy, Dr. Chandima Jeevandra, Director, Allergy and Immunology and Cell Biology Unit, University of Sri Jagadhanapura, Dr. Ananda Vijayakrama, Consultant Physician at the Infectious Disease Hospital, Colombo. Let me first introduce you the ground rules of this largely a virtual symposium. Each speaker will have 25 minutes and the questions are entertained at the end of all three presentations and not at the end of each presentation. Audience, please type your questions in the Q&A box in the Zoom screen at the lower border and do not ask questions orally or type in the chat box. It has to be in the Q&A box. I'll hand over the introduction of first speaker to my co-chair, Dr. Krishantha.
The first talk is going to be on COVID-19 vaccines, current global perspective. And let me warmly welcome Professor Suranjit Senaviratne, Professor and Consultant in Clinical Immunology and Allergy, Institute of Immunity and Transplantation and Health Services Laboratories, London, UK. Over to you, Professor Senaviratne.
Thank you. I'll give you a current global perspective on the COVID-19 vaccines as at the present time. All of us would know that this has caused massive devastation across the world, with the number of cases over 220 million, together with 7 million cases in the UK and many cases in the US and India. This figure will show you the SARS-CoV-2 schematic of the SARS-CoV-2 virus. And why I put this is to show you the spike proteins on the surface that binds to the cell. The virus enters the cell, multiplies, and then spreads from cell to cell. Now, the vaccines have been designed to target the spike protein. And secondly, as the virus keeps on multiplying, variations can occur or mutations can occur, and therefore viral variants will have arisen, and this is causing an effect around the world. So vaccinations have been a major pillar when it comes to the control and of SARS-CoV-2 infection and preventing it and trying to get control over the pandemic. So 8 to 10 vaccines have been approved so far, but this slide shows you that there are some vaccines that were abandoned. That's not every vaccine that was developed was a success and was approved. So several vaccines were abandoned, especially in Australia, etc. And the rigorous process was followed with regards to doing the clinical trials and authorizing or approving these vaccines. over 5 billion doses have been administered in the world so far. And you can see the schematic, this graph from May showing the countries that were vaccinated at high rate at that time. And then this was a more recent figure, again showing the countries that have very, very high second dose vaccination rates. Now, immediately you can see from this that some of the richer countries were at the top, and some of the countries were not even having a single dose of vaccine being given to its population. And this is not good because it means that it's not an equitable distribution and it has an impact on the variant distribution, etc. The summary of my talk would be quickly going through some immune aspects of the infection. Just 2 or 3 slides on the variants because that has been touched already. And then I will focus on the vaccines and what is new and what is current at the moment with regards to COVID-19 vaccines. If we start with the immune system, you have viruses, bacteria, and fungi that try to attack our body, the danger signals. You have the first part of the immune system, the second part of the immune system, antibodies, white cells, lymphocytes, and cytokines, which come into play to get rid of these. Similarly, in the SARS-CoV-2 infection, cytokines are just chemicals that help the immune cells to talk to each other. And if the cytokines are dysregulated, then you find that hypercytokine syndromes occur, and then issues occur with regards to fluid leakage, etc. What are the changes, the immune changes that occur in COVID? Many changes occur. Some cytokines are increased many-fold, such as IL-6, IL-1, etc. Some cells are reduced, some cells are decreased. And I won't go into great detail because I've spoken about this in previous talks, etc. But a lot of immune changes occur. And there is immune dysregulation. So the virus comes and multiplies, and then it leads to an immune dysregulatory state. And what's the importance of knowing this? By knowing this factor, we can target certain treatment options to control this process. So these are some of the treatments that we use, steroids, etc. And the important guidelines to be followed is continue the regular medications. And if it's an asthma patient, you continue the inhalers. You don't start it anew, but you continue it. Your paracetamol is okay, not NSAIDs. You don't start aspirin newly, but if you're already on aspirin, you continue it. The important aspect to remember is steroids are, such as dexamethasone, is fine, but not given at the wrong time. It has to be given at the correct time, because if given too early and too high dose, it can cause issues. You do not give antibiotics unnecessarily, because this is a viral infection, not a bacterial. If you have a secondary bacterial infection, definitely, but you do not give it too early and unnecessarily. So these are some sort of guidance with regards to treatment, which you can get by studying the pathogenesis, and that is also important for vaccination. The immune response consists of antibodies. The G, A, and M antibodies occurring at different times. You have the CD4 cell and the CD8 cells, and these are what you would try to get with vaccination. If you're infected with SARS-CoV-2, you will get this process occurring, but it will be about 7 to 10 days after, and many people can die in the process. So therefore, vaccination will try to produce this before the person gets infected, so that the person, even if they get infected, would only get a mild infection, not a severe infection. Age is important. The older the person, the immune response can be more dysregulated and it can be dysfunctional. And this is important. That is why you have to protect the older population early and not delay their protection for long periods of time. And that again is obtained by looking at the pathogens of the condition over the period of time that we have studied it. So that is a quick overview of some of the immune aspects that we have to take into consideration in the infection and in vaccination. The variants have come in big time from autumn of 2020, and we have known quite a lot, and quite a lot has been written about the different variants. At the present, you have variants of concern, variants of interest, and the variants of concern are alpha, beta, gamma, and delta as per the WHO classification. And then you have some variants of interest. Now, what is the effect of the variants? The issue is many changes occur in the virus, close to 5,000, but not all of those are important. However, some of them are clinically important and they can affect one or more of these following processes. That is, they can affect the spread, the transmissibility, they can cause more severe disease, it can affect diagnostic tests, therapeutic agents, or they can affect, importantly, vaccine-induced immunity. And that's something that really interests scientists around the world. Does it affect vaccine-induced immunity? So those are the potential effects, 5 potential effects. So the variants of concern, alpha, beta, gamma, delta, the variants of interest. So the first slide produced by the WHO, but then subsequently other variants of interest have also come in, such as mu and delta. If we look at the delta variant, which is the one that is circulating widely around the world and is affecting so many populations, including Sri Lanka, they were initially called the double mutant because they had 2 critical mutations in the receptor binding domain, the place where the virus binds to the ACE receptor and enters the cell. Not that they had only 2 mutations, but these are 2 critical mutations. That was why they call the double mutant. They have several other mutations in the genes of the virus. And this was the article that just coming out that we describe in detail the Delta variant of SARS-CoV-2 and its effect on the vaccination, because you find that the antibodies that are produced from vaccinations are the neutralization capacity is reduced with the Delta variant compared to the other variants such as Alpha. Still, it's able to neutralize it and prevent severe disease. However, we are having an effect on vaccination with the Delta variant, and there are some breakthrough infection, especially mild or asymptomatic infection that are coming through, which I will describe as it goes on. So there are other variants such as the mu and the lambda variants, which we have described, and so many others. And this is a small article on the characteristics of 2 other variants that people are monitoring very carefully with regards to the SARS-CoV-2 virus. So next we go on to the main part of the talk, that is the COVID-19 vaccines. We have spoken about the immune response, the issues with regards to variant, Delta variant, etc., and mu and lambda coming into the equation recently. So when it comes to vaccines, I told you the vaccines are targeted against spike protein on the surface of the cell, and there are several vaccines that have been studied and many that have been authorized or approved so far. This is a list of the vaccines that some of the common vaccines with their properties, and you can see that at the top you have the mRNA vaccines, the Pfizer and the Moderna vaccine, which are the best vaccines around. Efficacy is very high, effectiveness is very high, and then you have the viral vector vaccines, that's AstraZeneca, the J&J and the Sputnik vaccines, and then you have the killed vaccines, which are the Sinopharm and Sinovac. So you find that the effectiveness and efficacy are lowest in the Sinovac and Sinopharm, while it is highest in the mRNA vaccines. Now, interestingly, the person who first described the mRNA process, the vaccine sort of using mRNA in diagnostics and therapeutic, they won a major prize, I think, yesterday. And when they described the process initially, that lady could not get grants for a long period of time, could not get, her job, she had to leave her job, she was demoted, etc., because they thought this process will never work in clinical medicine. And we can see that over a number of years after that, that it has been a major success with regards to SARS-CoV-2, and it will be important when it comes to cancer vaccination, because that is the next goal that the mRNA process will go into. So we have a whole range of vaccinations that are available for us to use in SARS-CoV-2 infection to prevent it, and that should go hand in hand. That's very important with the social distancing measure. Vaccination alone is not sufficient. You have to have the other measures in place that go hand in hand. Now, this slide shows you that there is infection, which can lead to disease. So you can be asymptomatic, you can have mild disease, you can have moderate disease or severe disease. What do vaccinations do? It prevents severe disease. That's the first thing it does. That's important because all vaccines are doing that well. If you can prevent people getting to hospital, ICU, or dying, that is the first thing with regards to vaccination. But we must know that those who are infected or those who have the disease can transmit the disease. And that is important when it comes to the next few slides. Efficacy is if it's in a clinical trial, effectiveness is in the real world. And we have both efficacy trials published in the major journals and the effectiveness trials coming from the UK, US, Germany, Europe, plus Israel, showing that the vaccines that have been are both efficacious and they are effective in controlling the infection. So very early in December, the UK government looked at this process and they categorized 9 different groups. Why I put this slide is because they went very systematical. The older people, the healthcare workers, people with immune deficiency, cancers, etc., vaccinated very early in the process. By February, they had received both vaccines. And they followed this process and vaccinated a big number of the population, over 40 odd million, have been double vaccinated at the present time. It made an effect because you can see the curves. In November, December, you had the alpha variant circulating very widely, and then with vaccination coming on board, you found that the curve turning and the numbers reducing. We know that Delta is coming now and increase the numbers, but the severity of the infection is low because of lots of people being double vaccinated. You have to get 2 vaccines. 1 vaccine is not sufficient. 1 dose of either Pfizer or AstraZeneca vaccine would only give about 30% protection, which is lower than 50% prescribed by the WHO. And 2 doses will increase the level of protection, both the alpha variant and the Delta variant. So 2 doses of vaccination are essential if you want to get appropriate protection. That is important to remember. Now, the issue is that with the Delta variant coming into the focus, that we know that it protects against severe infection, etc., but there are some breakthrough infections. And some people who are double vaccinated are getting breakthrough infection, but there's a mild infection or asymptomatic. Now, the issue with that is that when they get a mild or asymptomatic infection, the viral load is still high. So that those people can transmit the infection to those who are not vaccinated. This was clearly shown in the Oxford ONS study, and that is important to remember with regards to the non-vaccinated group, because they are at very much higher risk from the people who get breakthrough infections, that's vaccinated people who get breakthrough infections. Extremely important point. So in the Los Angeles study, it was found that unvaccinated people had a 5 times rate, the rate of COVID infection 5 times higher, and 29 times more likely to be hospitalized. So the group that has been targeted now is the non-vaccinated, but that is the group that is ending up in ICU, hospitalization, and death, as opposed to the vaccinated population. Now, the other aspect to be considered is, what about the immune response following vaccination? Now, the Pfizer company very early said that the immune response could be waning after some period of time. And there was the risk reduction in infection was 96 2 months after that, 83.7 4 months after. So there was a reduction in there was a 12.5 point reduction in the risk of infection. So it appeared to be that the immune response was waning. And this was again shown beautifully in the VIII study, where they've studied people who had been vaccinated, and they found that there was a waning of the response, which I'll show you in the next slide. So looking at a reasonable worst case scenario, they found that the protection could fall below 50% in some elderly and healthcare workers by the winter. And that is why the UK government at the moment is most likely going for booster vaccination. This is a very contentious issue at the moment, giving everyone a booster 3rd dose, but it will be discussed, and it appears that next week the process will start for the general population, but that is again an issue that has been discussed. So these are the figures that were shown from the VIII study. 1 month after the Pfizer, it was 88%, and then 5 to 6 months it dropped to 74%. And Oxford AstraZeneca started at a lower dose, a lower level, and then also dropped after a few months. So we wrote an article outlining all these aspects when the 3rd dose was recommended for people with immune deficiency. And at present, both the UK, US, and several other countries are giving patients with immune deficiency a 3rd dose. The timing of the timing in the US, it's at least 1 month after the second dose. In the UK, at least 2 months. And generally, people are going for that period or up to 3 months for the immune deficiency, because we know that patients with immune deficiency and cancer may make suboptimal responses that have been clearly shown in many studies that have been published so far. What about children? That's another widely discussed issue. What about children, vaccination children? Initially, the Pfizer vaccine was approved for children, for persons over the age of 16. And the other vaccines, such as the Oxford, AstraZeneca, and the Moderna, etc., were 18 years. Then subsequently, studies came up, and now the Pfizer and Moderna have been approved. The Pfizer has been approved up 12 and over. And it has been rolled out in the US and in Canada and several other countries like Israel. In the UK, the 16-year-olds and 17-year-olds, all 16-year-olds and 17-year-olds are offered the Pfizer vaccine at present. 12 to 15, the high-risk children are given the Pfizer vaccine, but the other children it's still not approved for the other children. So the JCVI, the Joint Committee of Vaccination Immunization, said they cannot recommend for other children. However, the government may override that. And there's again a lot of discussion. In the next week, we would know what is happening. We have to remember, put it into context. In this article, we have described the different aspects of COVID-19 in children, the pros and the cons with regards to vaccination in children and the issues with transmitting to adults. And since children get only mild infection, should we be vaccinating them, or should we get these vaccines out to places where even healthcare workers do not have any vaccination? So these are the issues that come up, and that has been described in these articles, in the article that has been written here. Again, this has been discussed in the sort of current updates, which was again written very recently about vaccinating children. And at the present time, 16 and 17-year-olds are vaccinated in the UK, and the other group, only the high risk, from 12 onwards, only the high risk. Below 12, studies are ongoing, and many studies should be reporting in the next few weeks or in the coming months. So during this quick talk, what I have told you is a quick overview of the immune response to COVID-19 infection and following vaccination, the antibody response, the cellular response, and I told you there is a response that occurs following infection, but it takes some time. That is why we try to give a vaccine to mimic that response so that the person is protected. And then I told you about the variants, including the Delta variant, which is causing some concern about vaccination, although at the present time it is protecting against severe infection, but that the hope is that no other more nasty variants arise in population, that the transmission is very high. And that is what we should focus on, reducing transmission in areas that are not protected at the moment. And then I spoke to you about the COVID-19 vaccines, the ones that were approved, the mRNA vaccines, the viral vector vaccines, and the killed vaccines. And I told you some of the properties of those, vaccinating patients who are immune deficient or who have cancer, vaccinating children, and then giving this third booster in a wider range of people, which is again being discussed, especially with the waning of some immune responses that are seen. And when it comes to children, we have to balance the benefit to them as opposed to benefit to the community. Thank you very much.
Thank you, Professor Ranjit, for your elaborate and up-to-date lecture. And we'll be again getting on to the questions at the end of all three speakers' talks. And virtual participants are reminded that please type your questions in the Q&A box, and we will direct them to the relevant speakers at the end of the symposium. So thank you, Suranjit, and we will get on with the next talk of this symposium. It is named Simply a Piece of Bad News Wrapped Up in a Protein, Sri Lankan Perspectives. to be delivered by Dr. Chandima Jeevandara. He's the Director of Allergy, Immunology and Cell Biology Unit in the University of Sri Jayadalpura. Over to you, Chandima.
Thank you, Chairperson, sir, Madam, for the kind introduction. It's indeed a great pleasure to be with you to talk about the variants of SARS-CoV-2 and the disease trends, and also our work from the Allergy, Immunology and Cell Biology Unit of the University of Sri Jayawardhanapura, Sri Lanka. And I'm indeed grateful for the President and the Council members of the Gold Medical Association for inviting me to talk to this prestigious audience. A virus is simply a piece of bad news wrapped up in protein. The biologist Jean and Peter Medawar wrote in 1977. In January, scientists in China deciphered the most important news in 2020. They unraveled the genome sequence of an unknown pneumonia in China. No sooner, Sri Lanka reported its first case of coronavirus back in January 2020 from a foreign national. The first local coronavirus case was detected on 11th of March from a laboratory. The dawn of the year 2020 transformed our lives, and more than 221 million confirmed cases of COVID-19 and more than 4.5 million deaths reported to date. And this is a gross underestimate. It has crippled economies, disrupted lives, livelihoods and social lives, and increased inequality was evident, especially in terms of vaccination. Let's talk about the situation in Sri Lanka. Like the other parts of the world, Sri Lanka is not doing very well at the moment. We report quite a significant number of cases, and there's a slight decline over the past 1 week. The most important finding here is the number of deaths. The 7-day average of the number of deaths is staggeringly high, and probably one of the highest in the world, which is not very good news as one of the best countries in terms of healthcare. However, there are positive sides. Our vaccine rollout is extremely good. We are even catching up America's right now. And if you can see, even in the global map, Sri Lanka is becoming dark green, which is great news. And we are hopeful that we will be able to contain the case numbers at least by mid-October. So, ladies and gentlemen, in that background, let me take you through our Sri Lankan experience in genomic sequencing and the uses and the values of sequencing globally for future control. SARS-CoV-2 virus is a single-stranded positive-sequence RNA virus which belongs to lineage B of the genus beta coronavirus family. It shares about 78% homology with the SARS-CoV virus, and it consists of 2 open reading frames, namely ORF1A and ORF1B, which constitute for about 2/3 of the genome. The rest 1/3 of the genome encodes for 4 structural proteins, namely nucleocapsid, spike, membrane, and envelope. So altogether, there are about 30,000 base pairs which we unravel through genome sequencing. So back in 2020 March, Sri Lanka did not have sequencing facilities. However, Allergy, Immunology and Cell Biology Unit of University Jagannathpura had the facilities, had the expertise. So Minister of Health invited us to be part of this effort in identifying this SARS-CoV-2 genome, and we were very happy to contribute onto their request. And we stepped in. Genome sequencing, we know it originated in late 1970, when Frederick Sanger at the MRC Center in Cambridge developed a gel-based method that combined DNA polymerases with a mixture of standard and chain-terminating nucleotides known as DNTPs. Since then, this technology has advanced rapidly. As of today, even in our lab, we have both second generation and third generation sequencing platform, which is capable of sequencing the SARS-CoV-2 genome. There is a notable difference between the two platforms. Let's look at it briefly. The second generation platform is able to generate short reads, but through this method, when we develop the draft genome, there may be sequence gaps, and missing sequence leads sometimes limits the biological interpretation. To combat the practical issue, Oxford Nanotechnology developed high-five reads, which are using in our laboratory currently, and it is capable of encoding the complete genome. A comprehensive structural, functional, and organizational picture of the genome is possible through this method. Let's compare the speed and the scale between genomic responses in SARS epidemic versus SARS-CoV-2. Back in 2002-2003, only 3 viral genomes were publicly shared within the first month, and only about 31 were available within 3 months. However, things are really different in 2021. The SARS-CoV-2 pandemic, during the SARS-CoV-2 pandemic, the causative pathogen causing this unexplained pneumonia was revealed within 1 week. And the pathogen was announced as novel coronavirus and then later renamed as SARS-CoV-2 in the beginning of January 2020. 6 genomes are publicly shared within a couple of weeks, allowing rapid development of diagnostic assays and strategies for many public health interventions. And as of today, more than 2 million SARS-CoV-2 genomes has been uploaded to the world databases. It's mainly because of the third generation sequencing platform, which even possible, even in a failed setting. This is a picture, I took it from the net, where their sequencing is happening in a failed setting. This is in our lab. Our scientists are working using a similar platform, which helped. The sequencing is accessible to even small laboratories with providing real-time analysis. So how we have responded? So we sequenced our first genome on 23rd of April 2020 using the second generation platform, which was available with us at that time. So the first genome was introduced around this day, and then until the second wave, which we observed from associated with the garment factory, we did not do much sequencing because there were no cases. We have updated only about 16 genome sequences until about October. But since then, we detected significant number of cases in the country, and we increased our capacity to about 94 samples per month. And then later, during this epidemic, this phase of the pandemic, we increased our sampling, and we are now currently doing about 94 samples a week, probably the maximum. Let's go back and evaluate our performance compared to the other parts of the world. At the beginning, we were a bit late to upload our sequence, simply not because of anything, because At that time, back in 2020, we did not have necessary reagents and consumables in Sri Lanka. To get it down to Sri Lanka, it took some time. But since then, we have sequenced more than 1,200 genomes. Compared to the developed world, our performance is grossly inadequate. However, when we compare our sequencing capacity in the region, we are doing a very good job and probably the best sequencing facility in the South Asia. And even in Asian region, we are around number 6, which is very good news from a single sequencing facility. Operational structure, unfortunately, we don't have as operational structure as such. So if you compare with the UCOG UK, where all sequencing platforms are combined, it's working as a unit. But here, whenever we want to do a sequencing run, we need to contact in each and individual labs or the regional laboratories to get down samples to get a clear picture about Sri Lanka. The SARS-CoV-2 virus evolves over time. So from one generation to another, similar copies are generated. It's like an old photocopier. Sometimes from the parent generation, when it develops children, it will not produce the exact similar copy. There are mutations. And certain mutations may provide an added advantage to the virus, like increase in transmissibility. So that's why WHO has named 4 variants of concerns. So when you talk about a variance of concern, it could either provides advantage to the virus in terms of increasing transmissibility. Maybe it will cause severe illness, and probably it affects the vaccine efficacy, and sometimes it might impair the naturally acquired immunity and also might interfere with the diagnostic assays. So based on that, and after carefully evaluating the spread of different variants, they provide, the WHO gives different levels of attention to these viruses. So that's the most cautious one is the variants of concern, where we have, as of today, we have 4 variants of concern, namely B117, this is the UK variant, B1351, this is the beta variant found in South Africa, this is the gamma variant found in Brazil, and this is Delta, first detected in India. And since its first detection, it has branched out and it has developed many variants of concerns and 5 variants of interest. The latest addition is the mu. So all governing bodies are closely monitoring the phenotype of these variants. So when the virus evolved over time, there were hostility occurs. As you can see here, at the beginning, there was only one mutation provided an advantage to the virus, which is the D614G mutation, which is supposed to be facilitating the virus's increased transmissibility. Sooner, everywhere in the world, virus acquired this mutation, becoming the dominant variant causing SARS-CoV-2 virus viral infection in the world. But later, after some time, we saw certain key spike mutations happened, giving an added advantage to the virus. For example, in alpha, it clearly showed that it is more transmissible, at least 50% more transmissible than the Wuhan variant. And in delta, it is 50% more transmissible than the alpha, and it is 100% more transmissible than the Wuhan variant. And also, compared between alpha and delta, alpha is still considered to produce more severe disease compared to delta, although the transmissibility is far higher than alpha in delta variant. So in Sri Lanka, our sequencing has become a critical tool, not only in detecting and characterizing viral pathogens, but also supporting infection control and also making key epidemiological decisions. Let me draw some examples. When we detected the UK variant in Sri Lanka, there were restrictions in international travel for travelers. Then when we found out that the UK variant is the causative SARS-CoV-2 lineage for the ultra fast spread in April, we went into a lockdown. And then we found that Delta detected in Sri Lanka. The health ministry supported a decision of banning interprovincial travel because we detected them mainly in Colombo. And then later we found out that Delta is spreading fast all over the country, which again led to a decision of closing down the country. So these are important findings to make policy decisions in Sri Lanka. Although the timing of the decision was not the most appropriate, we can be happy that we have done our part. We have uploaded our data to the World Database, and as of today, GSAID is a recognized sequencing database where we upload our sequencing data to the World Database. So it has quite a significant number of Sri Lankan SARS-CoV-2 genomes uploaded. If we talk about the emergence and spread of Delta in the country, at the beginning, back in March, April 2020, most of these cases were imported from different parts of the world. Then we had our own Sri Lankan variant called B1411, which was replaced by Alpha and then Delta sequentially. Then we went on to check the spread of Delta in the last week, and we found that all provinces had a predominance of Delta as shown in this blue color. Not only that, we found several key mutations which is not seen elsewhere in the world. These are the 3 key mutations in this protein which I am listed here. Apart from that, there is another mutation also which we think will be important in the future, also found in the non-structural region of the virus. Then we further evaluated the emergence and spread of this mutated Delta as shown in this yellow color. As you can see here, from the parent Delta, this is the original Delta and this is the mutated Delta. It branched out as a different lineage, and we wanted to find out whether is there any transmission advantage with the mutated Delta. And at the initial runs it looked like, but then it stabilized, and from our latest run we don't seem to observe any higher transmissibility compared to the original Delta we saw and we see from other parts of the world. However, there is one key mutation which everyone is interested in, that is A701S. In the S gene, and out of the worldwide prevalence of 1,082 mutations in this particular region, Sri Lanka has reported 30%, which is the highest contribution from any country in the world. And even Even the last 60 days, Sri Lanka has contributed more than 75% of the ST mutations in the world, which is not very good news, as you can see here. Compared to the other country, Sri Lanka stands tall here in this map with regard to ST mutation over the last 60 days. And in our unit, as I mentioned earlier, we had our Sri Lankan variant, then we had the UK variant, and this is Delta. And you can see the disease trend and the deaths associated with different variants, the Sri Lankan variant, the UK variant, and the Delta variant. Furthermore, there are recent studies to show that the vaccine-induced immunity can be escaped, especially with Delta variant. And these are important findings to decide on certain policy decisions on vaccination. So, ladies and gentlemen, WHO has, in a recent document, identified 5 key applications of genomics sequencing in SARS-CoV-2. Even though we have not contributed to the first 2, that is the understand the emergence of SARS-CoV-2 and understand the biology of SARS-CoV-2, we have contributed. We will probably be contributing, improving the diagnostic and therapeutics by way of our genome sequencing. And most importantly, for Sri Lanka, we have been contributing significantly to the investigating the virus transmission and spread, and also to decide on certain policy decisions for epidemiology unit. Not only that, we have published, and this publication will appear very soon as an open access article. So, ladies and gentlemen, we need to learn from past, and we need to predict the future. Although the world is moving towards vaccination and about to reach herd immunity in certain parts of the world, I don't think we will have an end to this pandemic. The new variants will emerge, and we don't know how bad the next emerging variant will be. So we need to prepare ourselves. And in view of that, WHO has produced this policy document back in January 2008. And I'm happy to note that MRI and University of Colombo, they combined together in the effort of genome sequencing. And I think they have issued their first report of genome sequencing in the past couple of weeks. So as I mentioned earlier, as the goal of reaching herd immunity, vaccinating so many people that the virus simply has nowhere to go with the emergence of Delta, I realize it's just impossible to reach that. And this is our sequencing team. We are very grateful, and our team and the research funding organizations. Thank you very much. I'm happy to take any questions if you have.
Thank you, Dr. Chandima Divandara, for the excellent lecture on Sri Lankan sequencing. And also, I would like to congratulate your team for the excellent work. So we'll leave the questions to the end of the session. And let me introduce the next speaker, Dr. Ananda Vijayakrama, consultant physician, the National Institute of Infectious Diseases, Colombo. He will be talking on COVID-19, treating severe cases. Over to you, Dr. Ananda Vijayakrama.
Good afternoon, ladies and gentlemen. First, I would like to thank the President and the Council of the Gold Medical Association for inviting me for this academic sessions and giving me this opportunity to share some of my experience on this important topic. About a year ago, I came across this article published in a Nature journal which gives a prediction of the future of the pandemic. It started by saying June 2021. This was written in August 2020. The world has been in pandemic mode for a year and a half. The virus continues to spread at a slow burn. Intermittent lockdowns are the new normal. The approved vaccine offers 6 months of protection, but international deal making has slowed its distribution. An estimated 250 million people have been infected worldwide, and 1.7 million are dead. When I read this, I just laughed at this. I thought it's not believable. It's too much of imagination. However, when we looked at the historical accounts of initial estimates of deaths, there had been a quite a high, relatively high mortality rate associated with this infection. In China, estimates showed about 3 to 5% of mortality rate, changing across their regions. And a WHO study provided a mortality rate of 3%. And in hospital admitted patients, the mortality rate was much higher, which was shown in clinical studies too. In solidarity study, the death rate was around 12%. In remdesivir study too, the death rate was around 7 to 12%. In the recovery study, it was much higher, around 24%. We had quite a large number of deaths reported across the world. However, we had a lot of patients. We had very few deaths. So we thought probably we are doing well or better than other people. This 94-year-old gentleman was transferred to us from a private hospital with a history of progressive shortness of breath, fever and cough. And he was hypoxic on admission, but improved with oxygen. And he was hemodynamically stable. Later, he became confused. His saturation still maintained with 2 liters of oxygen. His creatinine was elevated. Other parameters are generally okay. The chest X-ray showed patchy consolidation in all 3 zones of right lung and mid zone, suggestive of COVID pneumonia. This is his first chest X-ray. It showed the involvement of right lung mainly, and the second X-ray showed the involvement of the left lung too. And because of his confused state, we did a CT scan of the brain too, which showed age-related cerebral atrophy. And the HRCT showed again changes suggestive of COVID pneumonia, but in addition, it showed changes suggestive of secondaries of neoplastic lesion, with the bilateral pleural effusion, small pleural effusion, and bone destruction with the nodular opacity. However, in spite of all this, this 94-year-old gentleman gradually improved, recovered, and went home after 2 weeks. So, this prediction came from this Nature journal. I thought probably not acceptable. Their imaginations were too wild. But then what we saw at the time they mentioned June 2021 was beyond their wildest imagination. We had 225,000 cases as of now, more than that, and more than 4.6 million deaths is by 13th of September. And these 2 graphs shows the occurrence of daily new cases in the world and the deaths. You can see the high numbers occurring in waves. And when it comes to Sri Lanka, these are the deaths reported by the Ministry of Health from 1st of April. And we see the number of deaths which were quite low at the beginning of April this year went up to more than 200. And we had large number of deaths during the last 2 months. So then with this, we face the challenge with what to treat these patients who are critically ill, severe cases. Again, if we go back to our old gentleman, how did he recover? Did we give him monoclonal antibodies? Did we give high dose of dexamethasone, tocilizumab, remdesivir, ivermectin? No, we didn't give anything. He just had standard treatment with oxygen, self-warning. He had secondary evidence of secondary infection, so we treated him with antibiotics, enoxaparin, and his sugar was high, so we gave him insulin. And that's all. And he recovered. If he was given anything like high dose steroids, very high dose steroids, and or monoclonal antibodies or anything, then his recovery, which probably would be little unlikely with all this age and other complications, would have attributed to that particular drug. And that is why we need evidence. That is why we need trials. Interestingly, a large number of trials have been started. Even by early March, more than 300 trials have been registered on medicines for COVID. And you can see worldwide, more than 4,000 trials had been registered by end of December last year. And majority of these trials are in Europe and North America. You can see in spite of the initial outbreak occurring in China, and in spite of having all these traditional medicines in China and in India and in Sri Lanka, the number of trials conducted in the Asian region is quite low. So many agents have been tested: antivirals, anti-malarial, antibiotics, antiparasitics, monoclonal antibodies. However, they have other issues in spite of all these studies. Many preprints of studies which are not peer-reviewed are available in the web. Data in some of these preprints have been used for meta-analysis, and then some preprints were later withdrawn. And some drugs used in clinical trials were promoted to use. This is the infamous article on hydroxychloroquine, which was retracted, which was published in the Lancet surprisingly, and then at the same time another article published in JAMA was withdrawn. This is a science article in the Science Journal. Two elite medical journals retracts coronavirus papers over data integrity questions, which is very probably maybe the first time in the history of these journals such withdrawal occurred. And then this preprint of ivermectin, which again was withdrawn. And it is important to mention that this article was considered in a meta-analysis. And then we see a cocktail of drugs being used in our country: vitamin C, vitamin D, zinc, azithromycin, doxycycline, dexamethasone, ivermectin. Many of these drugs had been used without much evidence. However, we have this therapeutic guidelines by the WHO. In the group, I also was fortunate to be there. And the current recommendations in a nutshell are these. The recommendations against systemic corticosteroids in patients with non-severe COVID-19, a strong recommendation for systemic corticosteroids in patients with severe and critical infections, so that is hypoxic patients. So this guideline specifically mentioned not to use corticosteroids in non-hypoxic patients. Conditional recommendations against remdesivir, against lopinavir, against HCQ, against ivermectin, and strong recommendations use IL-6 receptor blockers, tocilizumab or sarilumab. If you go to a case history, this 34-year-old male weighing 130 kilos was admitted to our hospital just a few weeks ago with fever for 8 days duration. When he was admitted, his saturation, he was brought in an ambulance with oxygen or 5 liters of oxygen. Still, his saturation was 85%. We increased his oxygen with NRBM later, which we had to increase to 15 liters. Started on dexamethasone 6 milligram IV, enoxaparin. He was getting desaturated even with mild exertion, so we had to catheterize, had to get a complete bed rest. These are his X-rays. The left-hand side one is the on admission, and the right-hand side one is 4 days later. You can see how the lung involvement has progressed. And this his monitoring chart. The blue line shows the oxygen supply. This the oxygen 15 liters. And the red one shows the oxygen saturation. Oxygen initially his saturation was around 83%, which improved to 95% and 97%, but then it dropped rapidly in spite of having 15 liters of oxygen. So with that, we gave him tocilizumab. Also, when the oxygen saturation started dropping in spite of having giving 15 liters, the response was not enough, poor, and we had to intubate and ventilate him on 20th. That's the third day of admission. This is chest X-ray showing extensive involvement of both lungs. And then, in spite of all this, he gradually improved. And we were able to extubate him on 27th. He was still oxygen dependent. We transferred him to a medical ward on 31st of August. Urine culture became positive for Candida. He had persistent tachycardia. His echocardiogram was normal, and he did a CTPA because of this persistent tachycardia. And these are the CTPA showed. A filling defect on the right pulmonary artery, and then there are some more filling defects in the branches. So he has several segmental, several pulmonary embolia affecting segments of the right lung. Now he's on enoxaparin and warfarin. We have started him on warfarin 2. We are adjusting the dose of warfarin. He's without oxygen now. We are mobilizing him slowly. He has lost 30 kilos during this period. Now he's 100 kilos of weight, but he's gradually improving. At this juncture, I thought it is worth mentioning something about tocilizumab. This text message I received yesterday. If anyone is looking for tocilizumab, within brackets, last moment injection to recover life, below is the contact received from a friend in pharma. So the details of the contact was given. Unfortunately, an idea had been given to people, and even to some doctors, that it is a magic bullet. It's not so. Of course, it is very useful in some selected cases. But on the other hand, it can make the disease process worse if not used correctly. This is the WHO living guideline recommendation. IL-6 receptor blockers reduce mortality and need for mechanical ventilation based on high certainty of evidence. Low certainty evidence suggests they may also reduce duration of mechanical ventilation and hospitalization. The in-hospital mortality is reduced in the VIII study. However, if it is given to 100 patients for whom it is indicated, 8 to 9 patients who would otherwise die would be saved. But you have to realize that still 27 patients in this group still would die. You cannot save everybody with tocilizumab. However, there's a significant reduction of death rate when it is used correctly. This is a temperature chart of a patient who later died. I was listening to the presentation of the death review by a SHO of that unit. The SHO started saying, when he was presenting, said the patient was given tocilizumab with broad spectrum antibiotic coverage. So obviously patient had high fever. His her procalcitonin was high. In spite of that, patient had been given tocilizumab, maybe because of this idea that it is a magic bullet, and patient went into severe sepsis and died. So it is important to use this important good drug appropriately. Unfortunately, we have been seeing an abuse of this drug due to improper or propaganda given by various people. This 45-year-old diabetic, again admitted a few weeks ago, was hypoxic. He had been on oxygen at home. He is a diabetic with peripheral vascular disease. He had below amputation of one side, and we had to increase his oxygenation to non-rebreathing mask. Then we were alternating his oxygen supply with high flow nasal oxygen and CPAP. We had to ventilate him on 24th. This is how his X-rays progressed. The left-hand one is the on admission X-ray. And then in the ICU, we had many issues. He developed infections, secondary infections, hyperglycemia, hypernatremia. His sodium increased up to 168. We treated him with desopacine nasal spray. It didn't work. Then with advice from the endocrinologist, we changed to oral desmosine, and we started him on low dose vasopressin. Then he started developing ischemia of the good leg too. In spite of all that, we extubated him because his respiratory wise he was improving. And then we noticed that he had developed left-sided hemiparesis and aphasia. And this is the CT scan done, which showed multiple infarctions in the brain. This is another issue we see may not be common, but then attributed to the severity of these patients. Again, we had to intubate this patient because of a lot of secretions. He went into again respiratory distress. But now again, we are planning to intubate him. But then probably we might have to, he might have to have surgical intervention for this because his part of the leg is getting gangrenous. It is important to mention something about the steroids too here. On the basis these how it is recommended on the basis of preliminary report from the recovery trial, the COVID-19 treatment guideline panel recommends using dexamethasone 6 milligram per day for up to 10 days or until hospital discharge, whichever comes first, for the treatment of COVID-19 in hospitalized patients who are mechanically ventilated and in hospitalization patients who require supplemental oxygen but who are not mechanically ventilated. So in hypoxic patients, the indicator is useful. And the panel recommends against using dexamethasone for the treatment of COVID-19 in patients who do not require supplemental oxygen. We see abuse of these steroids. The high death rate we saw in India was attributed by some people to abuse of these steroids. I don't know how much it is contributing in Sri Lanka too for deaths. We see the prescribing of dexamethasone to patients with mild illness, prescribing of very high doses of dexamethasone for patients with severe disease, continuation for steroid for a longer period, longer than recommended. High dose steroids, we know, result in poor blood sugar control, which affects the prognosis of the patient. Patients get hypokalemia, which is a common thing we see, the secondary bacterial infections, second fungal infections. So this steroids again has to be used judiciously. Then we have to talk about remdesivir. If I fail in my duty if I don't talk about this. The NIH guideline recommends use of remdesivir and dexamethasone in patients who require supplementary oxygen. However, the WHO therapeutic guideline does not recommend use of remdesivir. In fact, it recommends against using remdesivir because of lack of evidence. If you go through the evidence for remdesivir, which I'm not going to highlight here, you will realize that the evidence are very, very minimal. It is not cost effective using remdesivir, in my opinion. Another drug which was promoted, not for severe cases, is the antibody cocktail of tezepelumab and imdesivimab, which is popularly known as Veganco, which was given to apparently given to Trump. Now the studies show that it is effective if it is given to 100 patients. Sorry, there's a missing letter. 3 medical visits can be prevented if it is given to 100 patients. The one dose is around 100,000. So for 100 patients, we will need 100,000 into 100, and we can prevent 3 medical visits. So how cost effective that has to be considered. This is for patients who are non-severe. So we face issues like the lung inflammation, thrombosis of pulmonary vasculature, thrombosis in other vessels, secondary infections, bacterial, fungal, and then bleeding. And some of these could be iatrogenic also, bleeding, so hyperglycemia, worsening on new secondary infections, electrolyte imbalance, and some of these could be due to drugs or treatment we give, especially steroids. But we have some weapons to fight this. Yeah, oxygen probably that's the best weapon, I believe, to fight this. Yeah, we can use give it using nasal high flow, use prone ventilation, and then of course we have to use steroids correctly, anticoagulation, IL-6 inhibitors again correctly, antibiotic, monoclonal antibodies, remdesivir, ivermectin. Those are, I put questions, and I have already mentioned about these. So out of these, I believe it is very important to detect hypoxia early. If we treat these patients early with oxygen, correctly with oxygen, whenever necessary using non-invasive ventilation, we can reduce the mortality and morbidity too. So for this, it is important to have a place where we can observe people. I don't believe in using CCTVs. I don't think we can use CCTVs in monitoring these patients. The parameters, especially the respiratory rate, we have in our hospital, we have wards like this, open wards like this. This, of course, we were talking to some of these patients. So we can easily observe these patients, monitor these patients. When we go in, of course, we wear full PPE, but outside the wall, we just wear a face mask because we know that it won't spread otherwise. So then I think it is important to have timely tracheostomy. Again, getting a tracheostomy can be difficult. So in our hospital, we started using a percutaneous tracheostomy. This is on the right, on the left corner is me who is performing the percutaneous tracheostomy, and one of my senior MOs is using a amboscope to guide the tracheostomy. And then we have other things like sedation holds, trying to attempt to early weaning so that we can get them out of the ventilator quickly. And then again, it is important to do frequent cultures to detect bacterial organisms or fungal organisms which infect patients secondarily, which is again a common problem. And of course, the psychological and nutritional support for these patients is important. In spite of this, we have problems. This 57-year-old doctor was transferred from a base hospital on 16th of August with hypoxia. He had symptoms for 15 days, that positive on 3rd of August. Actually, initially he was admitted to our hospital, but he left on his own on the same day. He said he will come back if he has problems. And when he came, he was hypoxic on 15 liters. Saturation was 89%. So we put him on NRBM, and then he gradually improved. His procalcitonin was high, platelet was towards the low side, D-dimer was little high, and chest X-ray showed the progressive stage of COVID pneumonia. And the HRCT showed moderate degree of COVID pneumonia. He had no pulmonary embolism. And we continued him with enoxaparin, dexamethasone, antibiotics. We gave high nasal oxygen using NRBM, then high flow, then deep from time to time. And he improved gradually. Then we were able to take him to 60% of the venturi mass, and then we transferred the patient to a medical ward from the ICU. 2 days later, he was complaining of severe pain down his legs. In fact, he said the pain is so bad, he feels like committing suicide. We immediately got our radiologist who came and did using the portable scan, did a Doppler scan, which he thought is suspicious of DVT. He was anyway on enoxaparin. However, we planned to get a CT scan done next day. Next day morning, we found his urine output was reducing, and we did a CT scan, which did not show any deep vein thrombosis. Instead, the CT scan showed bleeding. He had bleeding into psoas muscle. You can see the size of bleeding, and this is another view. It shows multiple sites of bleeding into psoas muscle and the retroperitoneal muscle. He was getting dyspneic. We took him to the ICU again, and within half an hour, he collapsed. We transfused him with several pints of blood, but unfortunately, he didn't recover. He died. So in spite of all the weapons, we have all these problems. So we need more knowledge. I believe for this, we need documentation of the success with our usual case management, about unusual cases. Then people may be using off-label drugs, but then we need to document those to see the response to those. Then only we would know whether those will be useful or not. Otherwise, after 6 months of using this off-label using of drugs, still we will have the same knowledge and or lack of knowledge. And it is important to share experience about what problems we face, what solution we use. Then only I think we would be able to overcome the problems faced in managing severe cases of COVID. Thank you very much.
Thank you, Dr. Vijay for your excellent clinical lecture. I think it will be very useful for clinicians managing COVID patients right around the country. Now we have, thank you very much again for all three speakers. There are 15 minutes left. That was we are on schedule. So we have 15 minutes left for Q&A session. And we have received a couple of questions. Let me first direct, this question was asked from the director to Professor Ranjit. Can you elaborate more on the current recommendation of vaccination for children in UK? Can you elaborate more on the current recommendation of vaccination for children in UK? Because in Sri Lanka, we are about to start the vaccination for children. I think we are eagerly waiting what experience the UK clinicians and the community had with vaccination on children.
I suppose that's for me, Tilak. Yeah. So now a very, very hotly contested sort of topic in the last few weeks because of the pros and cons given by different people with regards to vaccination of children. The present position is that 16 and 17-year-olds, all 16 and 17-year-olds would have been offered the vaccine. Then initially they offered it to high-risk children. There were about 4 categories of high-risk 12 to 15-year-old children who were offered the vaccine, and that was to be the Pfizer vaccine. A few days ago, 2 or 3 days ago, the government medical officers, that is the chief medical officers, overrode the decision made by the JCVI and said that the children between the age of 12 and 15 would also be offered Pfizer vaccine. They said 1 Pfizer vaccine. That second dose would be put off till next year, the option of second dose. And the parents would be asked to give consent in 12 to 15. However, the child can override the parents' decision if there is a discrepancy. With 16 and 17-year-old, the child's perspective would be taken, because at that time there was the rule that at 16-year-old, if they are competent to give the consent. So that is the current position with regards to child vaccination in the UK, and it's a Pfizer vaccine. Moderna has also been approved, but it's a Pfizer and Moderna. We know that the AstraZeneca is not given to anyone under the age of 40 in the UK.
Okay, thank you, Saranjit. I hope it answered the question of the pediatrician who raised the question. And there's another question. I am sure this is also from Professor Ranjit. Would you recommend a different brand of a vaccine as a booster? I want to add that to that. What is the basis for that? Would you recommend a different brand of a vaccine as a booster? That again is quite relevant to Sri Lanka, because at least for the healthcare workers and the high-risk group, there's a talk that third or the booster is on the way. So would you recommend a different brand?
Yes.
And what is the basis for that?
It depends on, so in the UK, again, the JCVI just put their recommendation out that all over the age of 50 would be offered a third booster dose. About a week or 2 weeks ago, they said that people with immune deficiency, significant immune deficiency, would be given a third dose, and that was to be the Pfizer vaccine. A few days ago, it was all people over the age of 50 to be given the Pfizer vaccine. And the reason, even if they have received 2 AstraZeneca vaccines, or if they have received 2 Pfizer vaccines, the third dose was to be a Pfizer vaccine. And even for the next year, 2022, they have ordered 30 million doses of the Pfizer vaccine to be given, if needed, if that need originates to people as a fourth dose or whatever. So now, why is that? Because there is, we all know that the mRNA vaccines are the best vaccines around. We do know it. And the viral vector vaccines come lower than that, at least at the original studies. And we know that when they did the mix and match studies, we found that people who received 2 AstraZeneca vaccine, the antibody response was lower than those who received the AstraZeneca vaccine followed by a Pfizer vaccine. There were a bit more adverse effects and people had to miss 1 day or 2 days of work. However, the antibody response, at least the antibody response, was definitely better. And that was again confirmed by a publication on this Thursday in the New England Journal, where the group from Sweden again did that, because the problem was that under 60 or 65 in Europe, you would not get the AstraZeneca vaccine. They would not give it. In the UK, it was only 40. And in that group, some healthcare workers had also already received the AstraZeneca vaccine. So there was a group of people who received the Pfizer, and it was up to 115 times higher, about more than 100 times higher immune response, antibody response at least, in people who received the AstraZeneca followed by the Pfizer vaccine, as opposed to AstraZeneca. Now that is a 2-dose vaccine, but the 3rd dose vaccine, the UK government at least, and the JCVI has taken the option of going with the Pfizer vaccine. However, I must preface this because that is very important. It all depends on what resources you have at the time, because if you can't get Pfizer, and if Pfizer has to be given to the cancer patients, etc., then you have to individually, country-wise, decide which vaccine, because we know that for the booster, both AstraZeneca and Pfizer has been approved. So that has to be taken into consideration, because it is not only one consideration about what vaccine you want to use, you have to mix it together with what is available. Because when a booster is needed, it's far better to give the booster with what has been approved rather than waiting for one specific vaccine. And that is an important point that should also come into the equation.
Right. Thank you, Suranjit. I think I have another question from Dr. Jivandar, because the final comment you made is that about the Delta variant and its increased transmissibility. Now, as a clinician or community health point of view, this is my view. I just want your opinion on that. Now, when the virus is highly transmissible, Delta variant, and it is relatively less clinical severity, will that boomerang on its very existence in future? Because now we see many more people are getting infected, and even though the high-risk people are getting complications, but among the children and the young, healthy people, they become seroconverted even without the vaccine. So will that be a detriment for the existence of the virus in future? So the mutation became sort of a boomerang on the virus itself. Is that a hypothesis or it's a plausible?
Well, that's an important point. For example, when the virus spreads within a given community, it increases the chance of mutation, like we saw, especially in the Colombo Municipal Council area, where we saw 3 spike mutations appearing in our Delta variant, and which was alarmed by several international bodies to us also. And probably with these, especially with the high vaccination drives and high infection rates, especially it may spread among the unvaccinated people. Because of the high transmissibility, because of the high, the virus can replicate because of the high transmissibility, there are chances of more adverse mutations appearing, especially in a setting like ours. And on the other hand, as you said, there may be quite a lot of asymptomatic infections among children, which might produce immunity towards COVID-19, especially with Delta variant. So those are the questions unanswered. Probably the future of COVID would be something like that. We will have a situation with mutations, and which will have some stability to the virus, and probably will not kill people as we saw in the past. So a stable virus will remain with us for a longer time.
Right. Thank you, Doctor.
Doctor, there's another question to Dr. Jeevandara. Will there be late complications of vaccine? I think there are quite a few videos going viral in social media on some adverse effects. That might have been the probable root cause for this question. I would like to get your opinion, please.
Well, the COVID-19 vaccination drive is only maximum 1.5 years old. And we have already observed the side effects after administering millions of doses. And, there are certain side effects, so very rare side effects associated with, immediate side effects. But long-term side effects and the side effect profile probably will, even after 1.5 years, we have not heard of, major side effects. So I don't think there will be major side effects on the long run also. So, it's again, we cannot definitely say there will not be any side effect, but there is, everyone is monitoring, especially the post-marketing surveillance are on to understand or detect any any side effects, if any. But in my opinion, it's very unlikely that we'll have a major side effect associated with the vaccines.
Thank you for the reassurance answer. So next question is to Dr. Ananda Vijayvikrama. Now, there is a concern that AstraZeneca is prone to, there is a tendency to cause clotting. So now presume that you are going for a third dose of a person who's had 2 Sinopharm vaccine with the AstraZeneca. There is a question, and they just asked what your opinion on this as well.
Well, actually, I don't know. Because I don't think any country has that experience after 2 Sinopharms giving another AstraZeneca dose, whether that can increase clotting. I don't know whether Suranjit has any details from some other country. What we saw was there was increased incidence of clotting reported in patients, especially with the first dose of AstraZeneca, but that was not shown with the second dose as such. That was especially in the younger population. But if it is given as a booster dose, I don't know whether it can cause the same thing or worse thing or less clotting.
Thank you. I think we haven't taken the decisions as yet on the third dose and which vaccine we are going, if we are going for that. So let me, I think I would like to, since there is absence of further questions, I would like to conclude the session, and I would like to thank all 3 speakers for elaborating on all the important aspects of COVID infection management, prevention, and all the aspects of diagnostics as well. So in addition, I would also like to thank the virtual audience who joined and for their active participation. So on behalf of Galle Medical Association, I would like to thank all the speakers and the audience. Thank you very much.
Thanks.
Thank you, co-chairpersons. Next in line, we have the 4th symposium, Evolution of Dermatology, to touch or not to touch. I take the pleasure of inviting the co-chairpersons of the session, Dr. R.W. Kodikara-Arachchi, Consultant Physician, Teaching Hospital, Karapitiya, and Dr. Binari Vijayanayaka, Consultant Dermatologist, Teaching Hospital, Karapitiya, to the head table.
Yes. Welcome to the symposium on dermatology. The theme is evolution of dermatology, to touch or not to touch. We have 4 eminent speakers for this session. Professor Jayamini Senaratna, consultant dermatologist, Dr. Nayani Madarasinghe, consultant dermatologist, Dr. Chalukya Gunasekara, consultant dermatologist, and Dr. Janaka Akaravita, consultant dermatologist. To introduce the rules, questions will be entertained at the end of all 4 presentations and not at the end of each presentation. Audience, please, your question should be in the Q&A answer box. Please do not answer questions orally or type in the chat box. May I ask Binari to introduce the first speaker, please?
I would like to introduce the first speaker. He is Professor Jayamini Senaviratne, consultant dermatologist. He is working at Lady Ritchie Hospital for Children, Colombo. He will be talking on common sense in dermatology. Over to you, sir.
Good afternoon, ladies and gentlemen. First of all, I thank the President and the Council of the Gaul Medical Association for inviting me to speak in the dermatology symposium. Now, in dermatology, we come across many conditions. As you can see, dermatological conditions can be seen in neonates, infants, children, adults, and elderly. All age groups are involved, and skin diseases are of different pathological conditions. Now, about my topic, I would say common sense in clinical practice is to think rationally and logically all the time, both in the diagnosis and treatment. And we construct the diagnosis step by step. We rely on mostly valuable objective science. And more importantly, you need to identify the pathological process rather than rely on the name of the condition. In dermatology, things are slightly different. We encounter visible signs most of the time, and therefore we don't have to worry about elicitation and interpretation. Many factors determine the appearance of a skin lesion, and I have outlined the important ones. Skin has immense ability to repair the damage. Therefore, we need to focus on this aspect in the management of skin diseases. We often focus on promoting healing. Let me show you a number of common cases. From now onwards, a case series. Now, you can see that the rash is confined to the index finger of the dominant hand. He's a 3-wheeler driver. So in his leisure times, he sort of rotates the key in his index finger, resulting in contact dermatitis to nickel. As you can see, most of the key tags have a nickel ring. So once this is removed, the treatment is with a topical steroid, and he should avoid doing the same thing again. Here is another condition due to the buckle, the belt. Here you see a lot of pigmentation. That is a common thing in brown skin. On long term, it leads to post-inflammatory hypopigmentation, which may not improve immediately with the treatment, and that may need additional treatment like the prolonged use of emollients. Acne is another common problem. Acne also, since face play a vital role in your body image, when adolescents get acne on the face, they often manipulate it, resulting in pigmentation. And the primary problem in acne is the blockage that occurs on the duct of the pilosebaceous unit. The white thing is the block here. The important thing is when you apply topical therapy, it doesn't go down the duct. It has to diffuse through the epidermis to the where the problem is, where the block is. So the important message is most of the topical therapy will require a keratolytic. Some topical therapies like adapalene, which is currently used, do have a little bit of keratolytic activity, but may require an additional treatment. And if the block is fairly low down, yeah, you might need some surgical treatment. So these are a few facts about acne. Pigmentation and scarring are major issues. Not only the acne should disappear, people want to have a clear face. Maybe a degree of fairness also is expected by the patient. Next. In acne, you see the oily skin called seborrhea. You see inflammation, and here you see the scarring. Now, all these needs to be addressed in the treatment. And sometimes when the patient comes, it's the scarring that you see mainly. So this type of patient will not be relieved by topical applications alone. Some form of surgical requirement is needed, like in this young woman, where the macrocomidones were treated mainly with cauterization, targeting the blocked gland. Also, majority of patients with skin disease manipulate their skin lesions. They are upset. Here is a psoriatic patient on biologic, but these lesions persist. This is because during his free time, he breaks the skin lesions, which cauterize to the place. Here is another lady with facial pigmentation. You can appreciate that the pigmentation is more on the right side, and she's very depressed about it as well. The picture on the right hand side show her handedness. She's a right-hander. That's why the pigmentation is more common on the right side. So treatment alone, applications alone won't work here. Now, even patients with leprosy manipulate their skin lesions. Here is a child who keep on demonstrating the anesthesia by pinching the skin. This leads to the formation of the two pigmented nodules. Just to check your ability to observe things. This is actually a child who came with eczema, who was missed. His condition, panhypopituitarism, is a pituitary cataract. Sometimes patients may have serious underlying conditions. This child presented with eczema. This picture that Dr. Akaravita gave me. You can appreciate on the left-hand side pre-treatment, the eyelids are swollen, the complexion is straw-colored compared to the mother, eye opening is difficult. On the right-hand side, after treatment with thyroxine, so she had basically mixed edema. And the eczema will not improve as long as the underlying condition is treated. We come across a lot of autoimmune skin diseases. You cannot just say a disease is autoimmune in origin. You have to demonstrate for certain things like loss of tolerance. And also sometimes in dermatology, we come across conditions where the immune defect is transferred, say for instance, to the baby. The retinal disease is caused by an autoantibody IgG class. It gives rise to neonatal skin diseases. Here is a mother with pemphigus. You can see the blisters in the hard palate, and she gave birth to this baby with pemphigus neonatorum. Now here the antibody is fixed. You don't have to give steroids because its antibody is not generated. therefore symptomatic treatment for the neonate. This is subacute cutaneous LE on the mother with neonatal lupus in the baby. In brown skin, often pigmentary anomalies dominate in neonatal lupus. Similarly, congenital infections can be transmitted by mother to child. Here is a mother's temperature chart and a baby neonate who develop pigmentation and fever. This is congenital chikungunya. Similarly, other organisms that can cross the placenta include Treponema pallidum. The mother had secondary syphilis and the baby got congenital syphilis. So in our country, the VDRL is tested early in the pregnancy. So if the mother develops syphilis later, the neonate can be, the child can be affected. Similarly, in HIV, on the left-hand side is invasive tinea pedis on the child's leg and oral hairy leukoplakia in the mother's tongue, which are sort of, the combination is very diagnostic of AIDS. Patients with AIDS also have a lot of dry skin, cirrhosis. They looked aged apart from many infections. A pruritic papular eruption, pigmented purpuric eruption of HIV is shown here. Let me briefly go through other infections. Molluscum is a commonly occurring condition in childhood, but here if you look at the lesions apart from each other, underlying skin is normal. Whereas in immune deficiency, serious immune deficiencies, you see large number of molluscums, they are large, they are fused with each other. Molluscum in atopic patients, where the barrier is defective, tends to give rise to inflammation around the lesion, what is known as the halo dermatitis. Need to address all these issues when you treat. Coming to herpes simplex infection or also, which is common on this area of the mouth between near the vermilion border. These vesicles are loosely formed, so they break off very quickly. Next, the primary attack is much severe, where there is drooling of saliva and inability to swallow. And the child can inoculate these virus into other areas like the eye. And the most characteristic feature is the occurrence of lesion limited to a certain area, multiple vesicles, called herpetiform appearance. And here the treatment is with oral acyclovir topical therapy mode. From time to time, we see epidemics of the so-called hand-foot-mouth. But in clinical practice, it's more knee, buttock, elbow syndrome than the typical palm and soles involvement. So, this is what I was referring to, the knee, elbow, buttock syndrome than typical hand-foot-mouth disease. And this is a viral infection caused by an enterovirus. During the acute episode, zinc absorption is reduced. If you don't supplement, they lose the nails, as shown here. Pruritic purpuric papular eruption is caused by parvovirus infection, where there is a lot of pain and edema. Coming to bullous impetigo, where the lesions are quite superficial intraepidermal, so it doesn't lead to scarring, and caused by Staph aureus. Staph aureus is known to produce a lot of toxins which can cause serious conditions like the staphylococcal scalded skin syndrome. Here you can see the origin of the infection, the focus of primary infection in the ear where you see pustules. These are sterile because this is mediated by the toxin. Serious conditions occur in neonates, and when it heals, it peels off, leaving the underlying skin without scarring. So that's the Nikolsky sign, which indicates looseness of the upper epidermis, and you can see the pigmented cells beneath. basis of which was described some time ago. You can read this article in the Indian Journal. Coming to mycoplasma infections, often give rise to a number of lesions in the skin and mucous membranes. And the mucous membrane lesion is shown here. Next one. So there can be skin lesions which are not typical of erythema multiforme. So the proper name is mycoplasma-induced rash and mucositis. Coming to typhus, this is the fever pattern that you see in typhus, a biphasic fever pattern, which is usually M type. And the SCI is shown on the right side, but SCI is not commonly seen. But you see is a generalized rash, which depends on the age of the child, and the inoculum of the organism can differ. Sometimes it's purpuric, which is well seen on the palms and soles, or it can be maculopapular, more bumpy rash than erythema as shown on the right side. Regarding leprosy, we are familiar with most of the types of leprosy. Inoculating leprosy is a little understood entity that I am going to show you. Here is an infected grandmother who had inoculated the grandchild during sleep or while they slept. Inoculation of leprosy can also occur around the BCG scar, and since the incubation period is quite long, the lesion develops in late childhood. Regarding lepromatous leprosy, you are familiar with the nodular types of lepromatous leprosy, but there are types which are non-nodular as shown here, where there is diffuse infiltration of the entire ear, whereas in relapsing polychondritis, only the cartilaginous areas are affected. Again, inoculating leprosy, this is a beautician. She inoculated the organism here, and when she rubs, it got inoculated here. So these are forms of leprosy that we often don't recognize as inoculate. The main important thing about leprosy is the sensory impairment, and the damage to the autonomic nerves result in loss of hair. It's a very good sign, and that's a fairly long-lasting lesion. The nerve damage, the lag of thalamus is demonstrated here. You can also observe the diffuse erythema and sparsity of the eyebrows. So the clinical diagnosis is macular anesthetic, borderline tuberculoid leprosy with lag of thalamus. And sometimes it can lead to bilateral facial palsy. Pure neural leprosy, where the skin lesion is not visible. This child came with a reaction, and you can appreciate that it's on the posterior auricular nerve, whereas commonly encountered nerve in neural leprosy is the great auricular nerve. And coming to atypical mycobacterial infection, sometimes cause dissemination and vasculitic type, resulting in necrosis of digits like this child, where the treatment is lifelong ciprofloxacin and clarithromycin. So the take-home message about leprosy is suspect leprosy in long-standing skin lesions which are either symptomatic with altered sensory sensation. Skin lesions occurring on known leprous contacts. Skin lesions along with neural symptoms, especially peripheral nerve damage. Patients who live in endemic areas, and when other diseases have been excluded. Infestations. The larva migrans, cutaneous larva migrans, you see a migratory thread-like lesion which moves in the skin. They can't penetrate the basement membrane, and the treatment is with albendazole. Different clinical types that we encounter in this country. Most of the lesions are secondary infected, as you can see on the left-hand side, or you can develop an urticarial rash, as you can see on the right-hand side. The ulcerative type is shown on the right-hand side, where almost cellulitis has occurred, whereas in lava currents, the organism moves very fast. Visceral lava migrants occur in the deeper layers, is caused by Toxocara. So a contact history with a dog or a cat is important, often with puppies. And there's a severe eosinophilic reaction, as you can see in the histology. And the larvae doesn't respond to typical medication of albendazole. Coming to scabies, you are familiar with the common types. The crusted scabies occur in certain individuals with immune defects, like T cell defects in trisomy 21 or HIV. This is the nodular type of Norwegian scabies or crusted scabies. This is the diffuse type. There are millions of organisms here, and the treatment of choice is ivermectin. That's the scudula or eggs. When you scrape, you can see the eggs of the mite, or sometimes you see a live mite. Just touching psoriasis, the different types. In gutted psoriasis, the lesions are very tiny, and you need to induce a scale by scraping. Whereas small plaques and large plaques are easy to differentiate. Diffuse types. In this child, you can observe that the limbs are spared. So natural UV light has a very good role, and therefore that the patient will respond very well to PUA. Dactylitis is often not recognized in psoriasis. You can see that the entire digit is swollen, and you can appreciate the onycholysis and pitting on the affected nail. In children, any part of the body can be affected. Scalp, which is best treated with coconut oil compound applied in the night, washed off with a simple shampoo like 2% cetrimide. Next. Whereas flexural psoriasis is little inflammatory and needs a mild topical steroid like hydrocortisone clavulanol combination. In childhood psoriasis, especially napkin psoriasis, there is invariably a degree of streptococcal infection of the perineum. So anti-streptococcal oral treatment is mandatory. Now this child presented with psoriasis, which is purple in color. You can appreciate the color of the lesions on the neck. The clue to the diagnosis is on the lip, which is cyanosed. So the skin lesions color will be determined by the perfused blood. So if somebody has cyanosis, the skin lesions will also be purple, at least in this child. Whereas pustular psoriasis is an emergency where there is widespread erythema, swelling, and pustules, which fuse to form lakes of pustules, leave a background of hyperpigmentation or a brownish color. It gives a very, the number of signs tell you the diagnosis immediately. So if you have to wait for a biopsy, the patient will be in a critical condition. Treatment is urgent. The drug of choice for majority is acitretin. Thank you.
Thank you, sir, for that interesting presentation and sharing your experience with us. Then we will go into second speaker. The second speaker is Dr. Nayani Madarasinghe. She is the consultant dermatologist, National Institute of Infectious Diseases, Colombo. She will be talking on dermatophytosis, a new challenge to dermatologists. Over to you, Nayani.
First of all, I would like to thank the organizing committee for inviting me to do this lecture today. I will now share the screen. I would be talking to you on a new challenge to dermatologists, that is dermatophytosis. Dermatophytosis, or which is commonly known as tinea infection, is a disease of the stratum corneum of the skin, and it can also affect the nail and hair. It is caused by a keratophilic fungi, which is known as dermatophytes. The clinical features may vary depending on the site that is involved, and depending on the site, there are different names given to the disease. The typical clinical feature consisted of round erythematous plaque with central clearing and active border. This active border consists of scaling, erythema, papules, and sometimes pustules. Tinea cruris, that is tinea infection in groin. Tinea barbae, which is occurring in beard area. This presents at scaling and follicular-centric pustules, and this hair will be easily plaquable. Tinea faciae is tinea infection occurring in unbearded parts of the face. This usually have an atypical presentation, and sometimes this can be misdiagnosed as other skin diseases as well. Tinea pedis will have different clinical presentations with whitish curd-like material in between toes and hyperkeratosis with scaling on the soles and vesicobulous skin lesions. Tinea manum usually affects one hand with erythema, scaling, and dryness. This may be an extension of the tinea pedis. Tinea capitis is commonly seen in children. They usually come with patches of non-scarring alopecia, and there will be scaling in the underlying scalp, and also the cervical lymph nodes may be enlarged. Inflammatory tinea capitis is also known as chirion, and this is caused by a zoophilic dermatophyte species. And the presentation of inflammatory tinea capitis is somewhat different. It presents as an inflamed boggy mass resembling an abscess, and this is commonly mistaken as an abscess, and often incisional and drainage is performed. The early diagnosis of this is important because this can give rise to scarring alopecia. So early intervention with oral antifungal agents are important to prevent the scarring alopecia. The diagnosis of dermatophyte infection is fairly easy. It is usually a clinical diagnosis, and sometimes it is aided by skin scrapings for fungal microscopy. Actually, dermatophytosis used to be an easily treatable disease, and maybe a few years back, I would even not think of doing dermatophytosis as a separate lecture to a forum like this. But times have changed, and so is dermatophyte infection. Recently, dermatologists are observing increasing incidence of dermatophyte infections, which is rapidly spreading in the household with extensive disease and atypical presentations. And most alarmingly and most disturbingly, there's an inadequate therapeutic response to commonly used oral antifungal agents, which gives rise to chronic and recalcitrant disease and recurrences. This trend has been first reported in India, and we too are following the same. To objectively assess this, we did an island-wide multi-center study with representations from all 9 provinces, and it showed that lesions were present in for more than 6 months in 23.9%. That indicates actually chronic disease. And multiple sites were involved in 65.9%, and atypical sites such as the facial involvement was seen in 20.7%. In another online survey consisting of 50 dermatologists, 88% of them believed that there's a lack of therapeutic response to commonly used antifungal agents. So this problem of low therapeutic response, that is the therapeutic failure of dermatophytosis for the commonly used oral antifungals, we may not be seeing the actual picture, but just the tip of the iceberg. What could be the causes for this therapeutic failure? It is multifactorial with host, fungi, environmental, and drugs having a role. Environmental related factors such as hot to humid temperature and overcrowding may contribute to this, with favoring favorable conditions for the fungi to proliferate and harbor. And then we have the drug-related factors. Actually, this is one of the important factors because there are many drug-related factors which will be contributing to the therapeutic failure. One such thing is resistance. Both primary and secondary resistance for oral antifungals is reported. And then the other important thing could be that although we think that there's a therapeutic, low therapeutic response, we may not be giving the proper drug in proper doses and duration. And then the quality of the drugs is also important when there are different brands of oral antifungals. And then the drug interactions. Because these oral antifungal agents are known to have drug interactions with commonly used other drugs, it may not be achieving the desired therapeutic concentration. And then the other most important thing is the poor compliance. So we have to make it a note that we should advise our patients that they should continue the oral antifungals or the therapy that we give for the desired duration, because patients tend to stop this when they achieve the symptomatic control. And the cost of these drugs may be having an important part, because sometimes the oral antifungals are not available in the government sector, and then when we give it from the private sector, the cost is sometimes unbearable. So this may also lead to poor compliance. Resistance to azoles and terbinafine is both reported from India. Actually, we don't know the status in our country, but we are doing an antifungal sensitivity studies at the moment. Talking about the preferred oral antifungal drug, this was another online survey conducted on general practitioners, and it was shown that fluconazole was the most preferred oral antifungal agent, both in the private sector and in the government sector. And if it consider the best antifungal agent would not be fluconazole, and I would be dealing it with later on. Then the quality. The quality of itraconazole will depend on small pellet size, large number of pellets, and minimal variation in pellet size. This study, which from India, they have looked at the pellet size by a dermatoscope, and you can see the variation in pellet size. And also the uniform white colored pellets are found to be dummy pellets. So actually we can imagine the quality of the drug. Then the fungi related factors, that is the next important factor. It could be actually that the fungi is getting resistance to the oral antifungal agents. Or it could be that we are having a change in the predominant fungal species. Our previous studies showed that the predominant fungal species causing dermatophyte infection is Trichophyton mentogrophytes. Actually, a decade ago, this was Trichophyton rubrum, and now it has changed with Trichophyton mentogrophytes predominating. The same trend has been reported in India. So Trichophyton mentogrophytes is known to cause more virulent disease. So this may be largely contributing for the lack of therapeutic response that we see today. And this was further proved from our study, which showed the partial clearance percentage was significantly higher in Trichophyton mentogrophytes when compared to Trichophyton rubrum. And also the recurrences after complete response was significantly higher in Trichophyton mentogrophytes when compared to Trichophyton rubrum. Then the host-related factors, like we have to advise the patients regarding these actually to get a good therapeutic outcome, like proper personal hygiene and the change of fashion sense. Actually, the younger generation are more in favor of these tight-fitting clothes and nylon underwear, so we have to advise them regarding this. And also the other important factor is if there are more than one family member affected, they should all take the treatment together. And then the immunosuppression. So as you know, the percentage of the people with immunosuppression is increasing with large number of patients with diabetes, renal transplantations, and then the patients undergoing chemotherapy. These patients may harbor in the infection for longer periods of time, giving rise to spread within their household. Then one of the most important factors in this lack of therapeutic response in dermatophytosis is the topical usage of steroids, which causes a local reduction of immunosuppression. Use of topical steroids will alter the clinical presentation, reduce inflammation and scaling. Therefore, even if they come to a dermatologist, it's very difficult to obtain skin scaling for a diagnosis. And also it causes ineffective fungal clearance, because of the low reduced cell-mediated immunity which is happening in the local area due to the topical steroid. And this will give rise to chronic persistent disease and also need further longer durations of oral antifungal agents. So these are some instances where topical steroids have been used to for dermatophytosis. You can see that this is known as ring within ring appearance, also known as tinea pseudoimbricata. And here a potent topical steroid has been used on the face. The margins are indistinct and there's less inflammation. And in the hands, you can even see the steroid-induced hypopigmentation. In our study also, we were able to see that the partial clearance rate was significantly higher in the patients who, in the group that had received a topical steroid before presenting to the dermatology clinics than the group that had not received any topical steroids. And also the recurrences were significantly higher in the group that had received the topical steroids. So although the facts of using topical steroids are like that, which causes a big damage to the dermatophyte infection, it was noted that 63.2% of the patients had received some kind of a topical steroid before presenting to the dermatology clinics. Actually, this study was done before the time the COVID pandemic hit us, so the percentage may be even more now. And unfortunately, it was seen that most of the topical steroid prescriptions were either from the hospital outpatients department or by the general practitioners. And I think this is a failure of all medical professionals. We as dermatologists have not taken an active role in imparting knowledge, and the general practitioners or the medical officers are also engaged in a wrong clinical practice by giving topical steroids for dermatophyte infections. Now we are coming to the most important part of this talk. Can we overcome this problem of low therapeutic response? Yes, we can. If we all act responsibly and act together, we can overcome this problem. Method number one is not to use steroids. So usage of topical steroids at any stage of dermatophyte infection is a big no. So if you take that message from this lecture, that is also a big achievement. Sometimes topical steroids are used to reduce the inflammation and for symptomatic control in the initial stage of this infection, but that practice is also now not encouraged. And the most common indication is when the diagnosis is not clear, people tend to give a topical steroid or a combination cream. This practice is strongly discouraged because for the above reasons that I mentioned earlier. If you're not sure about the diagnosis, just give some oral antihistamines, which will achieve some symptomatic control, get down the patient again, and then you will get a proper idea. Then method number two is proper management. Proper management of dermatophyte infection is important, and topical antifungals are indicated when there's a single or one small lesion, and these could be continued 2 weeks post-resolution. And it has to be applied 2 centimeters beyond the active margin. There are a range of topical antifungals in the market, and actually it is according to the prescriber's preference, and it is better to combine the topical antifungal and the oral antifungal from 2 different classes. Then you have the systemic antifungals. Itraconazole and terbinafine are the preferred oral antifungal agents in dermatophyte infections, and glucofulvin also can be used because that is the widely available drug in the government sector. Then what about fluconazole? Although commonly practiced, this is not usually considered as effective in the management of dermatophytes. And also it has shown, like there are few studies which have shown efficacy with the 50 milligram daily dose, but not the 150 milligram weekly dose that is commonly practiced. And then the other fear is that the common usage of the fluconazole may cause resistant strains of candidiasis developing. Therefore, please keep your fluconazole for candida infections and not for dermatophytes. the dose and the duration. This is also very important because giving inadequate doses and for inadequate durations may give rise to resistance, survival of the resistant strains. And also that will clear the skin lesions partially, giving rise to spread within the household and then like later recurrences. The dose of terbinafine is 250 milligrams daily, and itraconazole is 200 milligrams daily, like it is given in usually a twice-a-day dose, and per kg dose is also there. The duration of the oral antifungal will actually depend on the site, but the minimum duration should be 2 to 4 weeks, and now we see actually even longer durations of oral antifungal agents are needed to achieve a complete clearance. And if the patients have used the topical steroids earlier, then the need for the oral antifungal agents the duration will become even longer. Tina incognito is when they have used a topical steroid earlier. These oral antifungal agents, we have to use them very carefully because at the moment we have a problem of overuse of steroids in dermatophyte infections. But in India, they have another problem, that is the misuse of azoles. Azole group oral antifungals, which can be used for longer durations, like shorter durations, and like not proper dosages, and like giving intermittent doses, may give rise to a problem like of drug resistance. So this could be our future. Therefore, we have to be very careful in using the oral antifungals with proper dosages and for the proper duration. If there's inability to follow up, it's always better to refer because we have only limited drug choices. So it's not like antibiotics. When it comes to oral antifungals, we have only very limited number. So please be careful when you are prescribing oral antifungals to do the right thing, because then at the end, if not, we will not have anything much to offer to our patients. Then the method number 3 is timely referral. So as I mentioned earlier, if the diagnosis is not sure, or if you are not able to follow up the patient fully, then it's better to refer to a specialized center. And also things like extensive tinea corporis, recalcitrant and chronic disease, and patients with other comorbidities are better followed up at specialized centers. So if we do all these things, and if we all act responsibly, and we might be able to overcome the problem of this low therapeutic response of dermatophytosis before it becomes a major public health issue in the country. Thank you.
Thank you, Nayani, for your interesting speech. Because this tinea infection is very challenging in these days to treating by dermatologists, not only the dermatologists, by others. Thank you very much.
Let me introduce the next speaker, Dr. Chalukya Gunasekara, consultant dermatologist, National Hospital of Sri Lanka. She'll be talking to us on dermatology beyond borders to achieve perfect skin. Chalukya, over to you.
Good afternoon. First, I'd like to thank the President and the Council of the Gall Medical Association for allowing me the opportunity to talk to you today. So, in the past, a dermatologist was expected to treat either cure or control skin diseases within the borders of the disease and not give much attention to what happens afterwards or the sequelae and aftermath of a skin disease. So in my talk, I would like to justify the evolution of cosmetic dermatology. I will touch upon skin aging and preservation of the skin. I know people of my age group would be particularly interested in this part, and also present you with the armamentarium of options that are available in cosmetic dermatology. So, if you look at a cross-section of dermatological conditions that dermatologists would deal with on a day-to-day basis, you would all agree that what is common about all these are the fact that there is a tremendous cosmetic impact on the patient, especially when it's on the face. Now, if I were to cross off the conditions which would be referred to as trivial or just purely cosmetic, you would agree that still the devastating impact on the skin is equal irrespective of the underlying cause. This has been proven again and again with studies on quality of life index in patients with skin diseases, both in adults and among children, where the quality of life index is equal to even severe underlying internal diseases such as renal disease and even diabetes. So there has developed a need for dermatology dealing with this aspect, and in the West, within the past 3 decades, this has developed tremendously, and we can also witness this in our own backyard, as shown by these studies over the past 20 years of clinic attendance patterns, where we see patterns of behavior seeking treatment for what were previously called pure cosmetic indications. Therefore, cosmetic dermatology is the maintenance of a normal appearance of the skin, restoring it or enhancing it. And similarly, on a day-to-day basis, cosmetics are items that are applied on the skin to improve the appearance of the skin or enhance the appearance of the skin. And cosmetics can play a vital role on a day-to-day basis in transforming a person's face from a, you can see a plain girl has been transformed into a beautiful one, and we witness this every day with our beautiful brides. Every bride is equally beautiful with a beautiful complexion due to the usage of cosmetics. Of course, as dermatologists, we do promote camouflaging skin diseases, which can have a tremendous psychological impact and cause social embarrassment, such as vitiligo of the face. Now, at this point, I'd like to introduce this term called cosmeceutical, which is something that sits on the fence between a cosmetic and a drug. In Sri Lanka, in the National Medicine Regulatory Authority, these are referred to as borderline products. These are used both to treat diseases as well as for cosmetic, purely cosmetic indications as well. Now, talking of diseases, sometimes the definition of a disease can become a little blurred, because if you take aging, we know there is time-gated intrinsic or chronological aging, which happens to everybody. There is also the accelerated form of this, which is due to the effects of the sun, or also called extrinsic or photoaging. Photoaging is mediated via the ultraviolet A and B rays of the sun, working through reactive oxygen species, which can produce DNA photoproducts both in epidermal keratinocytes as well as on the underlying dermal collagen. And this can manifest in a variety of ways, starting from pigmentary changes such as hyper or depigmentation, textural changes like wrinkling, which are seen more in fair skinned people, vascular changes such as telangiectasia, then benign lesions like seborrheic keratosis are accelerated with age, and of course dreaded pre-malignant and malignant lesions, even such as malignant melanoma, can be driven by photoaging. Hence, there is a demand for controlling these changes, and interestingly, even our own elderly population are seeking solutions for these problems nowadays. Hence, a dermatologist now needs to move beyond traditional and conventional therapeutic dermatology and embrace this concept of cosmetic dermatology, so that a total or holistic dermatological care can be given to your patient. And this is exemplified by this therapeutic ladder dealing with photoaging, starting with, of course, primary preventive measures. As in any disease, prevention is always better, and then going on to more invasive methods of treating photoaging. So I will start with the most simple form of treatment in cosmetic dermatology, namely cream applications, and these range from sunscreens to skin lightening preparations. Sunscreens, of course, are something that is something that is useful even in primary prevention of aging of the skin. And the better sunscreens will give a broad spectrum of coverage against both ultraviolet A rays and ultraviolet B rays. And the strength of a sunscreen is measured by what is called the sun protection factor, or the SPF value. And the higher the SPF value, the better the protective effect. And any decent sunscreen nowadays is expected to have an SPF value of 30 or more. Sunscreens are made up of two components: inorganic agents like zinc oxide and titanium dioxide, and organic chemicals as well. And the better sunscreens will combine components from both these to give a good ultraviolet coverage. Of course, the usage of sunscreens must be done properly. There are some rules and regulations to follow, or else you will not get the necessary effects. Okay, getting on to some anti-aging cosmeceuticals. Topical retinoids have the most amount of backup studies and data, and retinoids have been around for many, many years, ranging from tretinoin to adapalene. Then we have antioxidant cosmeceuticals. Out of the antioxidant vitamins, vitamin C has the most amount of backup data for usage. But there are lots of other compounds on the pipeline which are gaining momentum nowadays. Then going on to skin lightening preparations. Of course, as dermatologists, we prefer to reserve these preparations for actual hyperpigmentations, either disease due to disease or of even a cosmetic nature. These are some patients who have hyperpigmentation, some patients following collagen vascular diseases, sometimes post-inflammatory hyperpigmentation after any disease can lead to this kind of hyperpigmentation. However, in the Asian subcontinent and also even in Sri Lanka, there is this madness for whitening of the skin, because fairness seems to be equated with beauty by many people. And this has led to the flooding of the market, of course, promoted by social media, of many unsavory and unregistered whitening products. And therefore, as dermatologists, we are faced every day with the repercussions of usage of these whitening products, starting from contact allergies and even burns, going on to hyperpigmentary spots as well as even depigmentations, and also recalcitrant acne, atrophy of the skin, and striae. And we know that these are mediated by the usage of super potent steroids, which are actually prepared by unregistered people. Even in homes, people prepare these and distribute them over social media. And as a college, Sri Lanka College of Dermatologists has brought this to the attention of the authorities. However, because there are some problems with the enactment of the Cosmetic Act of Sri Lanka, no meaningful steps have been taken yet by the authorities to address this issue. So among skin lightening preparations, as dermatologists, we do have a number of products available to us, out of which hydroquinone is the prototype skin lightening chemical. It is a chemical that acts against the tyrosinase, the rate limiting step in the melanogenesis pathway. And its related product arbutin are very useful. However, they need to be used at the correct percentage for the correct period of time, or else you can have complications. Kojic acid and azelaic acid are less powerful chemicals in this area. Then we have the alpha hydroxy acids or fruit acids. These are an interesting group of chemicals because they have multiple actions. They exfoliate the skin. They help to preserve the collagen in the underlying dermis. So they are gaining momentum as very popular products. Now, coming on to glutathione, I'm sure some of you may have heard of this chemical. It is available as topical, oral, as well as IV preparations. However, due to lack of backup data on safety issues, the Sri Lanka College of Dermatologists has given some recommendations to the National Medicine Regulatory Authority regarding the usage of glutathione. Glutathione works by actually driving the pathway of melanogenesis towards a more lighter form of melanin production. We have recommended the dose capping for oral glutathione, and intravenous glutathione is actually not registered in Sri Lanka and not recommended due to lack of backup data. However, and this has been accepted by the NMRA, but sadly, if you do a Google search, you can find so many places offering IV glutathione. Then going on to oral supplements. Of course, needless to say, a healthy diet is the most important part of this. A lot of the antioxidant vitamins do help in preserving the skin. Recently, collagen peptides have gained popularity and are being used more and more. Okay, so going on to the more interventional procedures in cosmetic dermatology, we have a range of procedures available, starting from chemical peels to dermal fillers to lasers. But at this point, I need to point out that embarking on cosmetic dermatology can be like walking in a minefield, because there are so many complications and problems that can crop up, especially because people seeking cosmetic consultations tend to be very demanding. And unless a dermatologist is armed with the knowledge and the experience to deal with these issues, it can be a veritable minefield. So, starting with chemical peeling, the most simple procedure available. This is a controlled destruction of the superficial layers of the skin to the required depth by the application of a chemical agent. And we can do this according to the depth we require, starting from very superficial peels, which just go up to the stratum corneum, going right up to even the mid-dermis, depending on the chemical that is used. Some of the indications are pigmentary conditions such as melasma and freckles, early acne scars can benefit with chemical peeling, and also, of course, improvement of wrinkling can be done with this. And some of the agents that are available to us are, out of these, the most popular ones are alpha hydroxy acids or glycolic acid, the salicylic acids at different percentages, and trichloroacetic acid. Chemical peeling, I have been doing since 2006. And these are some of my patients who have benefited from this procedure. We are very comfortable with this procedure because if you follow proper protocol, you can avoid many of these complications. Otherwise, if not done properly, if the patient is not prepared, there can be disastrous repercussions with even chemical peeling. Going on to subcision, also known referring to subdermal incisional undermining, a very simple procedure, just requires a needle and proper technique and training. The idea is when you're dealing with atrophic skin lesions, you just put the needle in and break the tissues, the fibrous tissues which are binding the skin down. And this is the first study that we did in Sri Lanka way back in 2009, and we have had very good results with this, provided the correct patient is chosen for the procedure, and we are doing these procedures up to now. Microderm abrasion, where it is basically like sandpapering the skin, where an abrasive crystal is used via a handpiece, and the skin is resurfaced, and the indications and complications are very similar to chemical peeling, except that the machine needs to be available for this procedure. Going on to dermal fillers. These are very popular among the West because dermal fillers are particularly useful to fill out hollows and atrophic areas of the skin and even deep wrinkles. The fair-skinned people in the Western world love this procedure because wrinkling is a big problem amongst their skin types. But in our part of the world, there is less of a demand for fillers. There are many fillers ranging from collagen to hyaluronic acid to even your own fat. And the effects can last from a couple of months to even up to 2 years. In our practice, we do use these even for pure dermatological diseases. This is one of my patients who has morphia of the right side of the face, and all she wanted was to just look beautiful and have a more symmetrical face for her wedding, and I think we helped her to achieve this. And of course, if not done, if proper technique is not followed, there can be disastrous complications like swelling, allergy, and even necrosis of the skin. Next, we get on to botulinum toxin, or Botox as it's known, used in many specialties nowadays, including neurology. In dermatology, we tend to use these more for the dynamic wrinkling of the face, which is like the frown wrinkles. When you frown in the upper part of the face, the wrinkles that form on your forehead and around the eyes. There are some other indications for Botox as well. It is a very safe procedure provided it's done properly. Complications are very few, such as facial asymmetry. Of course, the effect lasts only about 6 to 9 months, and therefore this is one of the drawbacks of this procedure because of the very high cost involved. Then going on to platelet-rich plasma usage, we know about the abundance of growth factors present in platelet granules, and it is this quality that is used in many other conditions as well, other than in dermatology. So as dermatologists, we use it to fill out hollows or breakages of the skin, such as in deep acne scars or leg ulcers, and there are many other indications, including morphia. And there are very few contraindications for PRP. Of course, the disadvantages, once again, is the fact that the procedure is costly because it has to be prepared with a special machine. It consumes time and there can be a lot of pain. Pain, of course, can be reduced by using what is called a derma pen. And also, of course, it needs repeated injections. Talking of PRP, it is a very useful option in the patterned alopecias and very popular among dermatologists. Of course, the crowning glory of treating alopecias is hair transplantation. Unfortunately, very few dermatologists have undertaken this procedure because of time constraints. It's very time consuming and needs specialized equipment to harvest the hair. So unfortunately, this has led to many other unregistered people taking up this therapeutic option. Okay, so going on to lasers. This has been the game changer in cosmetic dermatology. Laser stands for light amplification by simulated emission of radiation. There are many laser machines available in the world nowadays, but of course at a very high cost, and every day more and more sophisticated machines are being offered with a very high price tag, of course. And depending on the type of laser media that are used, and depending on the target tissue that you are trying to reach, there are different lasers that can be used. Of course, this is one of the problems when you are doing lasers in cosmetic dermatology. You have to have many lasers for the different indications. And these are some pictures of my patients at National Hospital of Sri Lanka. We have a combined PDL and Nd:YAG laser at National Hospital, and also I'm happy to say that many other hospitals around the country can now offer this facility to their patients. So among lasers, in the vascular lasers, the most popular ones are PDL and Nd:YAG lasers, and some of the indications are mainly the vascular birthmarks. Complications can occur unless proper procedure is followed, you can end up with disastrous burns. So one must know the settings, how to titrate the settings when using this on patients. Pigment lasers are very popular for many of the pigmentary indications, going from freckles to deep dermal nevi. And the most popular ones are the Q-switched ND-YAG lasers. And these are available in many centers of Sri Lanka. So talking of tattoos, our youth are very impulsive and they will go and have a tattoo done. It's very popular among the young generation nowadays. They have a tattoo done without thinking further about it. And I have had many girls who have their boyfriend's names tattooed. And then once they change their boyfriend, they want this tattoo removed. Fortunately, we can offer tattoo laser removal and save their relationship. Right. So then lasers are also useful in taking off unwanted hair, either physiological or pathological. And this is an excellent procedure with minimum or no scarring, and patients are very satisfied with the results provided a good machine is used and at correct settings. One must also remember that laser can have many complications, especially if you don't follow protocol like eye protection. It is very vital to protect the eyes of both the patient and the doctor who is doing it. Otherwise, there can be disastrous complications. Then there are the ablative lasers, ablation of excessive tissues, commonly used for the warts and keratoses, as well as scars. Burn scars can be quite very useful. Carbon dioxide laser is the prototype ablative laser, which goes pretty deep in the skin. Then there are the more superficial, non-ablative, the fractionated lasers, which are used more for skin resurfacing and removal of either acne or other scars. So, ladies and gentlemen, I hope I have been able to convince you that it is time that dermatologists moved beyond conventional borders and try to deliver a near perfect skin to the patients by a combination of the disciplines of therapeutic dermatology, procedural, as well as cosmetic dermatology. And this is emphasized on this slide, where if you wish to do an acne scar revision, because there are different types of acne scars, from superficial to very deep, what are called box scars. So there are non-invasive methods. Then there are the minimally invasive procedures that I have already spoken to you about. And then there are more invasive methods of dealing with these scars. So it is important that the dermatologist is able to use these procedures in an optimum manner, either as a sequential manner or in a combined manner, so that the best results are delivered to your patient. Thank you. And I wish to thank my senior registrars, Dr. Rajivi Abhinayaka and Dr. Kalani Samusinga, whose invaluable help has went a long way in getting this presentation together.
Okay, thank you, Charlie, for that very informative presentation. May I introduce the next speaker, Dr. Janaka Akaravitra, consultant dermatologist, National Hospital of Sri Lanka, Colombo. He'll be talking to us on teledermatology, opportunities and challenges. Over to you, Janaka.
First, let me thank World Medical Association and Dr. Achala Liyanage for giving me this opportunity to talk on teledermatology, different aspects of it. The WHO defines teledermatology as use of communication technologies in healthcare services to exchange medical information for diagnosis, treatment, prevention, research, evaluation, and education over a distance. So that indicates actually even at the moment we are involved in an activity related to telemedicine. So the dermatology especially is a much popular field for telemedicine because we have actually visual techniques we use very much to diagnose patients. So it is much popular in dermatology. There are different models of teledermatology services. It can be primary teledermatology with the GP getting involved between the dermatologist and the patient. Sometimes it can be directly assisted with by the patient. And also there may be tertiary teledermatology, that is where the dermatologist want to get a second opinion from another dermatologist. And also the dermatologist can use the mobile phones or the other apparatuses to deliver certain messages or monitor the patient's reports, etc. That is, we are getting directly connected to the consumer. The data can be delivered in a store and forward method. That is where the patient collects the pictures and collect the reports, and they are forwarded to the clinician, and the clinician will see them and respond. The other method of data transmission is real-time interactive, where the patient and the clinician are directly communicating each other on real time. But actually, commonly what we do is the hybrid form, where we receive the pictures beforehand and then we get connected with the patient. So when we take like in a broader manner, there are so much of advantages or opportunities concerned with teledermatology. Mainly it is cost effectiveness and healthcare savings are sort of important. So it allows remote analysis and monitoring of data, as well as we can store the data. Now, when the patients send the pictures, we can store them. So sometimes they are automatically stored in our mobile phones. So that is that facility also is there, and so it reduces unnecessary or non-urgent visits to the hospital. So that will reduce the burden in the hospital as well as the transportation of the patient. So that will save a lot of money for the patient as well as the health system. And also, in certain situations, this can improve the revenue to the hospital, especially, revenue earning institutions, where the clinicians can be involved in teledermatology, where they are not directly seeing patients. And sometimes it can attract new patients and reduces no-show events, because we are directly connecting to the patient from wherever he is. And in a situation where the clinician opt to practice from home with teledermatology facility, the overhead for the institution, like supplying a room, air conditioning, other healthcare services, so that overhead will be less. So when we look at from the perspective of the patient, so it increases the availability of more specialists to the access of the patient. And when you want to refer to any specialist available in the country, we can do that. They are involved in teledermatology or telemedicine. So regardless of the location of the patient and the clinician. And if the patient is affordable and is aware about the technical aspect of teledermatology, it is very much easier for the patient to reach out with even with a simple question or a new sign developing, or when new symptom developing, and also get health advice with a very easy access to the clinician. Now, in this article published in 2011, teledermatology is compared to a train where you are walking along the train track. So the teledermatology, when the train comes, the dermatologists or the clinicians have to get on board. So most of us will be doing that. But otherwise, you have to completely get out of the way or get run over. So I think it is after about 10 years later. So basically the teledermatology train is coming. So most of us are ready to get on. But before that, we should know about the limitations of this newer technological method of seeing patients. So there are many facets of limitations. There is a significant breakdown in the relationship between clinician and the patient. We know from the moment the patient enters to the room, we gather information about patient. So that part is not there. And we greet the patient and until the patient goes out from the room. And there are certain special clinical clues where we can use the other senses other than the visual sense. So all those are missing with this method of consultation, as well as physical contact is especially important in certain situations, like in psoriasis, vitiligo, where patients are much embarrassed about their physical appearance. So physical touch would be a much relieving event for the patient. And we can't understand the sort of emotional aspect of the patient because we are not seeing the patient in a sort of a real situation. And so patient may be having some other defects which may not detect while we talk with over the phone. So all these facts lead to a situation like the patient as well as the clinician sometimes feel that this is not something really happening. So depersonalization. So it's like watching a movie. So the patient may not feel that really he had a consultation with the clinician. From our point, we may be unable to visualize some areas of skin which may give a good clue for our diagnosis. So if the patient has not photographed and if the patient is not thinking that it is relevant, and so physical examination, palpation, percussion, auscultation, all those things are cut off with this method. So, so with this situation, there is reduced confidence in patients and clinicians about the outcome of the teledermatology consultation. The technological limitations are much more when it is considering like a government sector hospital, so organizational and bureaucratic difficulties. You have to plan the infrastructure, buy the instruments, etc. But and there may be certain regulations by the telecommunication authorities, etc. Also, there may be some issues with how to charge the patient, payment methods, etc. in the private sector. And there may be difficulties in ensuring quality of care delivered through telemedicine, dermatology, and also the implementation of certain healthcare policies. And not only at the constitutional level, actually, individual healthcare workers' knowledge about technology is also important to implement this properly. So some of the clinicians have a fear of technology due to its rapid advances. So those things will be a hindrance for proper involvement. And from the patient point of view, there may be cultural and linguistic differences, and so they may not understand how to handle the communication tools. And so there are no standards agreed yet. And so the quality of images are very much important for us to diagnose about the skin condition. So that is an important point we have to think about when we enroll in teledermatology. Teledermatology is actually not very costly when it is implemented, but initially there may be some involvement of regarding the equipments and human resources are required. And there may be issues of insurance coverage and reimbursement of teledermatology treatment as well as the consultation fees, etc. And we know now actually most of the teledermatology consultations are now carried with the social media and direct phone conversations, etc. But there are teledermatology platforms, so the cost effectiveness is not assessed with that. And there is a big issue in confidentiality, because these photographs sent by the patients will be stored in our phones sometimes. So if somebody can steal them, hack them, so that will be a very very frustrating situation for the patient as well as the clinicians if they leak out. So those are special points we have to consider when we involve in teledermatology practice. And if we are running a remote clinic-like situation where a medical officer is connecting the patient to us, sometimes the clinical staff may feel that they have become just technicians. So it's one issue in that aspect. And the telemedicine market is market-driven, so that also is a concern when we involve in this. And the geographical locations may be exceeded. Sometimes even somebody who is living abroad may connect through the teledermatology route to you. Sometimes that can give rise to certain issues. What about the ethical issues of the clinician? So there are occasions where the clinician have been abused, because the clinicians also may be involved in the teledermatology practice in a single room, and the patient is at home. Sometimes they are not in good attire, and they don't see the professional communication with the clinician. Some people have different desires. They want to chat with the female clinicians, and so many occasions have happened. So that is another issue regarding the ethical aspects. And as we know, there are no defined rules and regulations still. So those have to be formulated when you practice. So whether patients can sue for your incorrect diagnosis, or whether proper diagnosis was not made, etc. And there are concerns about the limitations of fees as well. Now, the other issue is how accurate our diagnosis compared to the physical consultation. So in this study, about 40 pediatric cases were compared. So when they came, photographs were taken and passed to a dermatologist, and for teledermatology consultation, same time, they were subjected to in-office examination by a pediatric dermatologist. So they have compared the two outcomes, and overall diagnostic concordance was 83%. So that's reasonably well concordance, but still about 17% of time there is a difference between the physical examination and the final diagnosis. This the teledermatology will improve when higher quality images were included in their review. In this study, they have assessed the patient satisfaction. Then again, it is at a higher level, 82% when they receive a prescription, but it is not so when a prescription is not given. And to see that, it is interesting, the patients also prefer that teledermatology service to be at low cost. We know we have to spend more time for teledermatology consultation rather than in a physical one, but the patients expect it to be at a lower cost. Now, with the COVID-19 pandemic, we know teledermatology practice improved a lot. Actually, we were compelled to involve in teledermatology consultations worldwide. The teledermatology consultations have gone up about 5 to 10 times compared to the pre-COVID era. So it's an, a very significant trend towards teledermatology practice. This is a study done in India, involving the case analysis occurring towards the latter part of last year. So India has a bit of similar setup to Sri Lanka. So that will give a good idea about the situation. So they were able to arrive at a definitive diagnosis in about 93% of patients, and in-person visits were recommended only for about 2% of the patients. Out of the patient satisfaction, about 18% were very satisfied, and about 43% somewhat satisfied, and about 1/3 partially satisfied, and about only 6% are unsatisfied. So not so bad. So about 88% dermatologists felt comfortable providing teleconsultations, and about 82% of dermatologists thought that they need to continue telederm services in the upcoming months. So these are the disease entities they have seen in their study in about 7,000 patients. And so there were certain barriers for successful teleconsultation, like duplicate entries, incorrect contact details, and connectivity issues, and also technological inability of the patient or the relative to send a proper picture. So those were the main obstacles. From the point of clinicians, the opinions were like they found about 90% found difficulty in assessing the morphology and the topography. And so they wanted higher time per consultation. So it increases about 5 to 10 minutes more compared to a physical consultation. And they found it's difficult to establish a rapport with the patients, and technical or connectivity issues were there in about half of the situations. So those are practical difficulties, and further they highlight need for multiple rounds of communication and inability to perform additional testing. We know we do certain bits, site tests when seeing patients, and also possibility of prescription misuse. So now with this COVID-19, will teledermatology be the silver lining during and after COVID? So in future, so in this study, they have asked about the opinions. But anyway, it is interesting to see that so most of the consultations were done through WhatsApp and the other social media and over the phone consultation rather than separate teledermatology platforms. So about 70% dermatologists found teledermatology to be slightly difficult for making a diagnosis, and 9% did not find any significant difference, and about 4% found teledermatology easier than physical examination. And so common conditions like acne, tinea, alopecia were easier to diagnose, but when it comes to infections, then pigmentary disorders, inflammatory conditions, then it becomes much more less easy or difficult to arrive at a diagnosis. So in future, would you use teledermatology after COVID with the surge of teledermatology practices? 10% would limit physical consultation, and they prefer to use more teledermatology practice, only about 10%. So the vast majority, about 70%, plan to use it in conjunction with physical consultations. And about 15% claimed they will not use it at all. So, it has certain advantages as well as disadvantages. So it is crucial to be well aware of the opportunities as well as the challenges in teledermatology to entertain the maximum benefit of these modern technical advancements for the benefit of the patients as well as the clinicians. Thank you very much for your kind attention.
Thank you very much, Dr. Jana Kakaravita, speaking about the very interesting topic about this teledermatology. With that speech, we are now finished our all 4 lectures. Any questions?
Yeah, I think we have some time for questions. If you have any, please.
Shall I ask one question from Professor Jayamini Seneviratne, sir? About this cluster scabies, have you used ivermectin for the patients in your...
Actually, ivermectin was not available till COVID came around, you know. So I continued to stick. But I think now it's available.
Because these days ivermectin, they are discussing about the COVID, treating the COVID with ivermectin. Then we can use that for our scabies patients also. Thank you. Then with that, we will conclude this dermatology symposium. I would like to thank all the speakers, all the 4 speakers, who shared their experience with us, with the Goal Medical Association. And also I want to thank you, all the members who are joined with the Zoom. Thank you very much.
Thank you.
Now coming towards the conclusion of the 80th annual academic sessions of the Goal Medical Association. Moving on to the award ceremony, it is time to appreciate the professional achievements of the members of the GMA. I cordially invite Postgraduate Coordinator, Dr. Ganaka Senaratne, Consultant Physician, Teaching Hospital, Karapitiya, to announce the postgraduate awards.
Good evening to you all. It's my utmost pleasure to present these winners of Goal Medical Association PG Award 2021. These young life members of Goal Medical Association have succeeded in their respective postgraduate exams during the year 2021. Dr. U.R. Rajit Eranga, Probationary Lecturer in Anatomy and Registrar in Otorhinolaryngology. He has got through the selection examination in MD Surgery. Dr. Dilini Palangasinghe, Registrar in Clinical Nutrition. Selection examination for MD in Clinical Nutrition. Dr. Miyuru Hasanga Manawadu, Registrar in Pediatrics. Diploma in Child Health. Dr. I.L.A.N. Darshana, Lecturer in Community Medicine, who has got through in Master of Philosophy. Ms. Hasanga Ratnayaka, Lecturer in Biochemistry. She has Master of Philosophy. Dr. Pavani G. Punchiheva, Senior Registrar in Endocrinology. She has got through in MD Medicine. Dr. Chitrananda Chandana Dahanayaka, Senior Registrar in Respiratory Medicine, who has got through MD Medicine 2021. Dr. G.D.E. Kodituakku, Senior Registrar in Nephrology, who has got through MD Medicine 2021. Dr. Sunali Devika Nanayakara, Senior Registrar in Critical Care Medicine, MD Medicine. Dr. A.A.E.N. Madhusanka, Senior Registrar in Medicine, who has got through MD Medicine. Dr. Hiran Abesinghe, Senior Registrar in General Medicine, who has got through MD Medicine. Dr. A.D.S. Suranga Sanjeeva, Senior Registrar in Radiology, who is a lecturer in Anatomy, who has got through MD Radiology. Dr. Mudyanselage Chamini Tivandika Jayasundara, Senior Registrar in Microbiology, who has got through in MD Medical Microbiology. Dr. K.D.D.S. Vijayveera, Senior Registrar in Microbiology, who has got through in MD Medical Microbiology. The last winner of the day, Dr. Nirmita Lalindi De Silva, who is our compeer today, and lecturer in parasitology, who has got through MD Parasitology. Gold Medical Association wish all the very best and all the success for our young life members who have succeeded their respective exams during the year 2021 and hope they will do brilliantly in their future career. Thank you very much.
Thank you, sir. Next, I would like to cordially invite the co-editor of Gold Medical Association, Professor Sudhira Jayasinghe, Professor of Pharmacology, Faculty of Medicine, University of Ruhuna, to the podium to announce the winners of the Best Oral Presentation and the Best Poster Presentation of the Academic Sessions 2021.
Thank you, Lalindi. Good afternoon. It is my pleasure to announce the winners of the oral and poster presentations. On behalf of the co-editors, let me thank all the authors for submitting their valuable research to GMA. And also to the reviewers and judges for their contribution and commitment. This time we received a fairly good number of abstracts. Adherent to GMA standards, each abstract were reviewed by 2 independent reviewers. It was a little hard to take a decision or to select the best presentations as the window of the marks were narrow. In line with health guidelines, the winners were not invited for this occasion physically, but the certificates will be awarded at the GMA premises in the near future. Now let me announce the winners. The best oral presentation goes to Darshana ILAN for the paper titled Notified Incident Cases of Dengue and Leptospirosis, Time Series Analysis for 2 commonest vector-borne diseases in Sri Lanka. Authored by Darshana and Shamika RMA. Next, the best poster presentation. It goes to Lianage D for the paper titled Effect of COVID-19 Pandemic Situation on Congenital Hypothyroidism Screening Performances in Faculty of Medicine, Gaul. The paper was authored by Lianage D and Hettiarachchi M. Congratulations you all for your hard work. Thank you. Have a pleasant day.
Thank you, Madam. Before we conclude the session, let me cordially invite the Joint Secretary, Gaul Medical Association, Dr. Varsha D'Souza, Senior Lecturer in Medicine, Faculty of Medicine, University of Ruhuna, to deliver the concluding remarks.
Thank you, Lalindi. Good afternoon to all of you. It is my great pleasure and privilege to deliver the concluding remark at the 80th annual academic session of Gaul Medical Association. Due to the ongoing COVID-19 pandemic, this event was hosted on virtual platform. Therefore, this year's event has changed the history of Gaul Medical Association. The 80th annual academic session was held over the last day and a half, which included numerous symposia and plenary sessions based on our theme, Sustaining Healthcare Amidst Challenges. On behalf of the President and the Executive Committee, I would like to express my gratitude to all the resource persons who shared their knowledge and experience with us amidst their busy schedules to enlighten us on these current topics of interest. I also wish to thank all the chairpersons for sharing their, their valuable contribution to this event to make it a success. And my heartiest gratitude also goes to the researchers for sharing their research work on our platform. An event like this caliber would not be a reality without the untiring efforts of the members of the executive committee. Thank you very much for every one of you. It's been a pleasure being with you all for last 2 days. Thank you very much for joining with us for last 2 days. I hope that our efforts will expand the horizon of the medical fraternity. We have come to the end of the annual academic session, and I wish you all the best and have a nice, pleasant evening. Thank you.